بسم الله الرحمن الرحيم.
اقرأ باسم ربك الذي خلق، خلق الإنسان من علق. اقرأ وربك الأكرم الذي علم بالقلم، علم الإنسان ما لم يعلم. كلا إن الإنسان ليطغى أن رآه استغنى، إن إلى ربك الرجعى. أرأيت الذي ينهى عبدا إذا صلى، أرأيت إن كان على الهدى أو أمر بالتقوى، أرأيت إن كذب وتولى. ألم يعلم بأن الله يرى، كلا لئن لم ينته لنسفعا بالناصية، ناصية كاذبة خاطئة. فليدع ناديه، سندع الزبانية. كلا لا تطعه واسجد واقترب.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, distinguished guests, respected colleagues, and dear friends. It fills my heart with gratitude and pride to welcome you to the first Diabetes Educator Society Conference 2025. Today is more than a gathering. It is a dream realized, a vision come true, a milestone that will be remembered for years to come. Allow me first to extend my warmest welcome to our guests of honor, Dr. Sumaya Libloushi, Director of Nursing at Emirate Health Services and Head of the National Committee for Nursing and Midwifery at UAE Ministry of Health and Prevention, Ms. Yusur Hamad, Director of Nursing at Al Jalila Children's Specialty Hospital, Dubai Health, Dr. Abir Libloushi, Director of Nursing at Dubai Health, Dr. Ilham Al-Amiri, Pediatric Endocrinologist at Sulaiman Al-Habib Hospital in Dubai Healthcare City, Professor Nabil Al-Yatim, Professor and Chairman of the Nursing Department, College of Health Science, University of Sharjah, and last but not least, Dr. Muhammad Al-Hawqani, Secretary General of the National Institute of Health Specialties and Associate Professor at Emirates University, Al Ain. Your presence today adds a great value and meaning to our conference, reminding us of the collective strength and collaboration that have driven our profession forward. To our distinguished guests and partners, and most importantly, to my wonderful team of educators, the heart and the soul of this journey, I extended my heartfelt gratitude and appreciation to all of you. Your presence today means so much to us. It reflects your belief in the power of education, collaboration, and the difference we can make together for every person living with diabetes. I will start my speech by a story of how it all started. A story that holds a special place in my heart and shaped the journey that brought us here today. 3 years ago, specifically in April 2022, a moment in my clinical journey, it changed everything. I had a young patient under my care who was relocating to Abu Dhabi, and I needed to transfer her care to another diabetes educator. What seems like a simple referral became a real struggle. It took me more than 2 weeks to find a diabetes educator to refer the case to her. That experience opened my eyes to a major gap in our system, a lack of connection among diabetes educators across United Arab Emirates. It made me realize how much we need a united platform, a network that could connect all of us together for the benefit of patients and our profession. Inspired by this experience, I reached out to a few educators whom I knew at that time. They were around 7 educators, and I shared the idea with them of forming a club that would bring all of us together. They immediately loved the idea and offered their full support. As the vision started to take place, I turned to 2 colleagues whom I consider a dear friend of mine and an exceptional mentors, Prof. Salah Abu Snana and Dr. Fathiya Al-Awadi. Both of them, from the very first conversation, they believe in it and in us as a team. Their confidence in the vision, calm encouragement, and wisdom gave me the strength to move forward when the dream still felt uncertain. Their guidance became a cornerstone in our journey. They did not just support the initiative, they helped in shaping it. And in the process, they shaped me as a leader. Through their mentorship, I learned that true leadership is built on empathy, humility, and unwavering support. Their words still guide me to this day. If you believe in your purpose, lead it with integrity, and people will follow. Inspired by this faith and supported by those dedicated educators, we founded the Emirates Diabetes Educator Club on exactly 13th of April, 2022. And from the very first day, Dr. Fathiya Al-Awadi stood firmly by our side, supporting our growth under the Emirates and Endocrine Society from 2022 to 2025. Within a week of our formation, the 7 educators became 20. And today, we stand as more than 100 certified diabetes educators across the UAE. Representing nurses, dietitians, researchers, specialists from both public and private sectors. Each of those educators brought something unique to the club: clinical excellence, compassion, creativity, and together we formed the foundation of what would become a national movement. What started as an idea soon became an agreement, a promise among handful passionate educators that we would never work in isolation again. After we officially formulated the club, we created our vision and mission and defined the 3 key feature activities: educate healthcare professionals, patient education, and research. We developed the strategic roadmap from the year 2022 to 2025, outlining our goals and the steps we needed to take to make them reality. Soon after, we began to put this roadmap into action and transforming ideas into initiatives and plan into progress. As you can see here, these moments reflect the spirit of our journey, how each step, each collaboration, and each event brought our vision to life through education, innovation, and compassion. Today, we are one family, having a shared goal, which is to empower, to educate, and to prevent. In April 2025, our hard work and dedication were recognized, and we were officially invited by Dr. Sumaya Al-Blushi to join Emirates Nursing Association as a stand-alone society, a moment that marked a new chapter in our journey, elevating our mission and giving our educators a strong national voice. As we grow, we continued to build structure, credibility, and vision. We launched our website, hosted webinars, endorsed patient initiatives, collaborated with universities, and built bridge with educators around the world. Our community became recognized nationally for its dedication to excellence, specialization, and compassionate care. And today, we stand here to celebrate with you the first Emirates Diabetes Educator Society Conference 2025. This is not just a meeting of professionals. It is a celebration of our identity and our mission. We are here to highlight the vital role of multidisciplinary team in improving outcomes for people living with diabetes, and we are here to share knowledge, to collaborate across disciplines, and to foster innovation in education and care. It is a moment of pride for every educator who has ever stood beside a patient, offered guidance, or changed a life through education and compassion. This conference, held in the honor of World Diabetes Day, is a proof that dreams can grow into movements when driven by faith, teamwork, and passion to serve. Each session you will see in our agenda, from innovation and research to nutrition and multidisciplinary care, reflects very heart of who we are: educators, clinicians, and advocates working together for a healthier future. This is only the beginning. We promise to do more, to collaborate more, to improve more, and to serve better. We will continue to build bridge between patients and healthcare professionals. We will empower both through education and advocacy. We will continue to train, to lead, and to inspire, so every educator feels valid and every patient with diabetes feels empowered. Together, we will shape the future of diabetes education and care in United Arab Emirates. As I stand before you here today, I am filled with gratitude and hope. To my dear educators, you are the pillars of this achievement. To our partners and leaders, thank you for believing in us. To distinguished guests, your presence honors us and inspires us to keep moving forward. Let us continue to educate, to empower, and to prevent for our patients, for our profession, and for our beloved country. Welcome to this historic moment. Welcome to the first Emirates Diabetes Educator Society Conference. Thank you.
Assalamu alaikum and good morning to all. It's our great pleasure to have all of you here in our first Emirates Diabetes Society conference, and it's my great pleasure to be a part of this society as well. So in our first session today, it is our honor and great pleasure to have with us in our first session Mrs. Yusr Hamad. She is the Director of Nursing at Al Jalila Children's Specialty Hospital, Dubai Health. She has an experience of 20 years in nursing across the tertiary hospitals in Jordan, South Saudi, and United Arab Emirates. She holds a bachelor degree of nursing from University of Jordan, a master degree in healthcare administration, and as well quality and patient safety from the Royal College of Surgeons in Ireland. That was in 2018. She holds a master degree as well in pediatric nursing from Hamad bin Rashid University in BRU from United Arab Emirates, Dubai in 2025. Her career span, beside of her nursing in the operating room at Jordan University Hospital, she leads a leadership role in Dr. Sulaiman Al Habib Hospital Group. Then, at the moment, she holds a senior management position since joining to Al Jalila Children's Specialty Hospital, Dubai Health. That was from 2016 till present. She has served as a nursing director for the last 5 years. Please welcome with me Mrs. Yusr Hamad. And it's our great pleasure to have her here as a guest of honor.
Thank you very much for this nice introduction. And it's really a pleasure for me to be with you all here today and this first Diabetic Educator Society Conference. First of all, I want really to thank Zainab for this arrangement and for inviting me to be with you today here. Actually, it's really lovely to see those professionals being all here, just carrying one passion, advancing nursing career and improving the lives of children and their families. And sorry, I will keep saying children's because this is all I do. So I tried in my rehearsal to say patient, but it's coming for me natural children. So we're improving patients and their families. As a director for nursing in one of the leading children's hospitals, I have the privilege to witness the profound impact nurses do every day, not only on the clinical aspect, but also emotionally, educationally, and spiritually. And at the center of this impact, there is one thing, one essential element that we have as a nursing leadership to embrace every day in our practice, this nursing empowerment. So today, I have the privilege to stand in front of you speaking about nursing empowerment. This is a very topic. I will not be able to speak about it in 15 minutes, but I will give you a story that will show how much importance that we are empowering our nurses. Why nursing empowerment is a matter? Why we have to talk about nursing empowerment? Actually, nursing empowerment is more than an idea in the head of the leaders of the nursing. It actually should be the foundation of our nursing professional practices every day. It actually transitions a nurse to only who can do a task to becoming a partner of care, a patient advocate, a decision maker, and a true leader. Healthcare today is rapidly changing, and patient expectation is very high, and the demand also and the needs of the patient becomes very complex. Technology and the treatment continue to improve and advance. Sorry for this. I tried to rehearsal before the morning, but I could not. So we have two dimensions of empowerment. We have the structural empowerment and psychological empowerment. And when we're talking about structural, it's the system, it's the environment, it's everything that we can, as a leader, put in place to make our nurses feel empowered. And will include those elements that I will going to speak about it, but this is not limited to these elements. There is many things can be done as a leadership to empower our nurses. So first of all, we have to give them access for information. Nurses must have the appreciate. Do not link the objective with financial aspect, with the KPI, with the evaluation, and we are going to the end of the year, and we usually have IBB, so we start to link the activities that we were doing with their IBB. It should be connect with the value that the staff appreciate and believe in it. So if we have the structural empowerment and psychological empowerment, nurses can be valued, and they will perform to their full potential. Unfortunately, this is not always coming for natural, and we are facing a lot of challenge to embrace the empowerment for nurses. And those are some of the challenges as a leadership in nursing we're usually facing. Despite, again, all the efforts to flatten the hierarchy, we still having healthcare system with a hierarchical ladder, which not only in nursing, in the whole system. So despite that we say in our system that everybody is equally valued, still we're facing, I'm a doctor, you're a nurse, or I'm a bedside, you're the supervisor. And many incidents where we investigate, we're asking the nurses why you did not escalate, why you didn't speak, or why you didn't do. You will hear a question, an answer like, I'm only the bedside, she was the team leader, she did not inform me or ask me to do. Despite she knew that she has to do something, and she recognized that this patient might need escalation, but still, she will say that I'm the bedside. And those are where the challenge that we really, as a leader, we have to work on it and improve it. Also, leadership is very important in leadership that we support the nurses and include them in all decision-making process. And you can see now all accreditation program, whether it's GCIA or Magnet or Pathway to Excellence, they're talking about shared governance, because this is where we'll let everybody participate in the decision-making process. Limited resources and shortage, sometimes we're focused on the task, not on the inclusion and in the democratic way of doing things. Poor communication, we know, one of the most common challenge in healthcare system is the communication, because we have a lot of like multi-stakeholders, so we have challenge in communication. Cultural resistance to change and restricted autonomy. Sometimes we have, always we're going back to our colleagues, physicians, which we don't have a problem. We have many of the doctors here, they're our colleague and they're our partner in care, but always we have to have the nursing in the table when there is a decision to be made. So I know that it's very short time to give you a picture of what is the importance of nursing empowerment. I will share with you this very short story happened with us from real scenarios that's showing the advantages or the benefit of having the nurses empowered and how this could improve the patient outcome and also empowering families and the patient. So Muhammad, he's 7 weeks child who referred to us as an emergency case from one of the hospitals around us. He was diagnosed with complaining of bradycardia. And when he arrived to the Jalila hospital or to our hospital, we diagnosed him as long QT syndrome, AV block and bradycardia. He was in an emergency situation. We tried to manage him with medicine. Unfortunately, he had a poor response to the medicine. So our team decided that we will do a surgical procedure to have a permanent ventricular pacemaker. Hamad has his procedure, and luckily he was discharged on the 14th after like 2 weeks of staying in the hospital.
Everything about him felt like...
So I will show this video. We consented to share the video with you. And where is the story started? The story started when we started to plan for his discharge. He was ready to go home with the two conditions, that he has an AED and a caregiver who will be able to operate this machine. This is unusual to have an AED, automated external defibrillator, for a patient, and with the parents, they're not medical background, and they will be able to use it. We act. Sorry? 4 minutes. Okay. Yeah. This is really unusual situation, and for the first time, we will discharge a patient to home with this AED. So the team leader, the manager, and the educator came to me and said, this is the situation and we don't know what to do. Family cannot provide the equipment or the home nursing. So I said, okay, what do you think we need? We need the equipment and we need a home health nursing to support the family. I am, as a nursing leader, I have the opportunity to provide the resources and to empower the nurses. So I said, okay, I will give you the AED, but you will be empowered to empower family and give a trial, see if they will be able to learn. And they were said, with hesitant, with not being sure that this is gonna work, they went back to the family and they spoke with the mother, and luckily, she also with the fear, with anxious, she agreed to give a trial. So within the coming 2 weeks, they worked with the mother every day, tailoring a training program for her, simulation, feedback, demonstrating back, until one day she came and she said, I'm ready to go home with AED and being able to perform basic life support until the paramedics will reach to her, for God forbidden, if she is in a situation. And we discharged Muhammad to home with his mother, who's confident to take care of him in case of emergency situation. So empowering nurses, providing them with support, they were able to empower parents and children. And the mother did not only discharge home, she was courageous enough to travel with her son abroad to enjoy their summer vacation. And this is the video.
Everything about him felt like a miracle. His heartbeat, his breaths, his eyes. But the joy didn't last. The heartbeat that first filled me with happiness began to worry the doctors. After a series of tests, the difficult news came. Your baby has long QT syndrome. So I began this new chapter of motherhood. I learned how to perform CPR, how to use an AED, how to monitor his heartbeat and his breath. I was learning how to save my son. Before, I lived in constant fear of what if. But after the training, I had real tools, something I could rely on in an emergency. I had awareness that I could support Mohammed not just emotionally, but practically too. The training gave me confidence, understanding, and readiness. It brought me peace and flexibility in daily life. It didn't take away the pain, but it planted reassurance. I truly have a superhero.
The last pictures from the trip where they enjoyed the summer vacation with the family, and all of us in the room, we know how much difficult for a family to spend 4 months or 6 months in the hospital. This is not only burden for the family, but also both the child and the risk of acquiring hospital infection, which all of us, we don't want to put our kids in this risk. So by empowering the nurses, we we're giving the family the chance to go home with all necessary action and mitigating the risk that they may have. So today, the takeaway message, please, as a leader, as a nurses, as a colleague, take care of each other and feel supported and empower each other for having better health for our children and family. Thank you very much.
Thank you, Ms. Yusr, for your representation. Our second guest of honor for today is, I think he's a well-known professor, Professor Nabil Al-Yatim. He's a professor and chair Department of Nursing, College of Health Science at University of Sharjah, UAE. He's a chair of Nursing Department at the University of Sharjah, and adjunct professor at Charlestown University, Australia. He holds a PhD degree in Children and Adolescents Health of Nursing from the University of Galway, Ireland. He also has an extensive experience in pediatric health research and education as well. And he is an affiliate with Sharjah Institute for Medical and Health Research. His work includes numerous peer-reviewed medical and health researches. His work includes numerous peer-reviewed publications focusing on child and adolescent mental health, pediatric care, and healthcare technology integration. He also serves on the editorial board of leading journals, including Scandinavian Journal of Caring Science and Journal of Pediatric of Nursing. Please welcome with me Professor Nabil, and it's our great pleasure to have you in our first Emirates Diabetes Educators Society conference. You're welcomed.
Assalamu alaikum. And good morning to all. It's a pleasure to be with you here and to present about a very important topic, which is very related to specialization, the core topic of today, the economic power of nursing, which is the problem, and the solution is specialization. So I gave you the answer from the beginning, but now let's speak about the journey. Ms. Yusr made my life a little bit easy when she spoke about empowerment. Empowering nurses, make them empower parents and provide better care, that's for sure. Nurses are excellent. And then the beginning speech from Ms. Zainab also demonstrated persistence, commitment, caring. So the thing that ignited her and started all this great effort was searching for better care for one of her patients. So that's what started the whole journey. That's what nurses are actually doing. They care, they empower, they connect. I will jump to this slide and then I will go back. So they spoke about one of my slides, because this is what nurses do. They care, they listen, they acknowledge emotions, they promote adaptation. They took the mother and the family from one stage to another. Amazing. They didn't have to go to surgery. They didn't have to disrupt their life. They can live their life later. This is amazing. This is what the nurses do. They advocate. They advocated for the family. The family didn't know what options they had. If there was no nurses in the room, if it was all left to the surgeons, our colleagues, probably a surgery would have taken place. True? But because there was nurses in the room who were the different options and who were excellent advocates, the child and their family is leading normal life now, hopefully. So this is what nurses communicating. This is excellent, but this is not enough. This is not enough. But in reality, organization doesn't work only with compassion, doesn't look always for caring. They look for something else. They also care about cost. And that's the painful reality, is that they value nursing, maybe, for sure, but they also want some cost balance. They want to keep the hospital running. Yani. They have to balance between quality and cost. Unfortunately, and if there is leaders in the room, they will know that nursing service in most of the institutions are still considered to be a cost. Cost center, they use these terms, revenue center and cost centers. Nursing service costs them money, that's for sure. Pharmacy bring money because they sell medication for patients and they bring money. Laboratory services are also revenue centers because they do blood tests and that bring money. So what the hospitals usually do, if you go, I went to University Hospital Sharjah in the last maybe 10 years, frequently, they re-innovated the pharmacy area maybe 2-3 times. From smaller area to bigger area to more decoration, beautiful. It's now very beautiful. Dr. Bashair knows. Why? Why? Because it brings them money. Laboratory services also. It brings them money. That's the reality. So we have to prove to the healthcare leaders that, or managers, that nurses bring money to the table. And when we are providing good quality nursing care, people will come back to the hospital and that will bring money. Similar to what our colleagues, doctors, when they are providing excellent medical service, patients will come back and they will bring money with them. That's reality. So nurses has to be aware of that. It's not only about empowering. It's not only about, which is the core. This is the core of nursing. We are good at this already. We want to remain good at this. That remain the core of our work. Every single day is to communicate. Every single day is to teach our patients. Every single day to empower them. Every single day to be there, feel with them. That is important. That's what makes nurses nurses. Otherwise, what's the point of having nurses in the hospital if they don't do that? But also, we have to be mindful that we need to show them that we bring money also and have economic value. And specialization is one of the best way to achieve that. Having Ms. Zainab had a clinic in University Hospital Sharjah. Patients will see her after they see the consultant, right? And that service probably is chargeable. So then now they've maintained that clinic, maybe they will open another clinic. And then people, when they sit with Ms. Zainab and learn how to manage diabetes, they will respect when they know that this is a nurse who is speaking and guiding us. So it brings everything. Specialization brings respect, brings money, and so on. So specialization is an economically valid option. That is important to know, especially from the nursing leaders. When you want to get money, if you are doing a business, does the money start to come immediately or you have to put some money? You have to invest. So for the nurse managers, leaders, hospital administrators, invest in specialization of nurses so that you get money afterward. It will bring back money for sure. So specialization is an economically valid option. Not only that, specialization is now gaining global recognition in nursing. It is, believe it or not, it is now being recognized as a solution to our healthcare system globally. Why? Now to prepare a specialized doctor, how long it will take? It will take 6 years, maybe 5 to 6 years bachelor. and then residency, and then I don't know after that. It will take 10, 12 years to prepare a consultant or a specialized service. But how long does it take to prepare a specialized nurse? Maybe 5 years? So half the period. But why should consultant doctors who spend 10, 12 years doing studies and qualifications has to do with some, maybe 50% of the tasks that is routinely solved by nurses? We can spare that extremely important resource to the hospital, the doctor consultant, by empowering the nursing group to take care of that. And when the nurses need extra support, they can always go back to that consultant. So we are sparing their time for the most complex. That will also save money for the hospitals. It will save time for the patients. It will save time of the consultant and so on. So, and that is supported by global organizations. Like Deloitte is one of the biggest consultancies worldwide who provide consultancy in different areas, among them healthcare. What they've said that the global healthcare industry is facing numerous challenges: rapidly aging population, growing prevalence of chronic illnesses, increasing patient awareness, blah, 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 blah. So what is the solution? They said the solution for these global problems is to empower nursing and open specialized nursing clinics. That's it. If you open specialized nursing clinics in accessible areas, in malls, in the public areas, people can go in, get service, go out. So that one of the solutions that was mentioned. The Triple Impact Report. This is the UK Parliament. UK Parliament, they've formed a group to study persistent problems in the UK health system and propose solutions. Very famous report. It is called Triple Impact Report. Do you know why it was called the Triple Impact Report? Yes, because they came to a conclusion that developing the nursing service will bring triple impact, 3 benefits together. 1, enhancing the health. So improving nursing can significantly boost health globally through better care quality and expanded coverage. Also, you strengthen economies, creating more efficient healthcare system, creating more jobs, and so on. And it will advance gender equality and empower women, since the majority of the people working in nursing are women, so you are empowering women also. So strengthening nursing will bring these 3 benefits together. This is from the UK highest authority. There is the WHO State of the World Nursing Report also that supports specialization in nursing. You can go back and read it. There is the Lancet Commission Report on Nursing 2020. They came and said that the Lancet is well-known, a scientific publisher. They emphasized investment in nursing, education, leadership, and development and research will help in the achievement of sustainable development goals. That's the Lancet Commission report. So nursing is not only economical nursing specialization, not only economically valid option, it is a globally recognized solution for major health problems. And now let's go to the third. Is it supported in terms of research? Does research support specialization as a valid option? Let me tell you about few studies. I have to delete maybe 10, 15 studies because Ms. Zainab and the organizers told me you don't have time. I don't have time. So I have to select the most impactful research studies to show you how can a specialized nursing service solve problems. Let's take about the RN forecast study. Many of you probably have heard about it. This is a huge study. Big study. It included, here, if you look at the methods, there's a pointer here. Yeah. Oops, sorry. Let me go back. Here. If you look at the method section, researcher analyzed comprehensive discharge data of over 422,000, nearly 500,000 patient data from 300 hospitals across 9 European countries. This is a huge study. Huge study. What they came, the findings. I want to jump. The key finding, higher nursing workload. If you burn your nurses, you are increasing the patient mortality rate by 7%. 7 out of 100 patients will die. That's the meaning. That's the meaning of it. It's not, if you say it direct. 7 of 100 may die because of the burnout of the nurses. But the other one, if you improve the education level of nurses, greater proportions of nurses with bachelor degree and higher, what will bring? Will decrease the mortality risk of the same value. So if you educate nurses, make them specialized, you can save 7 patients from death out of whatever percentage. So that is a huge. Yalla, okay, just 1 minute. Please. Yeah. Study overview. That's another study that they've done in the United States. The impact of advanced practice nurses. Okay, what they've said, the finding, key results. States with full practice authority for nurses, yani states that allow nurses to practice to the full extent of their specialty. What they've achieved, their patients has better health outcomes, lower hospitalization rates, and reduced readmission rates. This is a comprehensive literature review. Literature review is a study of the studies. So you take studies and summarize it. They summarized studies that was published over 6 years, hundreds and thousands of studies. What was the main findings? There was main findings related to 4 areas. I will focus on the 2 areas, education and certification. Higher level of nurse educations are correlated with improved patient outcomes. There is 10% increase in university-prepared nurses associated with 7% decrease in mortality. Again, confirming the results of the previous study. If you have certification, if you have specialization, I was talking about this in the morning with Dr. Abir. If you have certification and specialization, reduced medication error, improved quality of care measures, and better, the last one is the most important for me, better recognition of deterioration of health. That is, so you're stopping the problem before it becomes a problem. If you have nurses, and there is another major study in 35 countries. Last one, I promise. 35 countries. What they found, this is for me, not only, this is transformation study. Because they connected it to a country level issues. It says 1% increase in practicing nurses per 1,000. Increasing number of nurses per 1,000 patients, it will affect the GDP. What is the GDP? Growth, domestic production, I think. It means the productivity of the whole country will increase. So nurses not only impacting patients, families, hospitals, their practice can impact the whole country. So that area, we need to highlight it. We need to focus it beside our core functions. Specialization is extremely important for nursing. It brings all this recognition, and one of the most important areas for specialization is in diabetes care. Diabetes care require multidisciplinary team, specialized, communicating properly to care for the patients for the entire of their life. So this is an extremely important example of how specialization in nursing can bring benefits for everybody. And we thank, I know Zainab from a long time, I was watching her leading all this change and proving consciously or unconsciously that specialization in nursing can transform life, can bring money, and can achieve the status of nursing. So thank you very much. And
Thank you very much, Professor Nabil, for your excellent presentation. Actually, I believe in empowering nurses as well in specialization of nursing. And now I'll give this mic to my colleague, Nasreen Al-Dawi. And after all the presentations, after the 2-second presentations, we'll have the question and answers if there is time. Thank you.
Good morning, everyone. After we heard great presentations about the importance of nursing role in changing a patient's life and even their families, it's my pleasure to start the session now that focusing on diabetes care and clinical practice. So our first speaker will be Dr. Tamadur. Dr. Tamadur Ali has an extensive background in diabetes research and education across the UK, USA, and UAE. She will speak today on building excellence, establishing a high-impact diabetes educator clinics. So she is widely respected for her ability to bridging this scientific research with practical to real-world diabetes education. Because of an emergency, we would like to welcome Dr. Tamadur as she will join us as virtual. And after that, I think any questions, maybe if you have any, you can just handle to Ms. Zainab, and she will, of course, take these questions to her. Thank you.
Hello, and welcome to the first Emirates Diabetes Educators Society Conference. I am Dr. Tamadur Ali. I'm the Manager of Diabetes Education at Imperial College London Diabetes and Endocrine Centre and the M42 Outpatient Care Cluster. So unfortunately, I am unable to be there with you in person on such a fantastic meet. However, from my little hometown in Oxford, I hope to spend a nice few minutes with you discussing building excellence and establishing high-impact diabetes education clinics. So thank you all for your attention in advance, and thanks to the organisers for the opportunity. So really, today we're going to talk about building excellence in 3 simple areas: why, and what, and the how. And if we think about the why, really, it's because naturally our global trends and recent data from the IDF Atlas indicate that between 20 and 79 years old, globally, there is a dramatic increase in diabetes, and that is going to continue to be so for 2050. Now, if we just kind of look on this side, in Africa, there is a 142% increase, and in the Middle East and Northern Africa, in the MENA region, there's a 92% increase, the highest in the world. And so, you know, when we're thinking locally, how does this affect us? Well, the trend is the same. It's affecting children and adolescents, pregnancy, impact that is financial, and burden on the healthcare system. So these global trends, are they going to change? No, they're going to increase. And like we said, it is all integrative into our disease burden, health economics, and overall public health. Now, is this a simple or complex matter? And the reason for such potentially a question that seems a little bit abstract is because really we are focusing on the pancreas, right? We are focusing on one organ, on one cell within the pancreatic islets, and they are the pancreatic beta cells. Because within these cells, if you look at them through a microscope, this is a confocal microscope, really we're talking about insulin. And insulin, due to this highly specified specialized cells, already by the nature of its pro-insulin composition, and of course we know about the C-peptide and so on, makes us really think about how complex it is to regulate and the need for the exogenous insulin in eventually advanced type 2 and in type 1 diabetes. And this is a complex matter. It is important to remember the pathophysiology because sometimes even in our clinics when we're trying to explain to our colleagues or to our patients the mechanism of action of a drug, yes, we don't necessarily have to go into this detail, but in building excellence, we're trying to bring the patient as close to understanding so that they can be on board and empowered, and we'll talk about this in a minute. So there is a level of complexity to this naturally, and there are genetic signatures that modulate a lot of this. And these are things we do have to bear in mind when we're seeking excellence. And the idea, or the skill rather, is weaving complex ideas into workable models. Every patient that comes through the clinic brings with them a unique set of concerns and issues that need our attention, and they are personalized, as we will see, and we'll talk about precision medicine. So it's not only important to think about all of this and to know about it, but to actually weave it into a workable model. And so if you spend some time thinking about the what, the what is really, what are we trying to do? We are trying to make an impact and to create change. And things have a knock-on effect, and we're not talking just in our clinics, but on a global scale. And small things do make a big difference. Every little helps. Sometimes it is one light bulb that goes into the patient's goes on the patient's mind, and that could be a door to a lot of their solving their issues that they come with, whether it can be a compliance or it's fear of the technology or anxiety or different lifestyle, improvements and so on. So really, small things make a big difference. Making an impact and creating change is what we are after. And really, being exceptional is what we should be aiming for. And if I can split it into two, so we're talking first about reliability and empowering patients through education and support. This is a continuous transactional force that keeps growing and should get stronger as we build our rapport with our patients. And in training and education, we know that time is a commodity, as with many things. So really, we should sit and assess how we are doing with that. The other thing is personalized support. As we are getting better at spotting out-of-scope services, whether they be specialist clinical services or referrals, clinical psych, safeguarding, and so on, these integrative holistic approaches ensure that our clinics not only talk about glucose, but the whole person as a complete individual. But there are other sides that complement this, things like advocacy, guidance, and data governance, along with quality responsibility. This is really, guidance and advocacy are public health determinants that also indicate our access and frequency of visits and how much we can actually be part of a patient's life. And so is data interpretation and management. So numbers mean nothing without context, and this is where we show patients responsibility and ownership of their own health. We teach them the skills, but also ourselves, peer-to-peer and upwards into key stakeholders and key opinion leaders into how we can make the ecosystem more sustainable on the long term. And I'm not expecting to go through all of the detail of this, but each aspect has different sub categories within it, whether it's delivering hands-on training, troubleshooting, safe practicing, updates on emerging technology, personalized tech solutions, lifestyle and health, analysis of details, analytical tools, self-management, and optimizing treatment plans through collaborations, emotional support, and so on. So there are lots of things that come in together to make our services exceptional. And how do we get there? Well, I think we should all have a toolbox, and these toolboxes are multivariate. So, initially, we really want to think about driving in this clinical application, making the science translational so that it's not so abstract. So it's just not numbers that mean nothing, or graphs that mean nothing, or clinical results that mean nothing to the patient. So this is a skill itself. And identifying the barriers and motivators and reducing bias, for we could be the barriers ourselves. And that's necessary to have this introspection into how this affects our clinics. And the variables are multiple, and we have to assess them individually because they're all part of the same picture. And to be able to judge their breadth and depth and to zoom out eventually and reevaluate before we go back into a particular problem. It's important to remain alert and keep moving and reaching for excellence. And this is where things like unlocking algorithms and AI system capabilities can help us do so. And with that, really, it's not necessarily about what's next, because there's a lot now that is happening that we need to think about. So if you talk about AI, algorithm-driven technology and decision, well, there's both an appeal and need for that. And this is part of building excellence as things progress in our clinics. And that's because there is accessibility to data, precision in making clinical decisions, and support of evidence-based and real-world data or real-world studies to support this. And if we're thinking about the technology specifically, we're talking about CGMs and continuous glucose monitoring, or automated insulin delivery systems, and there are multiple of those. So if we start with the CGMs, for instance, we have a few in the market at the moment, and that is expanding as we go forwards. And I'm just highlighting some that we have at our centers, and they're offer different patients, different opportunities and options, and patient choice is really important in this with clinical decision naturally. And we've all seen these from the consensus in terms of the different recommendations for the time and range. And the idea behind that, again, if we're thinking about excellence, is to have this personalized approach, and having this, patient stratification in terms of risk is really important. Bearing in mind that some of these targets are movable, for example, in pregnancy or in high-risk patients and gestational diabetes, but also we're becoming better at it and more specific to the extent that we are modulating our targets when we exercise, and depending on what kind of exercise. So these reports, again, are very familiar, and our target is to get more of the green and definitely know and learn how to interpret this and translate it to the patient such that when they come back to us, they are within whatever their set target range. And this is patient-facing also. The unique thing about these reports is that they are both ACP and patient-facing. So the patient understanding what their variability is, or their GMI, and how their sensor wear and their lifestyle modifications and medication adherence and appropriate dosing all tie into getting better results for them. If you talk about AIDs, particularly for those with type 1, and as we mentioned, advanced type 2, again, there's a plethora, and that's only increasing, and I've just shared some that we have. And we know that from these reports, we can track the patients, and we say, okay, well, you've moved from 59%, 74% time in range. Here are the changes pre and post to those two moments here. And we can analyze with depth their daily doses, their meals, their carbs, insulin time, active insulin time, and so on. And these algorithms are getting smarter, and the machine learning is such that it's learning from the patient's own data and own habits how we move forwards, which is great in terms of even patient safety and safeguarding. So really, when we have this data, one of the important skills is the interpretation of it. So not to be scared of digging deep and deep diving into the details of the metrics, into understanding how we can make it patient-facing in terms of pitch for these glycemic patterns and variabilities, and to translate that into actionable care plans that are not necessarily overwhelming for the patient either. So, this highly personalized advice comes in from, understanding the algorithmic flowcharts, the responses, and working with progressively complex cases to build that expertise over time. Translating it into education for the patients and behavioral change is also something where we can add to our expertise and excellence. Simple, motivating messages that drive self-management and behavior changes, challenging stigma and misconception, and allowing patients to feel more in control and empowered is important in long-term positive outcomes, not just in achieving, but in maintaining. So, we have room to work on this in our expertise, motivational interviewing techniques, simple transcripts, infographics, and teach-back assessments are all interesting tools to have in our box. And literacy, sometimes, we say, oh, this is too much for this patient, that they don't need to know all these details. But we've had patients, not only who work in clinical or medical fields, who use the technology and can understand all of the jargon if we really have to use it, but there are patients who are actually interested also in knowing what all of these things mean. So, you have to be able to meet the patient where they are. So hands-on familiarity and setups and things like insertion and pairing and basic troubleshooting, I think we're generally okay in. But sometimes, having deeper dives, again, like learner libraries or video-specific modules or competency checklists, practice sessions, these are all important. Because literacy, whether it's technical or clinical, both have, an HCP-facing aspect and a patient-facing aspect, and they all communicate and talk to each other, those systems and those flows of literacy between technical, clinical, HCP, and patients. So in that framework, what are some of the key considerations that we might have as we work towards building this excellence? Well, risk management, safety, and troubleshooting are really essential parts of this. And, if we have an adequacy in preparing for a variety of clinical scenarios, or whether these, handling the devices, technical or connectivity, or so on, these are things that can be sort of directly or easily fixed. Specialized guidance, escalation pathways, and simulated drills are important for understanding the different scenarios that may arise and how we can build our expertise there. But the governance of the data, it's not just the data and translating it, but its governance and quality assurance is something that we think is so far away from our clinic and from our practice. But actually, it's really important because we want to be able to track our outcomes and we want to see if there is a correlation between what we are doing and what we are getting. So, having skills to run QI projects and measure impact, whether it's in TIR or any of the other metrics, hypoglycemic episodes, hospitalization, whatever that may be. And so this is important when we iterate training programs. And so we can have built-in audit cycles, PDSAs, KPIs, and so on, specifically targeting that. The other aspect of that is credentialing and standardizing competency assessment. One of the things we discussed previously was not to have this variety or variability in quality, which comes from an inconsistency in competencies and standards. So it's really important to develop competency frameworks with observable behaviors that are correlational, at least if not causational to, these gaps that we identify. Again, things like OSCEs and simulated patient assessments, fine, but we also need periodic recertification and maintenance of these licenses and upskilling, constant upskilling that is credentialed and aligned in a standardized framework. But, moving a little bit into the things that feed into the technology or into our clinics or in our patient interactions, in our MIs, is also all the the things that patients may bring to our table when we're in clinic. And so what do we do with all of that information? So if we think about what's new in lifestyle modifications and holistic well-being, we begin to think about all the other things that may play a role in our clinics, and being aware of them is part of building that expertise. So personalized medicine and biomarker-based therapies are actually, things that are taking some of the spotlight. Genetic profiling, like we said, the biomarkers. In certain conditions like Alzheimer's, the neuroimaging, they're enabling personalized interventions. And there's lots of new work to show how glucotoxicity in the brain can be modulated and helped by a lot of these devices, our CGMs and our insulin pumps, and how it's not just used for neurodegenerative diseases, but also its presence in diabetes, which can be linked to early onset of these neurological diseases. And it's not exclusive only to that, but they include immunotherapy, gene therapy, and neuroprotective agents. Now, these advances are usually in the experimental phase or initial phase, trial phase, and so it's not like you can order them on from the pharmacy, or the doctor can just prescribe it immediately. But there are considerations for what the future is like, and so building excellence means that we are prepared for what is to come, and this has an overall arching, encompassing feel to it, because it's an integration of medical, lifestyle, genetics, environmental, and so on. The other thing that's a little bit closer to the diabetes realm is stealth stem therapy. And so regenerative and integrative therapies are not new. And the idea of working with stealth therapy, stem cell therapy, is not new. But and microRNAs. So I've spent many years in the labs working with these, and it's very fickle, it's very specific, it's highly specialized, and we've had systems that have worked, and they work better in other conditions than others. For example, in wound healing and tissue regeneration. But sometimes in nerve damage as well. But stem cell therapy for, let's say, combating the issues that we have with islet transplants, it's still in the early stages. And even when you hear of the success stories, they are eventually coming back onto insulin therapeutically after a lag period or an insulin-free time. And this is positive, it's still great, and we should be aware of it. But again, when our patients come in, building excellence is this merging and integration of research, teaching, and learning. And so with that, we shouldn't forget things like Western medicine for sure and functional medicine, but neuropathic, holistic, regenerative, osteopathic. And so there are lots of different types of medicines to try and sort the myth from the truth when the patients come in. So awareness of this is very important. Now, when we talk about physical activity and lifestyle interventions, initially it was diet and lifestyle, diet and physical exercise in lifestyle modification. But then we dug deep into what kind of diet, what kind of exercise. And then we added more things like regenerative sleep, stress management, and minimizing, substance misuse, and improving social connection and mental well-being. So we dug deeper again into what type of exercise. Is it aerobic? Is it anaerobic? Is it in the morning? Is it in the evening? Is it in a fasted state? Is it in a fed state? And the frequency of it, and how does this affect insulin and glucose, and so on. And so again, just making sure that we're adjusting temporary targets if we need, or again, meeting that patient where they are. And neuroticals and herbal medicine for longevity. There's a lot of talk of longevity and different things that feed into that. And traditional herbal medicines are not too far from that. So again, understanding their benefits and so on, but feeding into, because your patients are not just diabetes patients. They could come in with other chronic conditions. They could come in with cancer. They could come in cardiovascular disease, neurodegeneration, and so on. So it's just paying attention to these things. And so interprofessional collaboration and role clarity is really important, whether you're using technology or not, and understanding its impact on public health and access to healthcare is really, really important. So in terms of future directions, I see that, the advances in technology and utility can integrate all of what we use and know into our practice, and predictive analytics can help us within our clinics achieve that excellence in advance, right? And so multimodal clinics and telemedicine and remote monitoring and so on are going to help create an environment when all of this is put together. And so in the future, I see an increase in the integration of the clinical and therapeutic decision making using for sure the technologies, but also these multidisciplinary meets like this conference, and also in clinics as we have the multidisciplinary team clinics. We also, I think that we will see in clinics the more urgent patients that need our face-to-face time, where the others we can review remotely through triaging and coaching and understanding, delegation protocols and outreach and understanding the etiquette of telehealth and platforms that can help our remote and virtual clinics. And so clinical practice really is about bridging the past with what we currently do presently into the future. And so practically, really, the idea is to amalgamate training modalities and implementation. So if you remember our toolbox earlier, it's going to be now full with the tools that we need of all the aspects that we discussed, so that our clinics are ready and we are ready for our patients. And one more thing, let's not forget our basics, that there are models for teaching and learning that are across the board, and there's a lot of research to show that in medical education that's really important. And it started with Edgar Dale in 1900s, where he described that people will remember 10% of what they read, 20% of what they hear, 30% of what they see, 50% of what they see and hear, 70% of what they say and write, and 90% of what they do. So spend some time knowing your learning style, your patient's learning style, and getting into that mindset in the clinic. And later on, Bloom's taxonomy for sure came in by Benjamin Bloom in 1956 and upgraded or updated really by Anderson and Rothwell in 2001. And this is where we're trying to move ourselves from novice to expert. This is the cognitive domain. We're trying to go from lower order thinking to higher order thinking. We're going from just remembering and understanding to analyzing, evaluating, and creating. And this can be easily fixed or addressed with very specialized curriculum design, assessments, and teaching effectively for learning and authorizing basics, and peer teaching and mentorship. And so diabetes education models really are integrative, they're bidirectional, there are core aspects and there are subcategories, there are behavioral things and there are evaluative things, and all these aspects come together in a holistic approach that I'm sure feeds extremely well into how we choose to move forwards towards excellence in Diabetes Educator Club. And thank you very much once again for such a fantastic opportunity. I'm sure it's going to be a fantastic conference, and thank you for all the teams. These are my teams who I would not be here without them, so thank you very much.
First, I would like to thank Dr. Tamadur for her presentation. Actually, I'm so excited for our next speaker, Mrs. Sijoumol. Mrs. Sijoumol is a certified diabetes educator at Al Jalila Children's Specialty Hospital, and her topic will be from classic to curious, spotting the atypical diabetes. Actually, I'm really so excited for her presentation. Let us welcome Ms. Sijoumol.
Good morning, ladies and gentlemen. And thank you so much, Nasrin, for your kind introduction and warm welcome. And it's my honor and privilege to present here in the first Emirates Diabetes Educators Society Conference under Emirates Nursing Association. And thank you so much for the organizing committee for having me here. And today, I'm going to share few uncommon forms of diabetes under the title, From Classic to Curious, Spotting the Atypical Diabetes. Let's begin. Have you all know that Once upon a time, in 1500 BC, according to the ancient Egyptian manuscript, diabetes mellitus was considered as one single disease. The people believed that this disease is due to excessive thirst or urination. A bit later in time, in AD 400, two Indian physicians, Sushruta and Charaga, they have identified two different forms of diabetes, where they found that one form is predominantly seen in young and lean people, and the other one is seen in obese and elderly people. And after some time, the time was going, and in 1936, a British physician, Sir Harold Hemsworth, he formally identified the two different types of diabetes based on a patient's response to insulin therapy. Since then, there were a lot of things were happening in diabetes management. And by the end of 20th century, after discovery of insulin, there is something beyond type 1 and type 2 diabetes. So after that, there is emerging types of diabetes or the other forms of diabetes were identified. However, still, majority of the persons living with diabetes are either classified as type 2 or type 1. And as we all know that both are complex chronic disease and it has heterogeneous in nature. The classification is very important for determining the therapy. When we look into the traditional or the classic type 1 and type 2 diabetes, what we know that type 1 diabetes is mainly seen in young children, and it has high genetic predisposition, and diabetic ketoacidosis is a hallmark of type 1 diabetes, and it is mainly associated with absolute insulin deficiency and beta cell failure, and it has presence of insulin autoantibodies. However, when we look into type 2 diabetes, it is mainly associated with environmental factors, and it is mainly related with insulin resistance, and there is lack of insulin autoantibodies, and there is still preserved beta cell mass. But when we encounter in clinical practice, some of the diagnostic criteria or clinical manifestations are not matching with either type of the disease. So what happens here? Type 1 diabetes may appear with negative antibodies. Type 2 diabetes can admit with diabetic ketoacidosis. So why it happens like this? There is atypical presentation happens. So there is a paradigm shift in the diabetes pattern due to the increased prevalence of obesity. Here, the classic diabetes become the curious ones. Here comes my agenda. I am going to share 4 curious forms of diabetes through some real case scenarios. So let's meet my first case. This is Abdullah. He's a 12-year-old boy, newly diagnosed, admitted with moderate diabetic ketoacidosis. He had ADHD and learning difficulties, and he's an obese child with acanthosis nigricans, and the blood investigations reveals that he has dyslipidemia, and the HbA1c was around 13%, the C-peptide was about 0.37, and his 2 antibodies, which is IA2 and SING antibodies, were positive. And the family history revealed that the mother and the paternal grandparent has the history of type 2 diabetes. And this was his pH, and the admission, it was 7.12, and the bicarb is around 9.1, which shows that he admitted with a moderate decay. And what happens to this child after resolution of diabetic ketoacidosis? As usual, we have started him on multiple daily insulin injection therapy, and we started him on diabetes education and management. In view of his insulin resistance, we have started him on glucophage. So my question here, does he fit into type 1 diabetes criteria or type 2 diabetes criteria? So here you can see that his C-peptide is near to the lower side, and he is having positive antibodies. Plus, he is obese and signs of insulin resistance. So what do you think? Does he type 1 or type 2? So there is something called double diabetes. So what it is that? When someone has the type 1 diabetes along with type 2 diabetes, or I could say that it is an overlapping feature of type 1 and type 2 diabetes. Here, what we see that, what we have to treat here that the autoimmune problem of the type 1 diabetes along with insulin resistance. So what we are facing here, the dual challenge of type 1 and type 2. early identification is very important to prevent the micro and macrovascular complications in this case. And this double diabetes, it's also called as hybrid diabetes or mixed diabetes. And the literature shows that 4% of persons with type 1 diabetes have the potential to have type 2 diabetes. And when we look into the natural history of the progression of type 1 diabetes, what we can see that when a person with genetic risk exposed to the environmental factor, there is trigger of autoimmunity or the presence of insulin autoantibodies. And after that, there is stage 1, stage 2, stage 3, and stage 4. This is according to the latest ISPAT guidelines. And stage 4, this is the long-standing type 1 diabetes. So in all these stages, there is insulin autoantibodies are present, but the symptoms or a person will be clinically having symptoms only in the stage 3. So here you can see that in stage 1, stage 2, stage 3, there will be presence of autoantibodies and the beta cell loss. However, a person will be having hyperglycemia from stage 2 and he will be having symptoms from stage 3. So for a previously healthy person, he will be getting diagnosed only in stage 3. However, an obese person or an obese child can be diagnosed early. Why? Due to the increased insulin demands. So how to diagnose this double diabetes? As I mentioned earlier, it is an overlapping feature of type 1 and type 2 diabetes. So what we have to look for here, the presence of insulin autoantibodies or the autoimmunity, beta cell autoimmunity markers, and the presence of obesity and the signs and symptoms of insulin resistance, which includes acanthosis nigricans, dyslipidemia, or hypertension. How can we manage? Yes, insulin therapy is the cornerstone in the management of double diabetes because they have insulin deficiency and they have the presence of autoimmunity. So we can't skip the insulin therapy. Definitely, they will be managed with insulin therapy, especially we will start with multiple daily injection. Lifestyle therapy, yes, they are obese. So we need to focus on the healthy eating and the importance of physical activity. Along with insulin therapy, we can consider about adding some adjunctive therapies like glucophage and use of SGLT2 inhibitors like empagliflozin, dapagliflozin. However, the important message that we need to educate or empower the patient to check for the ketones because this the SGLT2 inhibitors can cause euglycemic diabetic ketoacidosis. So as an educator, it is very important to mention about the importance of hydration and the presence of frequent ketone monitoring. Then use of GLP-1 analogs. Yes, in this case, we can consider adding semaglutide because semaglutide, it will help in, it is recommended to use in, for the weight management. And also we can use the liraglutide and dulaglutide. And of course, continuous glucose monitoring is the key for the management for all these aspects. So how is Abdullah doing after the first follow-up after the admission? What you can see that he's really doing good, I mean relatively doing good, he's feeling stable and his timing range is around 53%. So by the time, because in our hospital what happens that the antibody result we will get after 1 week of the test. So by the time we already got his all antibody test, and then we have discussed the possibility of other adjunctive therapies to the family. Then the family agreed to start SGLT2 inhibitor along with glucophage. So we advised him to continue on the same insulin therapy, but in fact we have increased his basal insulin. As you can see that his glucose is still high. And then we have added SGLT2 inhibitor along with glucophage. So what happens to him? This is Abdullah doing after 3 months. He's really doing good. And you can see that his glycemia improved significantly. His timing range improved to 99%. And what happens, he has around 4 to 5 kg weight loss. And his total daily dose has decreased around 5 to 6 units. So this is about Abdullah. And moving to the second case, this is Sarah. She's a 4-year-old lovely girl, and who is diagnosed a month ago in another facility, and she came to a follow-up, second opinion in our hospital. And she, on diagnosis, she presented only with osmotic symptoms, and there was no history of diabetic ketoacidosis. and there is no family history of diabetic for this child. And currently, she is on Tresiba 1 unit and 0.5 units of Novorapid along with 3 main meals. And this is her lab investigations, and you can see that her HbA1c is around 7.2%, and her C-peptide is around 0.5. And the important thing, what you can see that all her antibodies were negative. So, this is Sarah's CGM readings. What you can see that she was wearing a Freestyle Libre sensor, and you can look at her profile. The overnight, she was really doing good. Only she was facing issues during the daytime, especially with her meal habits and eating patterns and the timing of bolus. So my question is here, looking at this child's profile, you can see that she's a 4-year-old child, and her HbA1c is around 7.2, and the C-peptide is about 0.5, and she has negative antibodies. So what could be the possible diagnosis for this child? Is she type 1? Does she fit into the type 1 criteria? Or is she type 2? Well, there is something called type 1 diabetes with negative antibodies. Type 1 diabetes with negative antibodies are known as seronegative type 1 diabetes. They are insulin deficient from diagnosis and at high risk of getting diabetic ketoacidosis. And studies shows that 5 to 10% of children diagnosed with type 1 diabetes may be seronegative. So when we are having a suspected child or a person with type 1 diabetes, the important thing that we need to screen for, we need to look for the presence of autoantibodies. And if the autoantibodies are positive, yes, they are confirmed type 1 diabetes, or they have immune-mediated type 1 diabetes. But if the antibodies are negative, consider to look at the C-peptide, and if the C-peptide is detectable, consider to look for the genetic testing or the MODY testing. And if it is positive, yes, diagnosed as MODY. But if it is negative, we need to consider to look for the HLA genotype to exclude the other possibilities. So if the HLA genotype is positive, or if it is present, what happens? They are type 1 diabetes with immune-mediated, but without antibodies. So if they have HLA genotype present, that means they are still type 1 diabetes, but lack of antibodies. So if the C-peptide is raised, yes, they are likely to have type 2 diabetes. So when we look into the diagnosis, it is very important to look at the clinical features. So we have to look for the clinical symptoms like osmotic symptoms like polyphagia, polyuria, polydipsia. Then we need to look for the C-peptide and the presence of autoimmunity. And then consider to do the genetic testing to exclude the MODY and the HLA typing to exclude the immune-mediated type 1 diabetes with negative antibodies. And the list is to look for the differential diagnosis. So when we have someone with negative antibodies, that doesn't mean that they don't have type 1 diabetes. So what are the other possibilities with negative antibodies? There is something called immune-mediated type 1 diabetes with negative antibodies. This is same thing with Sarah for our child with diabetes. So here what happens, she has beta cell destruction. It is due to immune-mediated. However, she is having negative antibodies. So this child, she is insulin deficient from the diagnosis and at high risk of getting diabetic ketoacidosis. So insulin therapy is the cornerstone in the management. When we look into the non-autoimmune type 1 diabetes, formerly it is known as type 1B or idiopathic diabetes. So again, there is a beta cell destruction here. However, this is not due to the immune. So that's why it is classified as it could be like idiopathic reason. However, this child, also those with non-autoimmune type 1 diabetes, they also need insulin therapy because they have complete beta cell destruction. Then we need to look for the other differential diagnosis like monogenic diabetes. Monogenic diabetes is mainly due to the single gene mutation, and it is mainly due to the autosomal dominant in nature. And in some monogenic diabetes like MODY3 and MODY1, we can consider adding the sulfonylureas for these patients. Then the other possibility we have to exclude the differential diagnosis could be ketosis-prone diabetes. Again, when they appear, they present like type 1 diabetes, but later they behave completely like type 2 diabetes. So what is the management for this kind of diabetes? Of course, insulin, because as I mentioned that they're insulin deficient, we need to treat them with multiple daily injections or the insulin pump therapy. And we must teach them about the carb counting and healthy eating. Of course, they need to take the insulin based on the carb counting. And the most important thing is glucose monitoring for all these children. So how is Sarah after 3 months? So we have increased her Tresiba. She's on Tresiba in 2 units, and we have started her with insulin Lemgip. She's around 1 to 2 units with her 3 main meals. So here what you can see that she has improved her glycemia, and her time in range is around 75%, and she is really doing good. Now moving to the third case, this is Ibrahim. He's 14-year-old, newly diagnosed, admitted with mild diabetic ketoacidosis. He's morbidly obese with severe acanthosis nigricans, with elevated liver enzyme and high blood pressure. And the family history revealed that the father has history of type 2 diabetes. And the blood investigation shows that HbA1c is around 13%, C-peptide is 0.9, all antibodies were negative. And on admission, his pH was around 7.2 and bicarb was 14, which shows that he admitted with mild diabetic ketoacidosis. So, does he fit in type 1 or type 2? Okay. Yes. So, this is definitely he's having type 2 diabetes because his C-peptide is in the normal range and he has all the negative antibodies. But what happens here, he admitted with diabetic ketoacidosis. This is an atypical presentation. In my previous slide, I have showed that there is a classic differentiation between type 1 and type 2. But what is this case? I would like to emphasize that there is a difference, that this child is admitted with diabetic ketoacidosis. So, DK is the traditional hallmark of children with type 1 diabetes. And children with type 2 diabetes can present with DK due to the increased prevalence of obesity. And DK and ketosis can occur less frequently in children with type 2 diabetes under certain conditions like stress, infection, or dehydration. So when we look into the key features of the onset of diabetic ketoacidosis in type 2, it could be age, especially in the pubertal children, or in the pubertal children what happens, they will be having insulin resistance. Or the children with obesity, they will be having insulin resistance. So it can cause, it can increase the insulin resistance, and it can cause glucotoxicity, as a result beta cell apoptosis, and it can cause absolute insulin deficiency and relative insulin deficiency, and it can trigger the diabetic ketoacidosis. And the triggers, as I mentioned earlier, it could be acute stress situations, could be infection, dehydration, or something like this. So it is very important to look at the clinical presentation like polyphagia, polyuria, and polydipsia, and of course this child will be presenting with Kussmaul's breath or something like that, the typical presentation of diabetic ketoacidosis. The main important thing is the diagnostic challenge. So here what we have to do that, we have to identify the difference between the type 1 and type 2. So based on the symptoms, our priority is to classify whether the child is on type 1 or type 2 to determine the therapy. So the management, yes, initial DK management, and after resolution of DK management, differentiate between type 1 and type 2. Then of course, long-term management. Long-term management includes the lifestyle management along with pharmacotherapy and regular monitoring. So what happened to our child? So after follow-up, of course, we have discharged him with insulin therapy and glucophage in view of his insulin resistance. And by the time we have received all his antibody panel, all the results, then after 1 week of follow-up, we have suggested all the other medication the possible options of medications like adding SGLT2 inhibitor and use of GLP-1 analogs. And then we have educated about the slowly down titration of insulin, because he is type 2, he doesn't need insulin, but we did not completely stop the insulin immediately. We have advised how to titrate the insulin. So how is Ibrahim doing now? You can see that his profile is improved, and his timing range improved to 99%, and he's completely out of insulin. This is around over a 6-month period of time. and he's only on SGLT2 inhibitor along with glucophage and weekly once GLP injection. And his weight has reduced around 10 kg, and he's really doing good and motivated. Now, moving forward to my last case, this is Kiara. She's a 5-week-old baby, born at 36 weeks, and she presented with hyperglycemia. And on admission, her C-peptide was around 0.9, and her HbA1c was 5.9. And we have started her on insulin therapy around Tresiba 1 unit, and we have placed sensor, and we have sent her lab investigations for genetic testing. And this was her profile. What you can see that her readings were around 54% was in range. And then we have counseled the mother, and we have started the diabetes education, and she was on ongoing therapy. And what happens in the follow-up? This is like after 2 weeks. The mother reported that she stopped all the insulin due to hypoglycemia. And this is the profile. This profile, you can see that 71% in range. This is without insulin. And already we got her, all antibodies were negative, and her C-peptide was in the normal range, and HbA1c is in the normal. So, what could be the possible diagnosis for this child? Type 1? Thank you so much. So this is something called transient neonatal diabetes. So it is a genetic form of neonatal diabetes, occurs in approximately 1 in 100,000 live births. Hyperglycemia during neonatal period, but remits during infancy. And common reported congenital abnormalities are macroglossia and umbilical hernia. The key features are onset. As I mentioned that it occurs in the neonatal period, and it will resolve during the infancy period. And the clinical presentation, usually they will be presenting with low birth weight, and some of the children, they will be having the clinical presentation of macroglossia and the umbilical hernia. Genetic cause, yes, there is a chromosome called 6q24. There is a defect in this 6q24 chromosome. This is the main reason for this transient neonatal diabetes. And as I mentioned, it is transient in nature. And yes, there is a possible relapse during the late period, especially in the adolescence or the late adulthood. So to conclude, double diabetes is an overlapping feature of type 1 and type 2 diabetes. So as I mentioned here, what we have to face the autoimmune part of type 1 diabetes along with insulin resistance of type 2 diabetes. So the challenge is dual. So the early identification is very important to identify prevent the micro and macrovascular complications in this case. A child comes with negative antibodies. That doesn't mean that they are not type 1. Of course, we need to dig deeper and look beyond the classic types. So type 1 diabetes with negative antibodies, yes, they are insulin deficient from diagnosis, and they need insulin therapy. And there is diabetic ketoacidosis. People can be admitted with diabetic ketoacidosis, and it is very important to differentiate the type 1 and type 2, and we need to aim or plan the management based on the right diagnosis. And transient neonatal diabetes, yes, it is. It occurs mainly, it occurs in neonatal period, but it resolves during infancy, and it is mainly due to the chromosome 6q24 defect, and it can possibly relapse during the late childhood. So, ladies and gentlemen, I would like to emphasize, not every diabetes fits the textbook. Stay curious, question the classic, and you will discover the extraordinary. And I just want to say that, be like Dr. Nand always, he says that, look beyond the classic types. You will find the curious one, and the curious ones which can change the lives of the people. Thank you so much.
Thank you. Thank you, Mrs. T. Jamal, for this is really exciting and nice presentation. Actually, because of the time, we will not be able to have questions, but I'm sure that you have a lot of questions for Mrs. Jamal. Please approach her in the break time, and you can ask her all questions you want. Let us welcome our next speaker, Dr. Ilham Al-Amiri. Dr. Ilham Al-Amiri will talk about exploring recent advances about autoimmune type 1 diabetes. Please help me to welcome Dr. Ilham.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good morning, ladies and gentlemen. I'm very delightful to be here among mostly nurses and educators, and I'd like really to tell you thank you for all the great job you are doing for our patients. And without your support, we cannot really achieve a good glycemic control in the patients with diabetes. So thank you, Zainab, for doing this, for bringing people together, and to be a leader in this field. I'm really proud of you and of your team. Thank you so much. So try to stop me because I think I have very long slides, and I was giving, it was submitted to me like a few days back, so I didn't rehearse. So we'll read it together. So my talk today is sponsored by Sanofi. It's about bringing early autoimmune type 1 center stage, and we'll explore recent advances about autoimmune type 1 diabetes. So these are my disclosures, and today we have 3 different objectives. Hopefully I can finish in this short time. And first is we have to learn more and revise the autoimmune pathophysiology of type 1 diabetes and how the disease progresses in order to go to the next objective, which is what is the clinical value of screening and how to identify people at risk of type 1 diabetes. And then when we have this screening done and we have positive patients, how we should provide psychosocial support to patients who have been screened positive. So let me just wake you up and ask you this question. Let's test your knowledge. Which of these Real Madrid players, past and present, has type 1 diabetes? Is it Cristiano Ronaldo? Is it Nacho? Is it Sergio Ramos? Is it Roberto Carlos? The answer is Nacho. Okay, so Nacho has been living with type 1 diabetes since he was 12 years old, and this is a very good example and role model for your patients to show him his picture that he, despite having diabetes at early age, he could fulfill a very challenging dream. So now we're gonna review together what is the autoimmune pathophysiology of autoimmune type 1 diabetes. So we know that the first question of the patients, they will say, why doctor, why my child? Why did this happen? We don't have type 1 diabetes in our family. Usually they are the first patient in the family to present with type 1 diabetes. So the simple way of explanation is that it's not purely genetic. So your child is predisposed to have type 1 diabetes because he's carrying some genes. Many of them we don't know what they are. We have some information like certain HLA genes or non-HLA genes, but still type 1 diabetes pathophysiology is a puzzle, and nobody knows exactly why does it happen to certain people and it doesn't happen to other people. But we know that it should be combined with a second hit, which is the environmental factors, and the leading cause of environmental factors, of course, are the infections, mainly viruses, but there are other studies showing different potential triggers, like, for example, early nutrition, certain gut microbiomes, but still these studies are not very strong conclusion in really what triggers the autoimmunity. So, and this brings us to the second question. So we know that it is an immune-mediated beta cell destruction, but which cell or cytotoxin directly attack and destroy the pancreatic beta cells in your mind? It is A, B, or C. Is it antigen-presenting cells? Is it cytotoxic T cells, or is it interleukin-2? Quickly. So it is cytotoxic T cells, okay? So there is a closer look on the pancreas. Pancreas is full of the islets of Langerhans, and you can see here there is one islet cell has lots of cells inside, mainly insulin-producing beta cells in gray and glucagon-producing alpha cells in green. And you can see that the autoreactive T cells already entered inside the islet cell and started to destroy the beta cells, which become black in color in this diagram. And this damaged beta cell cannot produce enough insulin or no insulin at all. And this will lead to reduction in the insulin secretion and high blood glucose. And as a result of this autoimmune destructions, like any autoimmune disease, what we can find in the blood, we can find markers of this autoimmune destruction process, which are called antibodies. In case of diabetes, it's called islet autoantibodies, or maybe diabetes autoantibodies. So far, we have 4 reliable antibodies that we can detect in patients with type 1 diabetes, whether before or after diagnosis. These are the insulinoma-associated antigen 2, the insulin autoantibody, the anti-GAD antibody, glutamic acid decarboxylase, and the latest one was the zinc transporter 8 antibody. And maybe many of you remember that we had, before we used to check for ICA or islet cell antibody, but they're not recommended anymore because they're not specific. So we are left with these 4 antibodies that are a very powerful tool for screening of type 1 diabetes. So when will these 4 antibodies appear in the body of the individual susceptible to develop type 1 diabetes? So these are based on large cohort studies following populations at risk of type 1 diabetes, and they found that since birth until 2 years, this is between 9 months and 2 years, this is the peak of the seroconversion from negative to positive antibodies. That's early. So if you follow them, you will see that this is the peak time that they will seroconvert to positive antibody compared to later ages. But how long will it take for type 1 diabetes to appear? So the autoimmunity eventually leads to clinical onset of type 1 diabetes, which Ms. Sijo clearly explained about the different stages of type 1 diabetes. So when it's stage 3, that means the clinical type 1 diabetes. So actually the peak here is at 10 to 14 years of age. So many years after the seroconversion, we will have the clinical stage 3 type 1 diabetes. So, but with the following the people, even in adulthood, now we know that there is a second rise also occurring in older age, as you can see clearly in this graph. So this will bring us to the third question. What proportion you think of people are diagnosed with type 1 diabetes in adulthood? Out of all type 1 diabetes population, what percentage are diagnosed in adulthood after age of 20? Is it 21%? Is it 38%? Or is it 62%? So I used to think like you, but I was surprised. It is 62%. So it's very surprising, even for me. This is recent data we have learned that now, this is from the IDF Atlas, because now people are more aware that type 1 diabetes can exist throughout your life, so they started to check for antibodies. They started to really see the patients who are not fitting the type 2 phenotype, and they are checking and they are finding that there are more and more people and adults diagnosed, because adults, of course, more than 20 years, there are larger population. So this also explains why the percentage is more. So of the total new type 1 diagnosis worldwide in 2021 IDF Atlas, it's estimated 62% occurred in people aged 20 years or more. So let's go back now to the story of type 1 before the onset of clinical diabetes. So Sijo made it very easy for me, so I can go very quickly because of the time. So the staging of the type 1 diabetes, actually we can differentiate in 3 distinct stages. You can see here Rosa and Ali, they are living their life carefree. They don't know anything about what's going on in their body. They have 100% beta cell functional mass, but some autoimmune triggers will happen at some stage, and they will start to have 0 to 1 autoantibodies. But it's until the stage 1, which they will have at least 2 or more autoantibodies. So we need to have at least 2 or more to be in stage 1. And at this stage, they will have still, normoglycemia. So they have only antibodies with normal glucose function or test, whatever you will do. So the next stage, I have to go back again. So here for Rosa and Ali, let's see and quantify the risk of developing clinical type 1. Let's say they now know they have 2 antibodies. They will ask you, doctor, what is my risk now? what is my risk of having diabetes? So we have certain numbers here we can read together. So the probability of progression from stage 1, that is the normoglycemia, to stage 3, which is the clinical diabetes, from the time of seroconversion is 44% risk in the next 5 years, 70% in the next 10 years, and up to 84% in the next 15 years. But if something happened and they went quickly into the stage 2, now he will come back and tell you, doctor, now what is my risk? So stage 2, I already have 2 antibodies or more, and I have certain abnormal blood glucose. Either it's abnormal fasting, abnormal postprandial, abnormal A1C, okay? So at this stage, they don't have symptoms, but they have just slightly abnormal dysglycemia, what we call it prediabetes. So at this stage, now the risk has increased. You remember the risk in 5 years in stage 1 was 44%. But now you can see that the risk has jumped into 75% in the next 5 years, that they will progress into stage 3 diabetes. And even here, the risk is increased to 100% of lifetime to having diabetes. So there is no way back at this stage when they have it, except if there is some intervention. So, and they will reach stage 3, which we will face in the patients who present to your ER. So this is the clinical diabetes with the antibodies and progression that can lead to DKA or presentation with a typical diabetes symptomatology. And this stage, maybe some antibodies become absent. So in summary, stage 3 is the most diagnosed between ages 10 and 14 years, but now cumulatively more adults are being diagnosed than children. The etiology of type 1 is complex, multifactorial, primary T cell destruction, and the autoimmunity type 1 often starts at early age, and the antibodies are a robust biomarkers of autoimmunity from the beginning of autoimmune attack on the beta cells. And we have 3 stages of type 1 diabetes progression. So now we know about the staging. Now we will talk more about the screening. What shall we do to detect these people? So screening now is advocated and advised and recommended by almost all the diabetes authorities in the world, ADA, ISPAD, and other authorities. In ADA 2024 guidelines, they say that you should screen pre-symptomatic type 1 diabetes who are at risk by checking the antibodies, and for those who have family history or those who have risk factors like having other autoimmune diseases or certain genetic markers. So who are the people at risk that the authorities advocate to screen? They are the relatives of people with clinical type 1 diabetes, whether it is the father, mother, brother, or sibling, or even children. The risk factor also in certain genetic variants and those who have other autoimmune diseases, as we mentioned. But now there are suggestions that it's not enough to check only the at-risk population, because we know that actually the risk of admitting with DKA is more in people who don't know about diabetes, right? So the people who know about diabetes, maybe they're more aware, they will check, they will be more aware about the symptoms. But the people who don't know anything about diabetes, they don't have anybody in their family to have diabetes, they are at a higher risk of presentation with DKA, and they are actually will benefit more from the screening. So this is why now people are advocating also to go to the population and screen for the antibody for diabetes to avoid unnecessary admissions to ICU and the mortality and severe morbidity that's associated with DKA. So here is a little busy slide, and it's very nice, but it's busy. It's mainly about the FRIDA or FR1DA trial. This is a huge trial which was done it's ongoing also in Bavaria in Germany, where they followed a large cohort of children since birth, maybe from 2 years onwards, and they are checking the antibodies. Okay, and then they will put them under monitoring and support, and they will see their progression, and maybe they're also providing some prevention studies as well. So they will screen by doing the antibodies, and they will confirm it more than once if it's positive. And then if the normal glucose is there, normal HbA1c, normal OGTT, normal CGM, they will be early diagnosed. Finished?
Sorry for the interruption. It's 3 minutes to go.
Okay, I'll try to finish. So most children in this study show that more than 90% of children were screened in Germany. 280 had pre-symptomatic type 1 diabetes, and with segregation we saw that stage 1 were 70%, but stage 2 and 3 were 6 and 9%. So what we learned from this study, that screening is feasible, it can be done, and we should do it at least twice, and it was well perceived by the primary care and HCPs and families. So I'll skip this. I will go to the last part. I hope I can finish in 2 studies. Now we have people already that we screen positive. What we are going to do about it? So this is a little of ethical and psychosocial issue, right? So we know that type 1 diabetes is a life-changing condition. So there is burden of daily checking, burden of hypoglycemia, of admission to hospital with DKA and its complications. There is big psychosocial impact, not only on the child, but also on the family, in the school. It can be associated with learning difficulties, with long-term complications, and of course, socioeconomic impact on the country as well. So the value of delaying the onset of symptomatic autoimmune diabetes is really very important. There's lots of benefits in the quality of life, mental, financial burden, because we are reducing here the increased risk of hypoglycemia, the increased risk of DKA, the lower chance of honeymoon period, and the reduced life expectancy, which is associated with diabetes. So in diabetes, in general, they have reduced life expectancy, especially in females. So can we reduce all these complications by just screening? To some extent, yes, because the earlier you detect, the better control you have, the better support you give, the more education you have, you will avoid the initial severe presentation, which is connected to long-term higher A1C and long-term complication, even from the start. So, but somebody might say, okay, why should I expose myself to unnecessary shock, sadness, stress, anger, grief, and all these negative feelings, and I will live with all this anxiety until I get diabetes. Better that I live my life carefree without any unusual or abnormal feelings or unusual feelings or negative feelings. Well, this is debatable. I can understand this, but we should really weigh the benefits and the harms of screening. So the benefits are much more than these negative feelings, because we can prevent mortality and even mortality and morbidity is associated with DKA and severe hypoglycemia. Just try to, so we have to incorporate psychosocial care and integrate it in our routine medical visits. So always ask the person how they are coping about the diabetes, maybe through questionnaires, maybe you need to refer them at a certain threshold to professionals with psychology and psychiatry, and recommend support tools and resources. Trying to wrap up 1 minute. So the key goal of education people who have antibodies positivity is to support their psychological needs and to educate them on how to manage. And the third part is to monitor their glycemia status. So with the last sentence here, provide education, support psychosocial intervention to optimize general health and mental health for affected individuals. I think I'll skip this one because of the time. So in summary, the psychosocial burden of having a confirmed antibody positive status should be assessed and the support offered to individuals. So you have to be ready when you are screening the children that you have the proper support system before you do that. And HCPs should ask the individual about how they feel about the news that they have antibodies, and then provide emotional, cognitive, and behavioral functioning, assess it and integrate it into your routine medical visits. At the end, I'd like to thank you all, the chairpersons and the committee, organizing committee, for providing me this chance to talk about this. And I'd like to really invite you to scan this QR and introduce you about this very important platform, which is called Bridge. It has a huge and updated educational content on the latest understanding in autoimmune type 1 diabetes and prevention trial, etc. Thank you very much, and I'm sorry if I exceeded my time.
Good morning again. Now I would like to welcome Dr. Abir Al-Balushi. First, she will give us a talk, and then she will also open the conference for today. Dr. Abir Al-Balushi, Assistant Nursing Director, Acting Chief Nursing Officer, Dubai Health Authority, and she is a leader with over 20 years of experience across critical care. Let us welcome Dr. Abir Al-Balushi.
Good morning, everyone. Usually, I'm bad in preparing presentation. I like storytelling, and I like... So it's really my pleasure to be with you today. My name is Abir Al-Balushi. I'm currently the Director of Nursing for Dubai Health. Dubai Health is the first integrated healthcare system in UAE, which we do have facilities, hospitals, we do have our own university, we have our foundation, Jalila Foundation, so we are really lucky to be at Dubai Health. I will be really talking about, I will be continuing what Dr. Nabil and Yusur was talking about, which is empowering. And I will take a different approach, and I will be highlighting empowering from the lens of a nurse executive. Empowering is not only just like what Dr. Nabil said and Yusur, it's not only the nursing, the patient care. Empowering nurses is beyond patient care. And also, empowering nurses really help you to improve the quality and the cost. If you have happy nurses and empowered nurses, engaged nurses, you will have less resignation, you will have better retention and better outcome. So, as a nurse leader, I will be sharing with you certain areas of empowerment that we applied at Dubai Health. I joined Dubai Health 2003, and I do remember when I left my previous organization, which is Cleveland Clinic. I've been with Cleveland Clinic the last 10 years. People thought that something wrong with me. I'm going back to a government sector, which has no clue what is the system. In addition, my role in Dubai Health is totally different than Cleveland Clinic. Cleveland Clinic was only a tertiary hospital, 500 beds. There was a CNO. I never been a CNO or a leader to lead and report to the CEO. So going to Dubai Health was really a shift in my career, but it also helped me to apply what I have learned, also to apply what I was always believing in. My first target was empowering nurses, but really being a role model of the empowerment. What I mean by that is that I hugely believe that, yes, I will be focusing on UAE National, and I want to share with you that we were able really to improve Emiratization in Dubai Health in less than 2 years, 200%. We were 43 UAE National. Today in the system, we are more than 150. But at the same time, as a nurse leader, my expat population are also 99% of my population. So I have 1% UAE National, I have 99 expat. So again, how can I empower my nurses and look at all the nationalities, all the experience at the same lens? I'm very happy to share with you that we are the first healthcare system that fully sponsor its expat nurses. We have a university, we have 2 master programs, we have cardiac program as well as pediatric. So the last 2 years, we sponsored first 7 expat nurses. The second batch were 9 expat nurses to do their master program. We do support them financially to pay for the fees, but as well as to have their study leaves. You cannot imagine that this empowerment of education really supported our retention. Our retention in 2023, we had 88%. And I was told by my boss, we want you to fix this. and no one told me how to fix it. I'm very glad to say that our retention in 2003 was 88. 2024, we jumped to 92, and up to date, we are 95. So I'm very excited that we have less resignation, we returned the nurses. So how did we do that? We do that by a different way. As my colleague Yusur said, shared governor is very important. It's not only top-down, but it's also down-up, where you need really to listen to your nurses. You need to be in the floor. You need to do rounding. You need to be really visible. The other area is the culture of speak up, culture of support, and fairness, okay? It's hard because as a nurse leader, sometimes when it's really a critical thing, you need to be really tough. You need to make a decision, and you cannot really pamper people during tough decision-taking. But at the same time, if you show your team that your behavior is consistent and you are doing the same action, but you are not really, I hate reporting to a leader who will today say, oh, it's okay, you miss your documentation. You can pick up. But the next day, your leader will say, no, why did you miss? So always the consistency in your behavior and attitude and decision-making is really support the empowerment of your nurses. The other area is clear expectation. Empowerment comes from expectation. And I learned from one of my leaders that empowerment is not a delegation, because sometimes we say, oh, I'm empowering my nurse, but you also delegate. So empowerment is not delegation. Finally, I'm very fan of specialization. I did my school in US. I'm the first UAE national with doctorate in nursing, which is different than PhD. I do believe that specialization, it's really needed in UAE. We need to start supporting our nurses to do their specialization. And also, we are a young country. You need to mentor and coach as a leader, because I do remember that I had one of my nurses. She is amazing. She's good in everything. You give her an assignment, she will make it perfect. I met with her and I told her, and if her leader will allow me, her name is Esther. I did ask her, I told her, Esther, you are good in leadership. She has the personality. You are really good in education, and you are really good in IT, in EPIC. What do you want to do? Because as a leader, I want to really put her everywhere. Sometimes we are greedy as a leaders. I want to really give her IT assignment, I want to give her education assignment, and also clinical, because she has master in ICU. And she came to me and she said, no, I'm sorry. Even though we offered her leadership in clinical management, she said to me, no, I have passion to nursing education. I want to remain in the patient, in the nursing education, and this is where I want to really grow. So as a leaders, it's very important for us to really mentor and coach, and sometimes show the people what they are good at, and how can we support them. That's all. I promise to make it very short. Thank you so much.
Being with us today, it's always a pleasure to have you. This is a huge empowerment. Thank you so much.
Thank you very much to all the speakers.
I'd like to invite Dr. Ilham, please. Bro, Nabil.
Prof. Nabil. Mrs. Yusr. Mrs. Jamal. Thank you all. I would like to invite Dr. Abir, Dr. Ilham, Prof. Nabil, Ms. Yusr, Bashayr, Dr. Nando, and all distinguished speakers for opening the conference. Thank you.
Bismillah ar-Rahman ar-Rahim. It gives me great pleasure to start this session. I hope you enjoyed your coffee break and watch for your glucose, please. So this next session, we will have 4 distinguished speakers. And I'd like to call on the first speaker. Maybe I forgot to introduce, you know me already. I'm Dr. Ilham, and with me, Mai, she's a diabetic educator also. I'm sure you know her. Right. So it's my pleasure to introduce Ms. Hana Ibrahim. She's a certified diabetes educator in Danat Al Emarat Hospital in Abu Dhabi and specialist in diabetes management and lifestyle coaching. She will be talking now about changing the course, predicting and delaying type 1 diabetes. This is a very important topic, and it's a follow-up of what I've already heard in the morning about screening and delaying type 1 diabetes. The floor is yours for the next 20 minutes, Ms. Hana.
Thank you so much, Dr. Ilham, for the kind introduction. Bismillah ar-Rahman ar-Rahim. It's an honor to begin by expressing my heartfelt gratitude and to Ms. Zainab Al-Abadla, the president of Emirates Diabetes Educator Society, for her remarkable dedication and leadership that led to the initial formation of the Emirates Diabetes Educator Club, which got transformed to Emirates Diabetes Educator Society. And I would like also to thank all other educators within the society. I was asked to talk about the predicting and delaying therapies in type 1 diabetes, and I have decided that I will include in the beginning of my presentation some of the work that I'm doing daily with the patients with type 1 diabetes, the challenges and the burdens that those patients and their families are facing. So without further delay, let me take you through my today's outline session. So the outlines for my session today is I will start by talking about the onset of type 1 diabetes. Then I will talk about the challenges that patients and families are facing, the screening and the early intervention for type 1 diabetes. And I will be referring to type 1 diabetes throughout my presentation as T1D. I will talk also about the new therapy, the immunomodulator therapy to reduce the onset of type 1 diabetes, and here I'm referring to the use of teplizumab. And at the end, I will be talking about the implementation and challenges for using this new therapy. So ladies and gentlemen, as you know, type 1 diabetes, as was explained extensively by Dr. Ilham in her presentation, is a form of an autoimmune disease, meaning that the patient's own body immune system is attacking the beta cells, and the beta cells in the pancreas are the cells responsible for producing insulin. We used to know previously that type 1 diabetes is only affecting pediatrics, but we came to know that only 19% of the cases diagnosed with type 1 diabetes are among pediatric population. However, now we came to know that it's around 60 to 62% of the cases can be diagnosed with type 1 diabetes in adulthood. As other type of diabetes, ladies and gentlemen, it's increasing worldwide in prevalence. According to the International Diabetes Federation in 2021, there was 8.4 million cases affected by type 1 diabetes, T1D, and the number has jumped to reach to 9.8 million cases in 2025. When the patient is diagnosed with this condition, they lose around 34 years of their healthy life. Those 34 years are lost because of the complex treatment regimen, the acute and chronic complications that those patients are going through. And as Dr. Ilham also was mentioning, they also are having a lower health and life expectancy. All of those factors led to an increased challenges and burden among patients and their families. Caregivers of patients who care for patients with type 1 diabetes always report a lack of support system which causes social isolation. They have a heightened level of anxiety from the diagnosis and even after diagnosis, which causes emotional stress, in addition to the high cost of supplies and care and ongoing care, which imply a very huge financial burdens on families and patients. Now let's look into some clinical statistics and some researches that examine those type of challenges in details. Looking into this cross-sectional study from US Children's Hospital, the study team tried to examine the relationship between parental anxiety and depression among those parents who got a child who was recently diagnosed with type 1 diabetes within the last 1 month. The study team used multiple tools to look into depression, current anxiety, diabetes-specific parenting stress, in addition to parent self-efficacy for diabetes care. And what they found out that the parents in this study reported a higher diabetes-specific parenting stress. And the higher the depressive symptoms those parents were having, the lower self-efficacy to manage their child's diabetes. Another Swedish study examined stress and burden experienced by those parents. And interestingly, the parents in this study reported that diabetes strains family dynamic, and it even affected the partner relationship and the partner interactions within the family, in addition to intimacy, because of caring for a child with T1D. Caring for a child with this chronic condition within the family even affected other siblings, as other siblings reported the feeling of having attention imbalance, conflicts, and feeling of being overlooked by their parents, since the main care was directed from the parents toward the child with T1D. All of those factors leads to exhaustion, poor sleep, as parents has to respond to alarms coming from the diabetes-related technologies that those children are using, like continuous glucose monitoring sensors or insulin pumps, in addition to the night checks. So those parents used to wake up at night and checking on their type 1 diabetes child because of the fear of severe hypoglycemia or hypoglycemic coma. Those factors led to cognitive overload for those parents. They have a trouble concentrating and thinking clearly, and they describe themselves as being tying oneself in knots, reflecting the constant amount of stress and the feeling of being pulled in so many directions. Another interesting systematic review of articles looked into the link between and the relationship between bullying and type 1 diabetes among children and adolescents. And in 85.7% on articles included in the systematic review, it was found out that children, youth with type 1 diabetes are having a higher level of victimization and bullying compared to other children who are not diabetic or doesn't have any other chronic condition. A couple of those articles even linked the higher bullying level with the worsening of glycemic control those patients were having. All of those leads to limitation in socialization, difficulties in managing diabetes in public places such as schools, because those children were feeling afraid to be bullied by their other peers if they inject themselves with insulin in front of other peers or they check their glucose level in front of their colleagues in schools. Looking to the last part of challenges, the financial challenges. So I looked into data from different different areas in the world, examining the financial challenges, examining the financial burden of having type 1 diabetes patients in the families. And in this cross-sectional survey from India, where 380 families were surveyed, 30.3% of families spent over 50% of their income on diabetes management. Some of them had to borrow money, and some of them even faces expenses that were above their income. Another study from China, they looked into the financial burden among those families who cares for patients or adolescents 18 years and younger with type 1 diabetes. And it was found out that among uninsured families, those who doesn't have medical insurance, those families has to spend 8 to 33% of their yearly income as an out-of-pocket cost on diabetes. Some of them faced a long-term economic distress, and some of them even had to face poverty. Another US modeling study looked into which was published in 2020, looked into the current number of patients who has diabetes, who has type 1 diabetes, and the expected number of patients who will get this disease within the coming 10 years. And it was found out that the lifetime economic burden for caring for a person with T1D to be around $500,000 per person. And this number, considering both the medical cost and the loss of productivity, the acute and chronic complications, the sick days that those patients are going through. And this number is translated nationally, collectively, to be around $813 billion. Now, ladies and gentlemen, moving to the second part of my presentation, which is screening. When the individual is diagnosed with type 1 diabetes, they usually present with the osmotic symptoms of polydipsia, polyuria, in addition to weight loss. And since we highlighted in the beginning that T1D is of an autoimmune origin, they will have a progressive attack on the pancreatic beta cells. And as it was explained earlier by Dr. Ilham, we usually test for the presence of those antibodies formed by the immune system against certain protein in the beta cells. And the key antibodies that we test for to diagnose a patient with T1D is GAD antibodies, zinc transporter, insulin antibodies, and IA2. Keep in mind, ladies and gentlemen, that siblings of a child or a person with type 1 diabetes have a 15, even 20 times higher chance to develop type 1 diabetes more than the general population. And this put them in the high risk group, those who we can predict that if they tested positive for autoantibodies, they can get diabetes, they can get type 1 diabetes in future. Now, just to remind you with this staging that you already saw with my colleagues Sijimol and Dr. Ilham about the staging. So before the person fall in stage 3 diabetes, which is the actual onset of diabetes, which the initiation of insulin is a life-saving action, they go through stage 1 and in stage 2. And as you know by now, that stage 1, individuals will have 2 or more positive antibodies, a degree of normoglycemia, so normal glucose and oral glucose tolerance test, and it doesn't have symptoms yet. If they fall in stage 2, they will have 2 or more positive antibodies, a degree of dysglycemia, so elevated glucose level, but not to a degree to satisfy the criteria to diagnose a patient with ADA, the ADA criteria to diagnose a patient with type 1 diabetes, and again, there will be no symptoms in this stage. Now, ladies and gentlemen, why it's important to keep in mind those siblings who come from a high-risk group and the staging of type 1 diabetes? Because it can tell us the probability or the prevalence on their prevalence of those who falls in stage 1 and stage 2, what's their prevalence to develop type 1 diabetes. So quickly, and for the sake to not to repeat the same informations, those who fall in stage 1 type 1 diabetes, they have a prevalence to develop type 1, those who fall in stage 1 will have a prevalence to develop diabetes, 70% prevalence to develop diabetes within the coming 10 years, and those who fall in stage 2 type 1 diabetes will have more than 80% to develop type 1 diabetes within the coming 5 years. Now we know about those who comes from high-risk group, okay? And as mentioned earlier in Dr. Ilham's presentation, is that 90% of the patients who got diagnosed with type 1 diabetes comes from no family history of type 1 diabetes. That's why we still see some cases who got diabetes ketoacidosis on diagnosis, on the onset of type 1 diabetes, because diabetes is not running in the family. That's why the families will misdiagnosing the child. I'll skip this one. And the question is, so what about the general population? Since 90% of the cases comes from no family history, why not to screen the whole population for type 1 diabetes? And there are two voices who argues for the universal screening the whole population for this autoimmune disease, and there are voices which are against the screening for type 1 diabetes. For voices who argues for screening, they argues that if we screen if we do the universal screening, we can intervene early, we can reduce the onset of diabetes ketoacidosis at diagnosis, and we might identify those candidates who are eligible for the delay therapy, which I will be talking to you after a while. What about voices who are against the universal screening? They argues that type 1 diabetes has a low prevalence in general population. So out of 100%, you can get 3% diagnosed with type 1 diabetes. So the prevalence is considerably low, which is between 0.3 to 0.4%. They argue against the high cost of universal screening because we are not screening only for autoantibodies present. We have to screen for other parameters also. We have to have an infrastructure of labs. We have to train personnel, which might imply a huge burden and pressure on the healthcare system. They argue also for the psychological impact of positive screening that was already described and discussed by Dr. Ilham in her presentation. And they also argues for the limitation of the intervention which is available, currently available to delay the onset of type 1 diabetes. And ladies and gentlemen, that takes me to the last part of my presentation, which is the delaying therapy. And here in United Arab Emirates, we are one of the luckiest countries really to be able to have the new therapy, which is the immunomodulator therapy used to delay the onset of type 1 diabetes. So keep in mind, it's not an immunosuppressive, it's an immunomodulator therapy. And what this medication do is it's called teplizumab, and it comes under the brand name of T-Zelides. So it's basically a CD3 monoclonal antibody. It humanized the T-cell receptor target. So what it does is that it will affect the subpopulation of T cells, rebalancing the effector T cells and the regulatory T cell function, which will block the immune attack and prevent the T cells, beta cells damage. This medication was approved to be used by the FDA on November 2022. Let's look into a clinical data. How much time I have? Okay. Let's look into a clinical data about teplizumab. And this is a very important trial among other trials. And this trial, the TN10 trial, is the trial that caused the registration of this medication in the in FDA. So this is a placebo-controlled, double-blind trial where they recruited 78 subjects. Those subjects were falling in stage 1 type 1 diabetes. They randomized them into two groups: a group that received the teplizumab and the other group who received a placebo, and the placebo was basically a normal saline. And they followed them over 1 year, 2 years, and 3 years. And the primary endpoint that they were trying to study here is the progression from stage 2 to stage 3. And you can see that in the light blue color that the teplizumab group has a lower prevalence to progress from stage 2 to stage 3. In fact, the median time of progression to stage 3 in the teplizumab group was 2 to 2.7 years. Who is eligible to use this medication? Individuals who are 8 years and older, who are falling in stage 2 type 1 diabetes, and they are mostly a relative of patients with type 1 diabetes. Now, if you remember at the beginning of my presentation, I was talking about the stress and the depression and the challenges of caring for a child for T1D. And I found this interesting survey where they surveyed the parents who have at least one child in the family who is type 1 diabetes and other children who doesn't have the disease. And they were
1 minute.
All right. So and they were trying to understand the awareness and the acceptance of those parents if they are happy to administer this medication for their other eligible children. And a majority, more than half of the surveyed parents were happy to introduce teplizumab to their other children, and they see that the benefits might be in reducing their stress and making them more ready to manage diabetes. Coming to the last slide, which is the implementation challenges for teplizumab. The first implementation challenge is basically the cost. It costs around $193,000 per 14 days treatment course. The delivery logistic is another challenge, because basically it's not a subcutaneous injection, it's not a tablet, it's an IV administered medication that need to be administered either through a peripheral central line or a peripheral cannula. The identification hurdle is another challenge, since there is no established programs yet worldwide to screen for type 1 diabetes. We usually clinicians do it in the clinic for those who are relative for type 1 diabetes, again, if the family is agreed or if the family wants, but there is no worldwide established program to screen for type 1 diabetes. Most of the programs are part of research and clinical trial, and the only country that recently in 2022 passed a law to screen the general population for T1D was in Italy, and the objective was to screen the whole population for other autoimmune disease also, like celiac and type 1 diabetes. And by that, I came to the end of my presentation, and I would like to summarize by saying that the daily management remains a major challenge in type 1 diabetes. Type 1 diabetes is no longer a predictable disease. We can identify those at risk. Delaying the onset is becoming a possibility, and we need more data to understand the importance of delaying therapy on morbidity, mortality, quality of life, beyond the use of this in reducing the DKA. And by that, I came to the end of my presentation. Thank you.
Thank you very much. Very nice and elegant presentation. Lots of new information. Thank you very much. So we welcome again Mrs. Wafa. I think I already introduced her. So the floor is yours. Again, we'll learn, inshallah, about smart solutions for diabetes in the next 20 minutes. I'll remind you when you have 4 minutes left.
Okay, so good afternoon again. I will continue from where we stopped.
to save the time. So we talked about the CGM categories, and we differentiate the difference between each one. Now, before selecting the CGM, you should be aware about the FDA performance requirements. And this part, I will not cover it. It will be covered by my colleague in details in the other session. But it is important for you to be aware about the high glycemic index food, which raising glucose level rapidly, that could lead to inaccurate CGM data temporarily. And is it important for you as a healthcare provider to be able for reading the CGM report accurately, such as the daily graph, which shows how glucose reading fluctuating over the daytime and how is it affected by the patient daily activity, such as food and exercise. Also, another summary page, ambulatory glucose profile, is important for us to know about it too. It's providing a summary about the patient glucose status in the past few days. So reading the report as a whole will help you in deciding smarter for your patient diabetes control and will keep the patient well engaged in his treatment too. Okay, the most frequent question from my patient and doctors, is the CGM accurate? According to the latest study, 14 days of CGM data is accurate as the HbA1c blood test. That means using of a short period of time of CGM can help in reliable decision about glucose control. There are several studies shows the accuracy of using CGM among diabetic patients. This table shows a summary of several studies was conducted in the United Arab Emirates. The overall result show that CGM is safe, accurate for patients who has type 1 and type 2 diabetic. And also it shows the efficacy of using the CGM in certain circumstances, such as fasting Ramadan and during teleconsultation. The most recent study, and it is interesting really, was done in the UAE, summarizing 16 papers from Abu Dhabi, shows that the using of technology rate was very high, which is a very good prognosis. However, the hemoglobin A1c was suboptimally controlled among type 1 children and young age group. This result is very critical, indicates us to do further investigations and research. Over all the innovations, CGM has been the most impactful. We have globally several kinds of CGM sensors, but what we have in the country is subcutaneous sensors, such as Dexcom, Freestyle Libre, Abbott, Medtronic, and Cypionix. All of these sensors are sharing the same core main features. They are minimally invasive. They used enzyme-based process to detect glucose in interstitial fluid. The price is varied from moderate to high. All of them are accurate as it is a newer model. The MARD level less than 10%, and all of them not required a calibration test. Moreover, it varies in the duration of use between 7 to 15 days, and the warm-up phase could take between 30 minutes up to 2 hours. In the following slides, I will share with you each sensor special features in details. Here we have two models from Dexcom, the G6 and G7. Both kinds are approved for 2 years old children and above. Also, it has a feature of insulin pump integration. However, the G7 is the newer, offers more improvement. It provides a 12-hour grace period over the 10 days of use, and it has a shorter warm-up period. Further, the G7 is smaller and thinner and more accurate than G6. We have also Guardian Medtronic sensor. This sensor, designed for ages 7 years and older, it has a smart guard automation feature. It gives real-time insulin adjustment when communicated with Mini-Med insulin pump from Medtronic. The most popular sensor used in the UAE is a Freestyle Libre 2 Plus. This sensor is thin, suitable for ages 2 years and above, and it has insulin pump feature partnership. It is the longer sensor in lifespan, can be used up to 15 days. And the most recent sensor available in the country is Cypionix. This sensor received the European MRD certification in 2023, and it is available in the Europe and UAE currently. It is approved to start for 3 years old and above, and the patient should change the sensor every 14 days. We expected at the end of this year to have Inteligo sensor, that kind of sensor designed for adult age group who's 18 years and above. And soon we will have the Roche AccuCheck Smart Guide, this kind of sensor using the artificial intelligence in hypoglycemia, hyperglycemia prediction. Moreover, the night low prediction about 20 to 30 minutes before it happens. Now, all of these innovations making diabetes management smarter, safer, more personalized than ever. Nice to know about this CGM, the Eversense. It is not available in UAE, but it is implanted subcutaneously, very thin, and we have a lifespan of 90 days. Now, before inserting the sensor for your patient, of course, you should lead them for the safety education or safety guides at the level of insertion and removal technique. Keep your patient aware about the difference between sensory glucose and the blood glucose level. Moreover, keep the alarms always active, and mention that some medications could affect the CGM reading accuracy, such as using vitamin C, some diuretics, and aspirin, and other kinds of beta blocker. At the insertion time, if your patient experienced bleeding more than 60 minutes from the insertion site, or protruding of the cannula, or complains of severe pain, or have allergy, please ask your patient to remove the sensor immediately and to do relocation. It is important to avoid using the sensor under X-ray or high magnetic fields, and keep the small particles away from the children's reach. Personally, I agree with the results of Kaya study, who said, don't recommend the CGM for patients who's not ready to engage regularly in a medical regular follow-up. And a nice results from American Association of Diabetes Educators highlights how these 7 self-care behaviors, if combined with CGM use, can help the patient understanding their diabetes pattern better, which leads for better control of the diabetes on the long run. Now, the proposed question, who should use the CGM? What do you think? Who should use the CGM? Who should use? Okay. Great. So let's answer this question through the largest studies. The GDRF, COMSAIR, and Diamond study found that using of CGM with multiple insulin dose or insulin pump will lead significantly for improvement in the hemoglobin A1C level among type 1 diabetic patients. The HiBody study confirmed that using CGM reduced the hypoglycemia episode significantly among type 1 diabetic patients, certainly who's complaining of hypoglycemia unawareness. And there is an interesting study said that reducing variability can, of course, lead for positive health outcome. So what about type 2 diabetic patient? In fact, researchers said over the past years, type 2 diabetic patients get several benefits from using the CGM at the level of improving their glucose level, reducing hypoglycemia, and modifying their lifestyle. There is no consensus to use CGM for hospitalized diabetic patients. So what about the non-diabetic patients? Of course, they can use the CGM. And the most recent studies said patients who's non-diabetic spend 2% or more above the time in range, they should be subjected for more investigations and further lab tests. This is just a suggestion, but there is no consensus yet about it. Now, the CGM report is great and helpful, but it will be more powerful if combined with this insulin pump for type 1 diabetic patient treatment. So in the market, we have two categories of insulin pump. The tubed insulin pump. This insulin pump, the body of the insulin pump connected with a very thin tube and with a cannula. The cannula inserted subcutaneously and should be changed every 3 to 4 days, whereas the insulin pump body can be carried in the patient pocket or clipped in his clothes, and it should be disconnected if the patient willing to expose for water. The other kind is insulin patch pump. This kind of pump, small, compact, adhere to the skin, communicated with the smartphone app or with a remote through Bluetooth. There is no tubes. And the insulin pump supported with integrated delivery cannula that should be replaced every few days. According to the American Diabetes Association, selection of the insulin pump type depends on the patient status, and it is individualized, of course, between you and your patient plan. So here we can see the most popular insulin pump used in the market, Medtronic 780, Omnipod Dash, the newer Omnipod 5, and we expected to have tandem control insulin pump at the end of this year in the market. Each one have special characteristics at the level of age, weight, size, reservoir capacity, but I will stop on the main features of each one. Medtronic 780 has a hybrid closed-loop system that automatically can adjust the basal rate every 5 minutes. Also, it has an option of bolus correction every 5 minutes automatically. In addition to that, the algorithm has meal recognition technology, which helps to correct in the events of patient miscalculate of the bolus or mistaking the bolus. And this insulin pump is tubed. The other is Omnipod Dash. There is no tube for this pump, and it is totally manual control. For the newer Omnipod 5, it has a hybrid closed-loop system, automatically adjusts the basal rate every 5 minutes, but its algorithm don't have the option of bolus correction. And regarding tandem, it is a tubed insulin pump, has the feature of hybrid closed-loop system that automatically adjusts the basal rate and bolus as well, but every 1 hour. Again, in the market, we have two kinds of insulin patches pump. Solo from Accu-Chek. This insulin pump has a reusable insulin body base, lasts for 6 months to use, and the disposable part of the cannula and reservoir, the patient needs to change it every 3 to 4 days. This insulin pump required to communicate with a remote control for the insulin dose delivery, and it is approved to be used for the patient from 2 years old and above. It has 2 sizes of cannula, 6 mm and 9 mm. Compared to the EU patch insulin pump, it is disposable, sit as a whole. The patient should change it twice weekly. And this insulin pump communicated with the Narsha Smart app for giving the insulin doses, and it is approved for 6 years old and above. It has 1 size of cannula, 4.7 mm. Okay, now general advice before initiating the insulin pump. At the location level, ask your patient to avoid using the insulin pump at low atmospheric pressure. Avoid using it in high oxygen-rich environment and to remove it before exposure for the X-ray and high magnetic fields. Also, for the initial setting, they should use a trusted Wi-Fi. At technical level, ask your patient to do not use the blood glucose reading which taken more than 10 minutes to avoid miscalculation of the bolus, and to respond promptly for the messages, all alarms from the device. Also, it is important to check the activity status of the insulin pump frequently, or to check the tube if it is containing any air bubbles. And for sure, they need to track their glucose reading frequently. If there is hyperglycemia, more than 250, they need to check the blood ketone, and if indicated, to change the insulin pump. Okay, now several studies prove the benefits of using the insulin pump for type 1 and type 2, for type 1 diabetic patients, and either the patch or tubed insulin pump. So now insulin pump is the perfect tool for type 1 diabetic patient. What about type 2 who's still using the insulin pen? We can say to them, insulin pen has become smarter too. We have the smart pen, which is a reusable device connected with the mobile application by Bluetooth, have a feature of recording the insulin doses and tracking it automatically. It has a feature of giving alerts and reminders if the patient missed the insulin doses, and insulin temperature sensor reminder also, or alarm. It has the feature of integration with other kinds of CGM. The only available brand in the UAE market is InPen from Medtronic. The Smart Pen proves its benefits for increasing the patient adherence to the treatment, especially if they are missing the insulin doses due to the feature of reminder alarms. And it is also get benefits for the healthcare professionals, as they can reach to the patient data and help in clinical support. Now, as innovations continue to evolve, we have got knowledge from Abbott company that they developed a new sensor evaluating glucose and ketone at the same time. Also, researchers from MIT company have developed a wireless, small, teeny device, less than 3 milligrams, implanted subcutaneously, can release glucagon when hypoglycemia is detected. Now, after reviewing the tools and the system, I would like to share with you one real-life case, shows how selecting the proper technology and the innovation can help in changing the diabetic patient journey. So let's listen to our patient story. وين الفويس؟ لازم يكون في voice.
You have 1 minute left, Mrs. Wafa. 1 minute.
Okay. Anyway, supposed to have a voice, but anyway, this patient, she's 36 years old. I saw her before dialysis session, and she was taking total daily insulin dose is 44 units. Then this patient, she's type 1 diabetic, was suffering from severe hyperglycemia, and then she diagnosed with renal failure, started dialysis. After dialysis, she experienced severe hypoglycemia. Reached to the level, we stopped the basal insulin for her, and we give her total daily dose about 4 units to 6 unit maximum, bolus as correction dose. Then we advised her to use the insulin pump. At the beginning, she refused because she has background, she's not satisfied with the tubed insulin pump. Then we convinced her to start EU patch insulin pump. After trying this insulin pump, her glucose readings become better, well controlled, and until today, she's really well satisfied with it. This case reflects how combining innovation and education can lead for better diabetes and powerful diabetes control. And that brings me to the key message and the conclusion of this session, that technology empowers, education transforms, and together they refine diabetes care. Thank you for your listening and your time.
Very much, Wafa. Sorry, we will not take the questions now. We will keep them to the end of the panel discussion. Now, welcome with me Ms. Manar Abu Asaba. She is a senior diabetes educator working in Imperial College London Diabetes Center, and she's a faculty member in IDIT course, which is the course that helps us all to be certified in diabetes education. And she will be talking about transforming diabetes care and the power of education in driving sustainable change. The stage is yours.
Thank you. Thank you all for being here up to this minute. Assalamu alaikum. Ya'tikum al-afiyah. Good afternoon, everyone. Well, I will be grateful to start with great thankful for all the organization being made this such a dream make true, actually. And my heartful grateful for Zainab for all her effort and the support she get from all the team, and will deserve, actually. And good luck. We are aiming for more, definitely. So moving forward, starting from this presentation title, so we start initially in the morning and speaking about nursing, specialty, and I'm really grateful for Prof. Nabil, and he touched base on how specialty is important. And from that start, I will set the outline of my presentation, which is initially discuss the current guidelines for diabetes education and their component. So it's to address why you all here, and identify the major benefit in providing diabetes and self-management education as a part of person with diabetes care and critical time in delivering these specialist diabetes education. Also, we will move forward on implication these guidelines and how to incorporate them in your daily practice. So this term you will be hearing a lot. What is self-diabetes management? And what we do exactly. So ADA is explaining its ongoing process to facilitate knowledge, skill, and the ability necessary of delivering diabetes care. So you will be equipped with the skills, and you will be set up these skills to your own patient. Moving forward, this activity should be implemented and should be sustained. So keep these two words in your mind. So you need to understand how to sustain these skills and education. So these are the national standards set by ADA. So you remember, you are specialized, you need to get equipped with the knowledge, but you need to set a guidelines to deliver this knowledge. So ADA, luckily, we have a reference, so she set a 7-pillar to start any diabetes and self-management education program. So initially, support. So you need to get the support from leader, human line manager, from the country that you are holding and launching this program. Population, you assess. So you need to take into account to whom to deliver this education. So you need to target whether a small group, big group, and whether different age group, whether adult, pediatric. So these self-management education can be delivered to different target group. Furthermore, you need to have the team. Luckily, we have 100 diabetes educator licensed, and we are aiming for more and more. Definitely, as mentioned earlier, we are launching IDIT, Diabetes and Education course. So these are the first line course launched in the country to be able to get the license through DOH. So keep in mind the specialty and upgrade your skills. So we are aiming to increase the number of the team. Delivery and design, you need to take into account how to deliver and what are the structure of your program. Person-centered, keep in mind that you are dealing with different age group, not all patients same. We all have the guidelines, we all have the book, we all have the study, but you need to be specific in your delivering patient care. Measuring and demonstrating outcome, absolutely for any education program, you need to have quality indicator. You need to be able to assess your program. And believe me or not, we launched diabetes education program at Imperial College London Diabetes Center since 2018. And up to this minute, we are update the program. So we start initially with small group, building up the program, and always we modify the program based on patient evaluation and patient need. So we need to understand who will deliver this program, okay, whether you are specialty, and what team we need to deliver this program, and what evidence base to deliver such program, and how to deliver this program, and why we need such program, and when. So initially, diabetes educator, I'll skip it actually because for the sake of time. So as a specialty, sorry. I'm sorry, the arrow is moving quick. It's not backward. The pointer, it's hang, I see. It's hang. Thank you. Trying. It's now. I think the gentle press, I try. No, also, it's not backward, it's hang. I need just to go backward. I think it's hang. No, back. This is front. So certified diabetes educator need to have the informed decision making. So you need to have the license, you need to have the authority to practice your role. And you need to be able to practice and encourage behavior modification, and also have the tool for problem solving, and collaborate with other team member, and you should be a part of routine for any patient with diabetes. So as it's mentioned earlier, you will hear this terminology a lot in delivering patient care. So who are the care team? Okay, so we have diabetes patient, we have endocrinologist in the team, we have dietitian, pharmacist, family member and friend, other caregiver, we have pediatrician, psychiatric and social worker, community health worker, and we have supportive group. I faced patient last Thursday and he was asking, who are you? He's been following annually with us, and he was just surprised. What are our background as diabetes educator? And he gave me a hint why you need only pharmacist, dietitian, and a clinical background. Are you aiming to support and launch social worker in your practice? So, which give me a hint and things to consider in future modification. So as it's mentioned earlier, and it's mentioned with other colleagues, what are the 7 pillars in terms of delivering structured diabetes education? And these are really straightforward and need to be kept in every daily practice, which is you are a problem solving, you are enhancing and monitoring patient taking medication, healthy eating, healthy coping, and being active. These are the 7 pillars for every patient with diabetes need to be enrolled in your only daily practice. Nevertheless, it's mentioned earlier, diabetes education, it needs to be culture influence. You need to modify your daily group session daily individual consultation based on your culture base, and you need to have always the support with a psychological family member, and also insulin and medication. Patient is always coming to you to learn how to use all these tools if it's launched initially in their own treatment, and of course, all these innovation and technology, not all patients get this device, but whenever they have it, they have to pass by diabetes educator, and you go through lifestyle modification and nutritional aspect, 6 days rules, all these need to be addressed based on patient need, and addressing chronic complication. You are dealing with multi-case, different case, dialysis, pre-diabetes, different diagnoses. So depend on your facility, you are dealing with different individual. Based on that, you need to understand what are the individual needs for each single patient. And of course, risk reduction to avoid further complication. Lifestyle modification, it's not out of your role, not out of your scope. It's first initial treatment. So always we go through this term, and it's not far from your daily practice. So weight management, physical activity, overall well-being. And moving forward, physical activity and emotional well-being are correlated in one gap. So it's not far from your all daily practice and overall well-being for patient care. So tailor to individual need. Take into account your consultation need to be individuals, need to be financial build based on patient coverage and insurance. Remember, we are all facility now looking for income, looking for profit. So if you are specialized, you need a revenue for the facility. So based on that, be well known that the service should be built, but taking into account patient coverage, patient health insurance is also need to be taken into account. And always ongoing discussion with the insurance company, your facility, it's not out of your role. Cultural, individualized, so I told you, it should be based on your own community, your diabetes education program. And also, personal preference. You need to have a patient-own discussion. So give authority for patient to choose their care. So you deliver the skills, you implement, but keep it open skills. And I will get you through the consultation tips in your daily practice. So rules is not too far term. So you will learn how to respect your patient and make open-ended question. So make it an open discussion and listen, just not giving the deductive instruction for the patient. And patient always listen and get the knowledge, but don't be far. They can guide you what they really need to do. And also, always stay curious. So, open gate, open door, how to change patient practice. So, I will take you through 3 decision modules, which is a team talk, and optional talk, and decisional talk. This is a latest research, which is engagement in your own daily skills. So, it's not just listening, it's just giving option and active listening to patient. And at the end, you will find decision in terms of plan of care. Moving forward, the SHAPE consultation is seeking participation of each single patient and always compare the option. Don't give didactic learning. Just take an initiative and seek the patient what they really need, keen to do. Also, it's not a shared decision making. It's not just giving the instruction to patient. It's just an open gate between you and patient, building trust, and always evaluate. So find time to monitor and follow up your own patient. So what are the successful pillars of structural diabetes education program? Whether it's individual or a group, it's versus individual, team, you need to have the team. If it's short-term hours, 10 hours, as I meant, this is all proposal, but you need to figure out how to choose proper what matching your facility and your own group of patients. And also at the end, we all aiming for engagement and changing behavior. Remember, didactic lecture is at the end, so don't point and give instruction to patient. So we all go beyond HbA1c now. It's not just a figure. It's we need to look to quality of life, healthy lifestyle, self-efficacy and healthy coping. It's not just a figure. Remember, whenever patient came and asked for HbA1c, I'm saying, why you ask about this HbA1c? Just look for different pillar to improve your A1c. And moving forward, actually, we have the service, we have the specialty, but where are we in this? So from healthcare system, why do you think not all patients get this service? Is it lack of support? Is it limited number of diabetes educators? Or we don't have such structured program? And caregiver, referring to healthcare giver, do you think all physician, with all my respect, knows who's the educator, refer this patient? So we need to set a structure, guidelines, proper referral pathway to address your role. So in your own facility, I will tight your hand to set a policy, outline the guideline to address more your internal role in your facility. And also, patient with diabetes, as I told you, we need to consider coverage, insurance, and cost impact, and environmental, taking into account, respect the culture and patient beliefs. So the program, you need to assess, you need to set a goals, you need to plan, and you need to implement, at the end, evaluate through quality measure. So what are the measures of quality? These are proposal, okay? You need to identify always area for improvement. You need to type outcome, so whether it's a process, whether it's patient-related, or whether it's patient-reported. And what we are trying to achieve in delivering such a program, and these are a hint question, just to assess you where to improve, area for improving, and what challenging we face, and how we may change in these challenging for improvement, actually. And these are very standard and clear guideline, ADA. So when is the time to meet with the diabetes educator? So initially, any change in the transition in patient care, patient will get pregnant, change in their scenario. So definitely they need to see diabetes educator. So pregnancy itself is a change in patient case, patient empowerment. So she needs different modification, different program. So these patients should be seen by diabetes educator. Although, if patients, sorry, Shakir, I skipped you. I think I need time, still have time? Yeah. Okay, so the key message actually, what are the diabetes effective and self-management program? What are the time patient need to meet with diabetes educator, and why we are aiming for patient with center care? And as a healthcare professional, we all promote for patient with diabetes to be given a diabetes and self program. And there is a lot of guidelines and reference related to diabetes and self-management. Our major reference is ADA. Thank you.
Very much, Manar. Now, our next speaker will be Mr. Shakir Sulaiman. So he is a senior diabetes educator working in Sheikh Shakhbout Medical City with over than 10 years experience. He has also multiple contributions in research and clinical trials, focusing mainly in technology, integrating technology in diabetes education. And because educators are amazing, he will be talking about something else other than insulin. He will be talking about expanding diabetes educator impact on growth hormone service. Thank you, Shakir.
Thank you very much. Good afternoon, everyone, and welcome to First Diabetes Educator Conference, and congratulate for every diabetes educator in this region for the achievement. The extended congratulations, and the main thank goes for Ms. Zainab Abadla for your effort. Thank you very much from our deep heart. So today I decide, since we are speaking about diabetes since morning, I decide to take you something else to extend our role as diabetes educator. So we're going to talk about another role of diabetes educator for treating patients with endocrine disorder, which is growth hormone deficiency. The objective is we'll review the physiology of growth hormone understand treatment landscape in United Arab Emirates, discuss challenges and solution for a growth hormone, and emphasize digital platform for growth hormone deficiency. So growth hormone deficiency is being discovered, diagnosed since many years ago. Fancy medication, very expensive medication, very fancy laboratory measures are there, but still we have many, many children, they didn't reach to their height expectation as a clinical expectation. And the reason behind that, it always goes behind the adherence. And now we'll discuss in details what the digital platform that can bring and support patient to reach to the clinical outcome when it came for growth and standard deviation. So what is growth hormone? So growth hormone is a somatropin. It is a protein hormone that transfers by blood. It's a polypeptide of containing 191 amino acids, and its role it's making our height as it's expected. And somatropin is the main ingredient for growth hormone, and that's been genetically engineered by mammalian cells, and just to produce authentic polypeptide that carry the 191 amino acid to replace patient with growth hormone deficiency to gain their height. So growth hormone, if we look at the action of the growth hormone, it increases bone growth, it increases lean muscle mass, decrease adipose tissue, and because that, if you just notice after you starting treating patient with growth hormone, you will feel that he losing weight from his face, and that because he's starting decreasing some adipose tissue, increasing growth of proliferation of most body cells. And if you look for the growth hormone action in different segments, in the height, reduce the skeleton growth, pre-pubertal in children with short statures. In the bone, it stimulates synthesis, some very essential minerals and substances like phosphate, like collagen, like chondroitin, and that all it's responsible for direct effect for enhance skeletal growth and decrease bone mineral density. If you look at the muscles, it promotes cellular growth stimulated by protein formation. So what is the growth hormone available in the market in United Arab Emirates? We have Sazin, we have Nootropion, Genotropin, Omnitrope, Amhenotrope. All this growth hormone is available and being used by our clinician. And the very important point that we need to look deep for the patient background, patient economic status, patient support system to pick the best growth hormone for this patient. In particular, I'm going to speak about the Sazin. So Sazin offers us with digital healthcare system where we can monitor the patient virtually. Patient can track their children adherence, and that will increase the adherence, which will affect the growth velocity and will increase the standard deviation as well. So in digital health system ecosystem, it has Growth Buddy, which is an app that's been downloaded by patient, and they can track their patient data, their children data. They can track even virtually if their children has took the injection or no. And it has another, those who don't like to use devices, they still can use like PIN, Alwita PIN, and we are not supporting PIN anymore. We support the digital system because the tracking system. So if you look for the digital system, you just count, which pointer? Okay, so it's 3 parts. It's 3 parts. So this is the patient device where the patient can have the device. Diabetes educator role here is to program the device, connect the device to the ecosystem, and adjust the dose, and educate the family how to use it. And when it came for the benefit for clinician and the diabetes educator, we can monitor patient season adherence, record the growth, create patient, assign device by serial number, and that will not assign by another serial number, manage patient list, and run reports. And for the patient and caregiver, they can record the growth, receiving reminders in their devices that your turn for growth hormone dose is now, take it. And if they missed 1 day, still they have a reminder as well. So this platform, what's providing us as a healthcare provider and as a parent for patients with growth hormone deficiency, support timely treatment, optimizing through remote patient adherence and progress monitoring. So if the patient is using normal growth hormone without platform, what is the scenario is, the patient turns into the clinic, we are assuming that patient taking full dose, and when we check the IGF, we find it lower than the normal, we assume that the patient is taking the full doses and we increase the growth hormone dose. But in fact, many of our patients, not in our region only, it's globally, they are not taking the medication regularly. And sometimes when we increase the dose because of lacking of adherence, and the patient out of sudden he starts adhere, we will have a high IGF. The second point is enable shared and personalized treatment decision through collaboration between healthcare team and patient. When we have a tool and we show parent and patient that, look, you haven't took like 25% of the medication for you, what's the reason? And we start looking after the reason. And sometimes it's very wise to change the patient from daily to weekly if the reason behind that is injection phobia, or a parent, they don't like to give daily injection due to the commitment. So sometimes we need just to look about everything around the patient, and we try to pick the best solution to gain the highest height as we expected clinically. And deliver real-world patient data to support effective management of a growth hormone treatment patient, because those data will accumulate it and will be in use for researchers for future improvement. So unfortunately, many studies have shown that 82% of the patients are missed 1 or more injection per month. And when they missed 1 or 2 injections per month, if the patient, the data shows that if patient missed 1 injection per month, the standard deviation will be less 0.11. If the patient missed 2 injection per month, the standard deviation will be less 0.22, and the 3 as well. So we are speaking about height, and height has time. And if the patient lost standard deviation by 0.33, that means he might lose like 6 or 7 or 10 centimeters from his height lifelong. So time-sensitive medication, time-sensitive condition, and we need to be very committed for our patient to try to use our best, because they will not lose the time before the bone is fused. And here again, has another study showing that the more you not taking your daily injection of growth hormone, the less growth velocity you have, the less standard deviation, and that will last for long. And here another study showing that people with any form of growth hormone that use platform, that they increase the standard deviation by 1.1 deviation. So my message here is, if you are run out of time with one patient and he came late to the clinic, like his age is 14 or 15, and he didn't have luxury of time to replace his growth hormone before the bone is fused, try to use a form of growth hormone that has platform, so you're trying to reach to the minimum optimal compliance to get the most benefit of the growth hormone. And similar studies showing that how if you miss the injection, you will reduce. See, if you just can't see the difference, if you didn't take the injection, you might lose 3 centimeters per year. And if you're taking the growth hormone for 3 or 4 years, that means many centimeters, and people will lose it forever. And here another study. There's multiple studies showing that the less adherence, the less growth you will have. And what is the solution? The solution is, before we start any growth hormone for any patient, we need to really look deep about patient background, patient educational background, family support, and we need to pick whether we go for daily injection hormone or weekly. Some changes and differences between growth hormone, some came with complications like gaining weight. So if we have patients with obesity or overweight, maybe we exclude the weekly growth hormone, because many studies shows that people with that growth hormone weekly that induce weight gain or affect the HbA1c. And we need just to look about those features to pick the best option. Identification of feature of non-adherence. So we need also to look why this patient not adhere. Is he having phobia? Is he doesn't have support from the family? If you have any psychological issue, we have a couple of patients that we managed to get them adhere to their treatment after we refer them to the psychologist. We don't need to forget the role of psychologists to empower patients to adhere to their treatment. They understand their situation, they understand why they take the medication, and they've been empowered. So if you have any patient with poor compliance with growth hormone deficiency, just think about to refer him to either dietitian or psychologist. They play a best role, a good role in our hospital. And of course, we need to develop efficient intervention based on delivery, constant personalizing advice. We need just to have we need, through the education, through the empowerment, reach to the reason of non-adhere, and we need to tackle that point and take it from there. So improving the adherence for patients with poor growth response. This is a study where they check the expert expectations. They check the endocrinologist physicians, and when they show them they use the platform Sayzen, and they measure their expectation. Next slide. Yeah. So many of experts said that motivation is the most important part when it came for growth hormone deficiency. We need to motivate the patient. Sometimes we need to, for myself, for example, sometimes I need just to find where it can motivate the patient. For example, for the girl, if they know about the role of growth hormone when it came for their beauty side, they will be adhered to more. So now I'll tell them, when you have normal growth hormone deficiency, your nail will grow better, your hair will be better, then she will start taking the growth hormone more seriously. And here, another study that compared between growth hormone with a platform versus growth hormone normal injection. And they found that the people using growth hormone Sayzen with a platform, they have additional 3.2 centimeter. And the reason behind that, the ecosystem behind that treatment. Here, another study from UK, supported pediatric growth hormone therapy, resulting in. So they measure the many physicians from UK, and they ask them to compare between platform devices and non-platform devices, and overall mean Likert scores of survey statement were 4+, and many of them, they said the preceding easy of use. So it's easy of use. The preset dose, they favor it because patient, there is no more longer need to dial the dose. It's preset by the diabetes educator or by the endocrinologist. And of course, we didn't miss our region. So here there's a study, multi-center study published recently, and it's been United Arab Emirates, Oman, and Saudi Arabia. There is where 22 patients, 186 of them, they finish the compliance data. And when we look for the data after they complete, the overall compliance were 87%. the people who are using this platform. And the minimum percentage recommended of 85% is considered optimal. So those patients reach the optimal growth. When we look for the details of the study, preset doses, the most like the preset doses and the hidden needles, because the device, it has hidden needles, so patient no longer can see the needles, they will feel the needles. And of course, I do recommend whenever you're prescribing patient with this device, some people, they say it doesn't have needles and patient will feel the needles, but we can see it has hidden needles, so you can build the trust better. So what we learn after that we starting doing the growth hormone education and with our patients, higher satisfaction scores were seen in more adherent people because they feel and they see their growth. The majority found is very useful tracking system, especially the parent and the caregivers. And there's still area to inconvenient, like storage and size. Some people, they are living in multiple houses, they move between home to home, and they found it very bulky to carry and very heavy. And here I need just explain the role of this platform when we take care of people like in rural area. We have a few patients, they are living in very rural area like in Ruwais or Ras Al Khaimah. So in this system, we can, from our clinic, we can open their file and we can check their adherence. We can adjust the dose if they need. And recently we're starting a new study in our system, the role of telemedicine when it came for growth hormone deficiency. And our target is if the patient compliance is 85 and below, we need to give them a call every 2 weeks, and we will measure the standard deviation after 6 months. We will look after also the changes in HbA1c and the changes in the weight. And hopefully we will find a good result in that system. So this system will be available for any people using those platforms, just if you connected the patient through the platform. So this is how it looks for if you open season. The growth, the green lines here, it's mean that patient have taken the injection. The pink line, that means patient didn't have the injection. And here, this is one of example in Sheikh Shakhbout city. If you just see here, the compliance were 30%. We call this patient, and the compliance is become 86%. Recently, we're starting calling patient because we have the privilege to see the compliance, and we have the luxury of that time. We're just starting empowering our patient because of time-sensitive condition. Tool, okay, I'm going to skip this. There is one tool for patient that can use. It's called a Grozon Buddy. And the Grozon Buddy, it's a library building in the patient application. It have few things. It have tracking statement that you can track the injection. It have learning library. Everything around the device, it's being recorded in that application. And it's, you can track the progress as well. And the goal also, the ultimate goal for growth hormone deficiency is increasing the adherence. Conclusion, adherence is remain critical obstacles in achieving response to growth hormone. New digital innovation is a way forward in medicine. Electronic health and connected care are innovative model for delivering modern medical care. Thank you.
We will be giving the certificate now
okay.
also. Thank you. Manar Abu Asaba. Okay, thank you all for our speakers, and now we will have our panel discussion. If you have any questions, the audience, we will give the priority for you first. So please, if anyone having question, can you just come and queue in here? Is it fine?
Thank you very much for all your amazing presentation. My question today for Hannah and Shakir. So my first question to Hannah, that you talk about the medication, which is May in last EDIC she discussed it, right? Okay, so we can see it now, it's on hand. So I would like to ask if we have it, as you said, we have it here, where we have it, and I want to know the side effect of it because it's a new medication. For Shakir, thank you for the presentation. I want to know, as a diabetes educator or somebody teaching about hormones, what's your trick that you learn through life? Because I know you are long in SSMC and you're doing that for a long time. What keep the patient adherence better as Shakir advising the patient? Thank you.
Thank you, May, for the question. So yes, you asked me two questions. The first one is about the availability of Tzielide, of teplizumab, and yes, it's available. And there are multiple entities, multiple hospitals around UAE who got the experience to use teplizumab. I believe in SSMC and us in Danat Al Imarat also, we had the privilege to introduce the medications for one patient, and also I believe our colleagues in Al Jalila, they did that. So yes, it's available. And about the side effect, let me make it clear. So there is a full protocol that needs to be followed when we administer this medication. And we usually go for blood test before the administration and during the administration and even after the administration. And if there are any side effect that was found from the blood markers, there is a criteria there is a criteria whether to hold or to stop the infusion. And as I mentioned, it's a 14 days of a consecutive infusion. The main side effects that reported in the clinical trials for this medication is basically something called cytokine releasing syndrome. And it's basically manifested by rashes, fever, and headache, and myalgia. If it was mild to moderate, we can still continue the infusion because this is considered to be transient. It subsides within 5 to 6 days during the infusion, and there is medications that need to be administered actually to overcome this main side effect, like antibiotic an antihistamine before and during the infusion. Other side effect, as I mentioned, there is a protocol if it happens, such as lymphopenia, anemia. It depends on the degree of those side effects, and it will tell us the degree whether we should hold or stop the infusion.
Thank you, May, for the question. So I'll give you a short answer for that. I think every patient has a key, and we need to look after that key to start the education. So some people, they are very keen in school, and they try to achieve their highest. And we speak about the growth hormone deficiency versus the IQ, it will tackle them. Some girls, if you're starting with the rule of growth hormone in their beauty side, skincare and hair growth, they will take it more. And for some parents, if we speak about the growth hormone deficiency versus the genital area formation and these things, they will take it more serious and they will start to empower the patient. The idea is not to make people freaking out. The idea is to motivate, to see what tackle them and starting from there. Thank you.
Any other questions from the audience? Okay.
Thank you so much for all the nice presentation. Special thank also to the organizer, Zainab. I have a question for Ms. Wafa. For the case study you have showed, what method do you recommend for blood glucose monitoring for patient who is using insulin pump and undergoing dialysis? I think it's very challenging. Okay. I need your recommendation. And what method of blood glucose monitoring do you use in patient using insulin pump and undergoing dialysis?
Okay. So which kind of continuous glucose monitor or a glucometer for certainly the patients who are undergoing blood dialysis while on insulin?
Our case study I shared with you, she's a type 1 diabetic patient, and of course she gets benefits from using the continuous glucose monitoring. And as I am in a private sector, the only sensor available in our pharmacy is Freestyle Libre 2+. Besides that, because you know the dialysis process, these patients could experience severe hypoglycemia, especially during the dialysis session or immediately after the dialysis session. So the sensor could give inaccurate reading temporarily. For that reason, I advised her to depend on the blood glucose readings if she planned to take a treatment decision in insulin correction or treating hypoglycemia, especially when she is not feeling the symptoms. Sometimes the sensors gives alarm, which is fake alarm of hypos, but the patient without feeling any, she's not feeling any signs of hypoglycemia. So better to confirm that status with the blood glucose test before taking her treatment decision. Thank you.
The question is from me to you, Manar. Okay, so my question is, as diabetes educator, would you prefer individual diabetes education consultation or group education session?
Thank you. That's a very political question, actually, which is, as we mentioned earlier, you need to figure out your structured education program initially. So, and I told you, a group session and structured education program are really crucial and beneficial. However, in daily practice, we are seeing individual or upon individual consultation. So in comparing individual consultation and group session, definitely I will go for group session. It will save time, it will share experience, and if it's evaluated structure, you will get the benefit absolutely. And believe me, at the end, you will be able to build for this service, and it will make a good revenue actually. And in terms of individual, yes, definitely, we always, whenever patient need, we offer a session, we offer individual consultation, but from my privilege and my expertise, I will go for group education
and looking to the impact of this group education and how it saves time, how it will impact experience change, yeah, I would go for group education. It's a debate question actually, but it's my preference.
Thank you very much, Manar. So with this, we come to conclusion of our talk. Thank you for all of you. So with this session, we covered multiple objectives. So Ms. Hana have spoken about how to screen patients for diabetes, how to prevent diabetes by applying some FDA-approved medication like teplizumab, and how to also prepare the family and the patient themselves when we are delaying it. It's better than having it suddenly. And then Ms. Wafa covered the role of technology in type 1 diabetes, which I believe all of us agree that it's coming a must more than luxury nowadays. And in the near future, I hope it will be available for all people who are insulin dependent. And then we have Ms. Manar, who found the connection between what available tools we have in the market and what technology and everything and resources. So as a structured education, it's a connection between those tools available to be delivered to the patient and the family in the right way to utilize them in the best way possible. And lastly, we end our talk with Mr. Shakir, who discussed the role beyond insulin, beyond our usual role. So we have a role as educator even to make sure that our patients are adhering to treatment to get the best result of medication that are very expensive and very impactful, like growth hormone therapy. And with this, we conclude.
Very nice wrap up. I should congratulate you for this. I love it. And I love all the presentations. Thank you, everybody. And I think people are waiting for lunch.
And now I just want to add that we are going to have a boat symposium, and it will be presented by our dear friend, Mrs. Ghada. So she will be here, and she will be discussing CGM in diabetes. So please stay with her, and we will give you a certificate as well. So we are sure that you are going to do brilliant. So I will give you the certificate now.
So nice of you. Assalamu alaikum. I'll make it short and nice. So it's a truly pleasure to be with you today with this Diabetes Educator Symposium, a conference. And let me express my feeling, how proud I am feeling that I'm seeing our diabetes educator community growing up. And finally, we have a stage to stand on, and we have a voice to be here. So thank you very much for everyone who contributed to this event to happen today. My talk today is about CGM, and I'm not going to elaborate more in the CGM types or how it works, but I'm going to connect it to our diabetes educator. And I'm going to show you today that the CGMS is not just a tool that empowers patients, but it's a tool that empowers diabetes educators and patients on the same time. This one? Oh, thank you. Okay. So why I choose the topic of CGM? Because during my daily practice as a diabetes educator, whether I was caring for pediatric or adolescent or adult, the glucose management remained the most complex and impactful, challenging part of the diabetes care plan. So CGM, it will never be just a tool for a patient. It also a core component that shape our conversation with the patient and how we guide them during their journey in diabetes care. This is my objectives. This one. Okay, as the diabetes Management has advanced significantly during the last years, but still, there is always a challenge. In the reality, we are still having issue with this, with the diabetes management. Guidelines recommended actually that the best is the patient to monitor blood glucose 6 to 10 times per day. But in real life, most of the patients doing this for less than more times a day. And this is not just observation, this was supported with a study. For example, Polonowski at 2011, he showed that only 1/3 of the patients adhered to recommended frequency of blood glucose monitoring. As well, Foster at 2019, and that was years after inventing the CGM, reported that less than 1/4 of insulin-treated patients reaching their target of hemoglobin A1C 7 or less. As well, Wong at 2014 found that about 2/3 of the patients skipping testing because they feel the finger stick is invasive procedure and it caused disruption for their daily life and routines. So when we put this finding together, we see the same pattern happening. Low adherence, low glucose monitoring resulted in poor glucose control. And here where the CGM is becoming essential and not optional. So let me talk about why finger stick test falls short. Finger stick reading only give us a single number, like a static moment of time, where they don't show us the reality and what happened in the reality, like how the speed and the direction of the glucose to fall or rise, and what happened in between the events. This was supported by a study also, a very important study published by Bod and colleagues in 2005 about diabetes care, where they evaluated glucose pattern using continuous glucose monitoring in both type 1 and type 2 diabetes. And the finding was very clear. Traditional blood glucose tests miss a huge number of glycemic events between highs and lows, and because the patient only capturing a single data or single scattered points that not showing us the full trend. And this is exactly why we need more dynamic and continuous view of glucose behavior. CGMS help us see the full picture, not just isolated numbers. Wow. Okay, I designed this caricature, by the way. Yeah. So what CGMS can do? CGMS can change the scenario and make it more clear for the patient and for the diabetes educator together. Here in the first character, I put how it's confusion, the session, how much there is confusion in the session, and discomfort between the patient and the educator. And when we start using the CGMS, it reveals the full data. The patient don't feel like she's under pressure, and the educator don't feel like he's lost between numbers. Because a few years ago, I remember that I used to spend maybe half of my sessions just trying to connect the numbers together and see what's happening between. And with the patient's short memories, they will never be able to help in this. Here we see the difference between reading every 1 minute versus reading every 5 minutes. And if it is up to me, I want reading every second. Because a low glucose event can evolve rapidly, and the CGMS allow us to see early changes. So it literally changed the real-time to real-time alert to real-time safety. And this is very helpful and useful, especially for children, for adolescents, and for elderly patients who are staying together, or even with any patient at risk for hypoglycemia. Now let's look at the impact of CGMS on the hemoglobin A1C reduction in patients with type 2 diabetes. Across different treatment groups, whether they are on rapid insulin, conventional therapy, or basal insulin, or even without insulin therapy, CGMS constantly show meaningful improvement. Kroger at 2020, this study reported that about 0.9% reduction in the hemoglobin A1C in patients using rapid or short-acting insulin after starting a freestyle Libre system. Carlson at 2022 In patients only on basal insulin, this study was done, and it showed even greater improvement with the hemoglobin average, hemoglobin A1C average 1.1, which is clinically significant. And here I want to highlight how powerful time and range, how it affects the hemoglobin A1C. We're not, and the complication, we're not just improving numbers. Time and range directly linked to complication and linked to complication risk. There is a study done by PIC at 2019. This study validated time and range, a reliable clinical outcome in diabetes trial. It showed that increasing time and range is strongly associated with a better overall glycemic control. Versky, also in 2019, they demonstrated a clear relationship between the time and range and hemoglobin A1C reduction. And we can see, for example, the complication reduced by 64% lower risk for retinopathy, 40% lower risk of microalbuminuria. This is case study. Here I want to introduce a real clinical scenario. An 18 years old with type 1 diabetes since 2017. She's struggling with diabetes with emotional barriers and unstable glucose levels. This case shows how CGM device can be an empowerment tool. Let me walk you through the journey with this patient. First, we started with the barriers. There's one missing slide. It's okay. Anyway, so let me walk you through this part of the case because reality reflects what many of our patients are really suffering. We started with a clear initial barrier. First of all, we have to understand what is the barrier for the patient. We have to break the ice. Then we can start the journey with the patient. The patient refused the CGM and insulin pump therapy because of discomfort, fear, and anxiety. And this is something we see a lot with our adolescent and younger patients, especially in younger patients, because they are afraid to be overwhelmed or afraid from the idea that a machine will be attached to their body all the time. The most important point here is that the patient decision was fully respected. We never apply pressure. Instead, we work collaboratively with her and her family. Our intervention focused more on supportive education, peer discussion, and family involvement. We encourage the patient to do self-reflection, to identify her fear and what is the area she wants to improve. And with the time, something really good happened, that the patient begin to trust the process and gradually accepted the idea of using technology to support her diabetes management. This case reminds us that sometimes the wisest thing to do is not to push a device, but to build a trust and understanding and confidence and readiness first. And then the acceptance will come eventually. So after the CGMS adoption, and that was a patient choice, like we introduced all the CGMS available in the service, and her choice was up to her. So she chooses the small, it's CGM anyway, it's a small discrete device that replaced every 2 weeks, seamless smartphone integration and easy application to be used. AGP report showed improvement and stability and control. As you can see here, still we are in the beginning, but at least there is data that we can discuss with the patient, and there is a problem that we can identify and talk to the patient about it. In this slide, there is a further reinforcement on the improvement of the CGMS. You can see the time in range is 93%, 0 very high reading, and 1% very low reading. The daily profile also shows more stability and fewer highs and lows, and all bitter control. This visual evidence is often the most powerful and empowering for the patient and families when they see this. So I will highlight the key factor that changes the patient outcome: consistency and visibility, and support to understand the better rather than reacting to numbers. Educator perspective. From our perspective as a diabetes educator, one of the biggest shifts that CGMS brought to our practice is that it transformed our work from monitoring to mentoring and coaching. We are no longer data collectors, we became behavior coaches. With CGMS, we are able to replace guessing with a clear scenario and clear continuous data. This allows us to conduct shorter and focus more in the education. So it's more focused and shorter education session that really build the trust and interaction with the patient. CGMS also enabled data-driven empathy. When the patients see their own trends, the highlights and the lows and the overnight changes, this opens a conversation with the patient. And instead of giving instruction, we start encouraging reflection, like asking the patient, what do you notice? Why do you think this has happened? And how do you feel about this part of the day and how you can manage it better? This shift us from monitoring to mentoring is where the biggest improvement and engagement with behavior, and the patient behavior is improved. Maybe you are hungry, but I'll just wrap up quickly. The clinical impact. Let's wrap up the clinical impact on the CGMS. First, CGMS constantly enhances glycemic control and improves patient engagement. When patients can actually see their glucose pattern, they become more involved and more aware. Secondly, studies across different populations showed that hemoglobin A1C reduction of 0.4 to 0.8 can be improved. CGMS help patients achieve an increase in time in range about 15 to 20%, which is how it shows how strongly linked to fewer complications and better long-term care. And finally, CGMS transformed the role of educator, and we evolved from simple monitor to glucose reading members who guide through behavioral change. Thank you so much. Alice? You can go for lunch, by the way.
Good afternoon, everyone. Hope you all had a nutritious lunch. And welcome again to the first Emirates Diabetes Educators Society Conference. Thank you all for being here with us and for attending, especially on a weekend. Your presence literally means the world to us, and without your attendance, there's actually no conference. I would also love to thank all of my colleagues who spoke today. Thank you so much for sharing all the knowledge and information. But I believe the biggest thanks should go to the brain behind all of this, to the woman, to the mother, and to our amazing leader, inside out, our current president, Ms. Zainab Al-Abadli. First, I would love to congratulate you on your success in bringing us all together under one group. This lovely group of people across the UAE, whom I consider, and I'd love to call them, my people, my tribe. And I feel so proud being part of this tribe. And I'm so happy to get to know you all. Dear Zainab, I want you to know that I deeply appreciate all the effort that you have put in the past 3 years to achieve this. And I also understand that effort required time away from your loved ones, time away from your family, away from your own self, and away from your own health. This sacrifice truly means a lot to me, and I'm 100% confident that each member of this group is equally grateful for this. I can only ask God to always watches over you and bring you energy, love, and health for many, many years to come, my friend. Amin. In the next session, you're going to hear from 3 different dietitians who are also certified diabetic educator. They will discuss with you different cases across different life stages, where you will get the chance to witness the beauty of applying proper medical nutrition therapy combined with a twist of diabetes education. And so with no further delay, kindly join me in welcoming our first speaker for today, my dearest colleague, Ms. Salam Al-Saghir. Ms. Salam, she's a licensed clinical dietitian from the Department of Health in Abu Dhabi. She currently works in Burjeel Medical City Hospital, where she serves inpatient and outpatient. She's also a SCOPE certified, and she also holds the American Bariatric Certification for Counselors. In her talk, she will discuss with you the role of nutrition, not only with those who are diagnosed with type 1, but also with those who are diagnosed with type 2 diabetes post-organ transplant. I hope you enjoy her talk, and I wish you all the very best of luck.
Good afternoon, everyone, and thank you, Fatin, for your amazing introduction. So today I will be discussing type 1 diabetes adolescents from DKA to empowerment through education. Case overview. Patient is 14 years old, his weight is 52, his weight for age is 50 percentile, which is equal to BMI 20. Presenting symptoms: polyuria, polydipsia, severe fatigue, vomiting and abdominal pain. He brought it to ER via emergency services. Investigations: his blood sugar was 558, HbA1c 12.5, BH7, high ketones and moderate dehydration. His C-peptide was low, 0.36, and GAD antibodies positive, 75.4. Patient was admitted to BICU for immediate stabilization. Notably, there was no family history of diabetes, making this a new diagnosis requiring comprehensive family education. During his stay at hospital, first 2 days was treating DKA by giving IV fluids and insulin infusion. By day 2 to day 3, his BH improved to 7.1. By day 3, successfully, patient was taking insulin subcutaneous therapy with basal bolus regimen. By discharge, his total daily dose was established at 26 units, which equals 0.5 units per kg, and referred to multidisciplinary team. Identified challenges: family dynamics, strong family support present, but requiring structure, guidance, and education, as the patient was first one in his family diagnosed with type 1 diabetes. Emotional adjustment, processing a life-changing diagnosis during adolescence, life barriers, limit physical activity, and low motivation, even though the patient was doing before exercise 4 times a week, but still after his diagnosis, it was difficult for him. Social concerns, anxiety about dietary restriction, and maintaining peer relations at school. So his blood sugar glucose before carb counting, the AGB report showing 44% time in range, and 55% time above range, and 1% time below range. Education goals: a comprehensive staged approach to empower patient and his family with essential diabetes management skills, building understanding, develop foundational knowledge about type 1 pathology and about insulin role, teaching carb counting by mastering practical skills to estimate and tracking carb in his food, train on ICR and ISF to precise insulin doses, encourage physical activity, support emotional health. Why carbohydrate counting matters? Greatest impact on blood glucose. Carbohydrate raise blood glucose more rapidly and significantly than protein and fats. Precision insulin matching, accurate carb counting allows precise insulin dosing and improve overall glycemic control. Dietary flexibility and confidence so the patient can enjoy his meal while maintaining glucose stability and reducing anxiety. Safety and hypoglycemia prevention, reduce risk of dangerous low blood sugar episodes from insulin miscalculation. So the stages of carb counting, the stage 1 was about basic carb counting, one carbohydrate exchange will equal to 15 grams of carbs. That make the patient familiar with the food. Stage 2, estimating carbohydrate in complete meals and reading nutritional labels. Essential skills developed: add carbohydrate total across entire meal, correlate carb intake with blood glucose reading, distinguish between high and moderate carb meal options, read and interpret nutrition facts labels accurately. By stage 3, advanced carb counting, calculating personalized insulin dosing. This patient was taking 34 units, which equal to 1:15 carb ratio, and ISF was 50. Example, for his lunch, before his lunch, his reading was 220. By calculating his ICR, he needs around 4 units to cover his meals, and he needs 2 units for correction. So total administration of insulin was 6 units for this meal. Practical education tools, food models and visual carb cards. 3D representation of portion size help families estimate carb accurately. Measuring carb and spoons, essential for learning precise portions at home. Nutrition labels, exercise, practice sessions with real food package to build skills. So the progress over time, the patient was able from week 1 to week 4 to identify carbohydrate containing food and estimated portion using visual cues. By week 8, read nutrition labels independently. By week 12, count carb for mixed meal confidently. So as I mentioned before, the patient was doing regular exercise around 4 times a week. Now, after he was more confident about taking his insulin and carb counting, he wants to start his exercise. So we advised him if his blood sugar is less than 100, he should take from 10 to 15 complex carb, and he should take from 100 to if his sugar was from 100 to 250, he can do his exercise, but he should check it every 30 minutes, and he should use trend arrows. If his sugar above 250, he should correct his sugar before doing his exercise. So blood glucose sugar levels after carb counting. This AGB report is showing his blood sugar after 4 months from continuous learning about carb counting. He reached an excellent average of sugar. Time in range was 96%. Not only that, also after 1 year from continuous learning, he's still managing to keep his time in range above 90%, and it's showing around 4% time below range, which only because of compression hypo. And this big effort, it was because of carb counting and supporting of his family, as he was the youngest child in his family, and he was the only kid. He have 3 sisters, which they was showing a big support for him during the sessions. Take-home message for this case: understanding carbohydrate counting is key to manage blood sugar for type 1 diabetes. Choose the carb counting method that works best for your lifestyle. Healthy eating, regular exercise, and ongoing education are essential for long-term success. By going to second case, managing post-transplant diabetes patients. So this case happened in our hospital in Burjil Medical City. The patient, his age was 58 years, male, and his BMI 32. Primary diagnosis, cryptogenic chronic liver disease. Patient presented with decompensated cirrhosis and successfully underwent deceased donor liver transplantation. Illness history: no documented history of diabetes or hypertension prior to transplant procedure. Relevant laboratory investigation: his random sugar was 410, triglyceride was elevated 170, and elevated ALT 137. Post-transplant medication: this patient was having 2 immunosuppressant medications, tacrolimus and mycophenolate. Also, he was taking corticosteroids and insulin glargine 18 units, insulin aspart 6 to 8 units, TID. This showing his blood sugar before the intervention of nutrition. His time in range was 43% and time above range 57%. Contributing factors to hyperglycemia: corticosteroids increase hepatic glucose production and impairs glucose uptake tissues. Tacrolimus induce pancreatic beta cell dysfunction and decrease insulin secretion. Nutritional stress: after he was admitted to hospital, he should follow a specific diets which will go from clear liquid to full liquid until he will reach to normal diet. His physical activity post-operative inactive. Challenges in diabetes management identify barriers to glycemic control. Lack of prior diabetes education of glucose monitoring experience, emotional fatigue and anxiety about a new diagnosis post-major surgery, psychological stress about long-term dietary restriction, limited appetite and taste change post-surgery, muscle loss impacting motivation for activity. So the clinical goal was here, post-transplant diabetes. The goal was not simply lowering numbers, it was focused about protecting the transplant organ, maintaining nutritional status, supporting immune recovery, stabilizing blood sugar to reduce metabolic stress, because the success of the transplant depends on the whole body metabolic environment, not glucose alone. Role of the diabetic educator: early identification and communication, collaborate with the transplant endocrine team, and recognition of intervention planning, patient-specific education about medication timing, recognition of hypo and hyper symptoms, glucose monitoring support, guide daily self-monitoring of blood glucose of insulin administration technique, psychological support, provide reassurance, address fears, and support patient adoption during the critical transition period. Nutrition education, post-transplant diabetes management. Balance moderate carbohydrate intake. The goal is steady glucose, not aggressive restriction. Adequate protein intake, high protein intake between 1.2 to 1.5 gram per kg, which support wound healing, preserve lean mass, and help immune function. So normally, the patients or the normal people, usually we need around 0.8 gram per kg. But for this case, after major surgery, he needs from 1.2 to 1.5, which is difficult to get it by food only. So we added supplement, oral nutritional supplement for him with high protein. Focus on heart protective fats because the transplant immunosuppressant can increase lipid levels. So we used olive oil, nuts, seeds, fish, avocado also to limit, and we should limit deep fried items and processed food. Maintain stable meal timing. Irregular intake increase glycemic variability, hypoglycemia risk in treated patients. Sodium awareness. Some transplant medication can cause fluid retention, so sodium intake should be moderate. Low microbial diet, which knowing as a neutropenic diet, we use it for people who have weak immune system. It's mainly about food safety. So we should teach the patient about it. Wash your hands and allow all the dairy product to be pasteurized. Avoid cut fruits and cut vegetables. Avoid raw eggs. Drug food interaction. Critical education on safe handling of immunosuppressant interactive food, including grapefruit, pomegranate, and herbal products that may elevate medication metabolism. So his blood glucose level post-intervention, post-nutrition intervention improved. His AGP report after 3 months was showing time in range 76%, and his recent AGP report is showing 82%. Thank you all for it.
Thank you for the excellent presentation. I am honored now to introduce Aman Al-Halawani, talented, humble dietitian and diabetes educator. I work closely with her, and I can truly say that she shines in everything she does. Aman is a senior clinical dietitian at Al-Qasimi Women and Children Hospital and specialized in pediatric nutrition and diabetes education, certified diabetes educator, trained in Imperial College London, co-founder of the Pediatric Diabetes Clinic. Please welcome her to the stage.
Assalamu alaikum. I would like to thank you all for being here today, and special thank for the moderator for this introduction. It's always a pleasure to meet colleagues who share the same passion for improving diabetes care. So today we'll talk about the integrating medical nutrition therapy with the advanced diabetes technology to better support our patient. So from birth to balance. We'll identify the key nutritional and the clinical aspect of neonatal hypoglycemia and manage hypoglycemia in neonates using IV fluid, formula feeding, and medication. understand the early use of CGM and insulin pump therapy in infant, and apply management strategies for the newly diagnosed type 1 diabetes, and will use the case-based reasoning to guide medical nutrition therapy and diabetes technology decision, will enhance multidisciplinary collaboration pediatric care. This is our first case. It's congenital hyperinsulinism. 7 days old boy. He stayed with us. When he admitted to emergency, his blood sugar was 22. He had 3 episodes of seizures, each lasting 10 to 15 seconds with loss of consciousness. Baby was preterm, 35 weeks plus 5 days, born to GDM mother, and his weight gain velocity was high. His birth weight was 2.7 and current weight 3.3. Patient admitted with the negative ketones, high C-peptide, high insulin, normal growth hormone, normal cortisol, normal sodium and potassium. We start CGM on day 1. Patient was MPO, and they try to maintain blood sugar with the IV dextrose, but there is a persistent hypoglycemia. It's around 25 episodes of hypoglycemia during day 3. So we start oral feeding on day 3 at 9 a.m. This is the requirement from SBGAN for preterm infant. So we have to focus on carbohydrate. The total carbohydrate, we can reach it, is 17 grams per kg per day. So for our patient, we can reach up to 56 grams per day. But this one for normal preterm infant, so practically in hypoglycemia cases, we reach up to 20. And also we have to focus on the GIR, which is glucose infusion rate. For normal term infant, it's from 4 to 6, and for preterm infant, from 6 to 8. So if we need 10 to 12 milligram per kg glucose to maintain euglycemia, that means highly suspected congenital hyperinsulinism. So this is how to calculate GIR. The first equation is how to calculate it from the feed, and the other one how to calculate from the IV dextrose. Nowadays, there is a lot of online calculator, but we have to know the basics. It's used to assess and adjust glucose delivery, especially in newborn and the infant, to prevent hypo and hyperglycemia. This is our feeding plan. We start with the 20 ml 2 hourly. Usually for hypoglycemia cases, we go for 2 hourly feed, and 11 ml per hour dextrose solution, 12%. So here when we calculate the total GIR and total carbohydrate from our feeding plan, the total carbohydrate, it was 15 grams per kg per day. We have space to reach up to 17. And the GIR was 10.5. We have space till 12, as I mentioned there. As we can see here, the majority of the GIR and carbohydrate, it's from dextrose. So we have to continue review the CGM reading and respond to any alarm as needed, and gradual titration of the IV dextrose according glucose reading until stable level are achieved. We have to monitor the feed volume, tolerance, and ensure adequate energy, protein, and carbohydrate intake. For hypoglycemia cases, it's difficult to reach normal protein energy ratio because the majority of energy it's come from carbohydrate. So we have to adjust the carbohydrate load on glucose trends. This is the day 4. Still there is hypoglycemia. We increase both feed and dextrose, but we have to confirm hypoglycemia episodes using a glucometer before doing an intervention. Here we have to keep recalculating both GIR and carbohydrate during the hypoglycemia management period. So when recalculated again after this adjustment, Now it's reached 12.9. We exceed the amount, and the carbohydrate 18.5. So we start a gradual reduction in the IV dextrose, and to maintain euglycemia during IV weaning, we increase the feed to 30 ml to hourly. And here we start adding glucose polymers. Glucose polymers are complex carbohydrate made of multiple glucose units, provide sustained and gradual release of carbohydrate, lead to prevent hypoglycemia. It's supplement additives coming as the powder form. We start added 1 gram per feed, so 12 gram per days. Now also we exceed the amount. We can't exceed 19 gram per kg per day. So the doctor's medical support will start here. They start dioxide at 3 a.m. And when we start the dioxide, they start reducing in the IV dextrose. So we increase the feed to 50 ml, and we advise mother to add extra expressed breast milk to extra support. In day 8, night, they stop IV dextrose. Day 9, alhamdulillah, there is no any hypoglycemia episodes, and the feed adjusted to preparing the mother for discharge. So we adjust the feed to 3 hourly, so only 8 feeds per day. And on day 10, we reduce the glucose polymers to 4 grams per day, so for alternative feeds. We check the weight gain velocity was 18 grams per day. It's acceptable for hospitalization time. Now here, through the continuous glucose monitoring, we closely track the patient glucose trends with the gradual adjustment of the feeding and IV dextrose. We successfully stabilize glucose level and achieve this improvement. We improve the patient here from 22% of hypoglycemia to 0% of hypoglycemia from day 3 to day 9 with a gradual reduction in hypoglycemia episodes. So now the patient ready for discharge. We advise the mother to increase the feed up to 90 ml per feed, 3 hourly, and to stay in glucose polymers, 1 gram alternative feeds. And we advise her also to monitor blood sugar. If blood sugar is low, she have to confirm it by glucometer. If the baby awake, she have to give him half tube of the glucogel, which contains 7 grams of carbohydrate. And if baby unconscious, 0.3 glucagon injection, and she have to wait 15 minutes, and if still low, she have to repeat it again. Now we'll shift to our second case, infant with type 1 diabetes. Now our case is she's girl. She's 12-old girl. She attend with the 7.1 kg, less than 3rd percentile. She lost 10% of her weight during the last month. And she attended with the fever. She was fever for 6 days ago, and they diagnosed her with ear infection. She started an antibiotic, and the mother noticed that there is severe polyuria, and the patient increased fatigue in last 2 days. So she attended to the hospital with the moderate dehydration, moderate DKA. A1C was 10.4, and glucose high, blood ketones high. They start manage her in ER, and they shifted her to PICU. So we evaluate the patient jointly with the multidisciplinary diabetes team. Patient was MPO, and they start insulin infusion. And we start also CGM at that day. Usually healthcare provider prefer not to start CGM on DKA phase, as the sensor accuracy may be affected, but we expected that the patient will out of DKA within 24 hours, so to enhance comfort and to minimize the finger breaks, especially for this young age. Now patient out of DKA, we start oral feeding, 150 ml milk 4 to 5 times per day. Patient has less appetite, so she refused any food. She's only on the milk, and we start educate mother about food group, which food affected the blood sugar, and which food she need to give insulin before, which food she can give it without any insulin coverage, zero carb food. Now we start MDI. We start with 1 unit of long-acting insulin, and we increase it the next day to 2 units with microdoses of the diluted Lispro insulin. We dilute it with the normal saline. And here, as we can see, the blood sugar is high. Her blood sugar high because mother gave her milk and food without any insulin coverage. We have the challenge with insulin administration. Mother not satisfied with the diluted insulin because it's syringe and needle, and she feels it's painful for her daughter. So she requests to use half unit pen instead. We discuss with the mother because half unit pen is a quite large dose for her daughter. She usually wait until the glucose go up, as you can see here. Okay. And give her the dose after that. It's function as a correction, not as the carb coverage. So we plan for possible insulin pump initiation soon to find the tool basal rate according to milk intake and to manage small doses requirement for ICR and ISF. We start to prepare the family for the pump initiation. Parents attend an insulin pump workshop and they develop confidence with the daily use and management. We're using with them here the simplest carb counting method. They're preparing a list for child usual food, and we're writing for them the carbohydrate content for each item because it's limited item for her age. And we're teaching the mother how to read food, some food label. She brings some food label, cereals from outside, and we educate her how to read the food label. This is our first patient was started on an insulin pump at just 12 months of age, 4 days after diagnosis. This is the pump setting. We start with the ICR 1 to 50. We're using here 350 rule as ISPAD, preterm preschool age, and ISF 1 to 300 with total basal 1.7 units per day. May we require to increase the basal rate between 9 p.m. and 12 a.m. as the ISPAD recommendation, but for now we start with this basal rate, and we increase it and test it later if needed. Here, we see that in the pump, there is a lot of correction between 12 a.m. and 12 p.m. So the total correction was 2.8 unit. So we increase the basal rate from 0.05 to 0.1 unit per hour, and we reduce the ISF little bit to 250 to improve correction. Here we educate the mother to enter all carbohydrate events into the pump, into the sensor, for accurate insulin dosing and to facilitate pump setting and the adjustment, only for 2-3 days to adjust the insulin pump. Here we'll start with from the beginning of the graph. Again, we increase the basal rate from 9 p.m. to 3 a.m. 15%. Now the basal rate is 40% from total daily dose. And as you can see here, the blue circle show when the mother enter insulin into the pump. Sometimes it was giving bit late, so we advise her to give. So we advise her to enter the carbohydrate into the pump at least 10 minutes before the meal. And the red circle showing the mother give the food and the milk without any insulin coverage, so without policing, to build her confidence and to reduce this fluctuation in the pump. We increase the ICR little bit to 155, and we advise her to enter all carbohydrate into the pump to prevent this fluctuation. Now patient confident with the pump, we discharge her in the patch insulin pump. Patient weight less than 30 percentile, so we prescribe for her high calorie formula and give her follow-up appointment as usual within 1 week. but unfortunately, patient back to ER with the fever, poor intake, abdominal wall swallowing, and pus from pump sites. And all surgeons confirmed that the abdominal wall abscess, this is only case of an infected pump sites in our unit, and the wound healing and wound culture confirmed that the MRSA infection. This is the reading after infection. It's high, of course. So the pus drainage done while the pump was placed, but we changed the site. And our plan to initiate the sick basal mode in the pump. And we achieved good control with this sick basal, but despite achieving the good control with the pump using the sick basal, the parents' confidence with the pump decreased. So they request to switch back to MDI. We try to convince them that the pump will achieve better glucose control, but they refuse to continue. So here we explain for them that we may require to reduce the insulin doses within coming 2 days because we expected improvement as the infection-related insulin resistant resolved. And here 2 weeks data average, when the mother attended to the clinic for follow-up, when we asked her about the blood sugar, she said it's perfect now. But when we check CGM and AGB report, it's only 34% target in range. So mother have fear of hypoglycemia, leading her to maintain of higher glucose level, and she is unable to deliver very small insulin doses, also leading her to skipping insulin for some small meals. So within 3 months of education, we felt that MDI failed to achieve satisfactory glycemic control. With the improved confidence, the parents and the team decide to reinitiate pump again. Now she is on insulin pump. Weight improved, she is above 25th percentile. This is 2 weeks data average after the insulin pump. We haven't reached our final goal yet, but our rule doesn't stop at a certain stage. It's continuous process because every phase brings new challenges and learning needs. Our rules to observe patient closely, identify the individual needs, and to support them along the way. This is conclusion. Early glycemic intervention require personalized age-specific approach. Nutrition remain foundational even in the high-teach diabetes care. CGM under 2 years of age is off-label, but we found it very helpful to enhance parents' confidence and to support the clinical decision. Multidisciplinary teamwork is essential for sustainable glycemic control. And before I finish, I would like to thank amazing diabetes team. I'm really proud to be part of such caring and a supportive group. Thank you.
Thank you. Thank you, Aman, for the exceptional presentation. Actually, you covered the complex topics, 2 cases, and you made it sound simple. It was actually complicated and explained it in depth and very clear. Thank you very much. And for the next presenter, allow me to introduce Srila. She is a clinical dietitian, certified diabetes educator in Mint Clinic City Hospital, Dubai. She is a weight management program coordinator, specialist in advanced diabetes and critical care nutrition, also certified in insulin pump therapy, GLP-1 management, and scope obesity education. Please, the floor is yours.
Hello. Thank you so much, Samia. Thank you for having me over here, and thank you for patiently being over here all day. So we have gone through different kind of cases in terms of pediatrics and organ transplant. I'm going to talk about 2 adult cases. The first one we're going to talk about is a 25-year-old male diagnosed. Technically was planning to just do a health checkup and ultimately ended up with hyperlipidemia. That was the history past 6 months, and patient had already started on atorvastatin fenofibrate. Patient was overweight at a BMI of 29, but then by January the patient had lost 6 kgs. The GTT blood test was high, and this was all done in India and was also due to do a fibroscan to rule out any fatty liver. So when the patient came to the hospital, there were a lot of referrals that was happening ongoing, and eventually the patient reached the nephrologist. The blood test showed that the HbA1c was already at 9.3 with RBS at 12.3. Even the lipid profile was high. The glucose in the urine was almost 4+. The plan was to start with the CGM data first, start with insulin, Diglotec with Aspart at 14 units, and then meet the dietitian and the educator. However, so these were the medications that were started as well: saroglitazole, atorvastatin, folic acid, Zincovit, vitamin D, and methylcobalamin. At the first consultation, the CGM was fixed, demonstrated everything, settings was done, a 24-hour recall was done, and based on the recall, it was seen that the interpretation was the patient, however, eating homemade food, healthy food, but was majorly carb-based. Although the patient was a non-vegetarian, was eating chicken, fish, everything, but the majority of the food was always a carb-based food. There was no other habits of smoking or alcohol. Stress was extremely high. This patient was in an IT field, constantly screen time, constantly traveling. Meal timings were not that regular. The meal timings that were regular only was when he was at home. There was no other form of exercise. Initially, the patient and the family did not want an intervention, which is the usual case when they feel that they're eating home food. It's a very clean food, and they did not want any diet intervention yet. They wanted to try by themselves, and they left the clinic. However, we made sure that they had some education pamphlets, but the patient did come back in few weeks' time, seeing that looking at the CGM data with the sugar levels were on the higher side. The insulin was increased to 12 to 16 units, and titration was also advised. That's when we start with the lifestyle intervention, where we focused on stress management, how to make sure that the eating habits is taken care of when you're traveling, the time zones, exercise, how to incorporate the exercise, whether it's taking the steps, whether it is walking 10,000 steps, risky behaviors. Anyway, there was no smoking and alcohol, so that was taken care of. Sleep, this was another aspect that was discussed. Social support. So although the patient was 25 years old, the mother was very worried, and the mother was the main person in terms of the intervention, and she was worried that we don't want to talk about diabetes outside, so this needs to be taken care of by itself. In terms of nutrition, more live examples and culturally tailored foods were included, with a lot of food examples to ensure that the patient is able to adhere to the diet practices as well. Because what we have always seen is it's not one size fits all. It has to be culturally tailored. It has to be tailored to their lifestyle practice as well, and not the other way around. Nutrition labeling, because when the patient was traveling, a lot of foods were in the form of packets, so it was very important for the patient to understand how to read the nutrition labels in terms of serving size and sugars. In a month's follow-up, it was seen that the patient's AGP report target in range had almost reached to 98%, and there was 1 or 2 episodes of low where the patient ended up taking insulin but did not eat, and that was one of the reasons why the lows had happened. In 2 months' time, when the blood test was done again, the HbA1c reached to 7.7. The fasting had come down from 13.8 to 5.9, and even the cholesterol levels had come down considerably. Post-lifestyle intervention, from the doctor's aspect, the insulin had been reduced and the follow-up was recommended. From the dietitian's aspect, it was made sure that the dietary intervention, specifically the travel regimen, was taken care of, and exercise regimen. However, the patient has now gone back to India, so he has been following up over there. So that was my first case. My second case is 28-year-old lady at 29 weeks gestation. There was no past medical history for her. So this patient had an HbA1c at 6.4 with the second 2-hour post meal at 8.65. When the CGM data was taken into consideration, it was seen that the percentage in target was only 25% and 72% of the time her sugars were on the high level. And when the treatment was started, insulin Degludec was started at 6 to 8 units and titration was discussed. When a 24-hour recall was done, it was seen that the patient had taken a lot of high refined carbs and lots of juices. So this thought process that they have that having fresh juices is good during pregnancy, coconut water is good during pregnancy. So that was continued, although she was still eating vegetables and salads and also walking, but it was a pre-notion that she had. And specifically her sweet craving, she was a person who never used to have sweets or chocolates, but the moment the pregnancy tenure started and her sweet craving had almost shot up. The nutrition strategies that was explained. So here the focus was not just from the sugar aspect, but from a pregnancy aspect as a whole to make sure that the baby's nutrition is also taken care of. So first, the discussion was about what are carbs, what are not the carbs, what is the glycemic index of the carbs, so that how she can incorporate that into her diet, how she can distribute the carbohydrates throughout the meal timings. Even the eating method to begin with low fiber, low glycemic fibers, and then end the meal with carbs was discussed, replacing the carb meals with more of protein. The sweet craving was satisfied in terms of fruits, so that's one discussion we had, to have fruits and low glycemic index fruits were also explained to her, healthy fats. Besides that, we also had a brief discussion about certain nutrition requirements specifically required during pregnancy. That is the healthy fats for the baby's brain development, folate and vitamin B12, vitamin D, iodine, even the energy requirements and overall macros. In few weeks' time, so we were regularly having follow-ups. Certain follow-ups used to happen over phone just to avoid a lot of traveling for her. When the CGM data was seen that her percentage of target, so the moment she stopped her refined sugar, she started eating more mindfully, the percentage in target had reached 93%, where the target above had gone only to 7%. Her FBS had come down to 4. During this time, the Degludec insulin was stopped and the doctor had changed the medication to metformin 750 OD. Regular follow-ups were happening and ultimately the patient delivered a healthy baby girl at 38.3 weeks and the baby weight was 2.89. So practical takeaways in terms of this age group for me would be tailored carb portions, meal consumption is important, but however, it has to be culturally tailored in terms of their practices, their lifestyle routines, and CGM trends definitely helped even for the patients as a motivation of what is the difference that their diet is making. So the numbers itself made them understand that whatever changes they are doing, it does help, and that further motivated them to continue with the changes. So the key principle was one size does not fit all, whether it is diet, nutrition, whether it is even diabetes education. So the DSMES concept that we are talking about, the main aspect is all these education support has to be catered to the patient's needs, which builds a trust with them. And automatically it leads to a better adherence and quality of life. And that's, thank you.
Thank you, Srila, for the excellent cases about type 2 and gestational diabetes. And before, I'm happy to say that we are ahead of time. Before we go to the Dexcom, and allow me to call the guest speakers to join us on the stage for the certification.
We are kindly asking Ms. Salam Al-Saghir to come and collect her certificate of appreciation.
أمان الحلواني. Miss Rila. Before we end up, allow me to introduce Dr. Jalal from Dexcom. The next speaker is from Dexcom, Beyond Accuracy, the clinical value of Dexcom CGM. Please join me to welcome.
Hello. So, I actually work in Dubai Diabetes Center, and we're going to go over mainly Dexcom or the CGMS. All right. So I always have a presentation, since I work with Dubai Academic Health Corporation, that this is a private presentation, has no relation to the Diabetes Center. And so we're starting with this guy. And so the whole idea, you're going to have a lot of patients that at some point they're on insulin therapy, even on oral agent. And as you know, generally speaking, diabetes is a progressive disease. Over time it gets worse. Somewhere between 10 to 13 years after the diagnosis, you'll be on insulin therapy. And with our population, with a very healthy lifestyle that we live here, with everybody sleeping 3 in the morning, with very high carb intake, very few people do very well. And so this is a typical thing that you're going to see a lot of people running, very bad A1Cs, and you're getting 9 and 10s. And not related because there's something wrong in the disease, it's just really the lifestyle more than anything else. So if you have a patient like this with A1C of 10.1%, and they're taking DAPA because they have a heart failure on top of the insulin therapy. And of course, you would like to use SGLT2 with insulin because that, beside the cardiorenal benefit, there's going to be benefit that you're not going to need as much insulin, so you decrease the weight gain you're going to get with insulin. And that's, of course, safer. So if you get a patient like this, and they bring you a number like that, and that's typically what happens. So very common in the diabetes center, I see people who take in just oral agent, and they check 4 times daily, and I tell them you don't really need to check 4 times a day, but they insist to do it this way. And then I see people who take 4 shots a day, and this is why I get. Typically it's the other way, always. And so people will come and they bring you 2 numbers, and you're supposed to be so smart to be able to figure out what to do with the patient. And so if you have a patient like this who's taking basal bolus, can you make any judgment based on this? And the answer is no, because you really cannot. And so the idea is, can I have a tool where it's not going to only help me see the numbers, you're going to see how the life interaction. So typically when a patient comes on insulin therapy, there's a few questions you want to ask. Of course, their lows, how low they feel before they do anything, because that's may make you more careful about the lows. You need to ask about their work schedule. I have a lot of patients who are shift workers, so of course that's a big issue. And then if they're shift workers or not, you're going to ask them, when do you eat what days? Because you want to see the timing of this. To try to see, once you try to look at the readings, how you're going to adjust their treatment. So the first concept when you start looking on the continuous glucose monitor is what you call time and range. I'm sure they're all understand it very well, but the whole idea is we've been using the A1C as a holy grail. Now, of course, A1C is not the most accurate test, but we have so much studies based on it. It's well established, is well standardized, but we have to understand that a lot of things can make it falsely high or low. So you're going to have a lot of patients with anemia, high triglyceride could be a factor, low iron. So a lot of time you're going to have a reading that doesn't make sense. That's number one. Number two is the A1C at the end of the day is an average. And it's supposed to be 3-month average sugar, plus minus, based on the life cycle of the red cells, correct? So if anything will change the life cycle of the red cells will affect your A1C reading. On top of that, you have to understand that the last 4 weeks will affect your A1C more than the prior 4 weeks, for example, which means that it's not really an equal average 3-month numbers in a way. So if you're doing much better in the last 4 weeks, your A1C may improve much more than actually your average 3-month in a sense. But at the end of the day, I don't think this is a laser. Well, anyway, so what you can see here, that you can have an A1C and you have this kind of fluctuation, and you can have an A1C that's also 7%, but here the time in range is 70%, and here the time in range is lower. So the whole idea is that you may have a similar A1C, but you have a different reading. Now, your target to be this 7% and not the 7%. It's true that we look at complication from perspective of A1C, but we have a lot of data that actually when you have a significant glycemic excursion, you're still already at the risk of getting microvascular complication. Even for retinopathy, for example, is quite sensitive. Even if you get post-meals in the 150s, that already increases your risk of retinopathy. So I think it's better to try to see how high it goes after meal, try to get the good readings about it. So A1C is a good marker, but there are a lot of things, sometimes it doesn't make sense. So a lot of time I have patients who check quite often, luckily, and then when I look at the A1C and it doesn't make sense, I may order fructosamine, I may put CGM-S. I need to figure out what should I trust. Should I trust the A1C or should I trust the reading? The CGM-S, of course, widely used in type 1 and is getting more recognition in type 2. I'll show you some data showing benefit mainly in type 2. In type 1 is already established, there's not a question. And I think we need not only to focus on the time and range, you actually need to look at the whole thing, time and range, hypos, hyper, and I'll go quickly over that. So this is generally speaking that you need to have about 70% between 70 to 180. You're going to look to have less than 4% in the reading between 54 and 70, less than 1% in significant hypo, which is below 54, and you need to have less than 25% in the glucose of 180 to 250, and less than 5% in the glucose of 250. So generally speaking, in the vast majority of patients, this is kind of what you target. Now, saying that, you're going to have some other populations, so you may have a sicker or older cardiovascular patient, and you don't necessarily need to have them such tightly controlled. In this population, you want to try also to avoid hypoglycemia, and in this case, you put a tighter range to avoid hypo, which means I am accepting to have a glucose between 70 to 80, 50% instead of 70%, as long as I'm having much less lows, i.e. below 71%. And I'm allowing numbers over 180 to be about 50% of the time. So accepting this fact, because again, we know from older trials that a patient who significantly experience hypoglycemia, they have increased risk of cardiovascular event or death. Now, when you have a pregnant patient with type 1, of course you need to be type of control, and then you need to change the setting on the CGM-S. It cannot be 70 to 180. You change it to about 63 to 140. Now, this is kind of a general recommendation, and you want to have, again, 70% in range, but this range is different. It's much tighter. So it's, again, 63 to 140. You need to have preferably less than 4% in the sugar between 54 and 63, and 1% below 54, and 25% or less above 140. Now, as type 1 pregnant, again, it's sometimes very hard to achieve this, but again, this is kind of your target to try to achieve. Now, in a pregnant type 2 or gestational diabetes, they're much easier to control. And you see that. I mean, a lot of them, either with metformin or you give them just basal, and sometimes you may give them one meal and they're well controlled. And so you want to have, again, not a lot of lows, so about 4% in the 63, 1% below 54. And you need to have about 90% between 63 to 140. So you want them very tightly controlled. And actually, typically in gestational diabetes, again, the recommendation is supposedly 1 hour below 140, but actually I prefer, and with a lot of data suggest, actually even the 1 hour you may want it below 120. So if you can get them below 120, then that's maybe better even for the 1 hour after meal. because if you look sometime, especially with the kind of diet we eat, sometime if you check, if you do the 2 hours, it could look 120, but if you ask 1 hour, the patient could be 200. So with the kind of food, the high carb, I typically prefer the 1 hour for digestion. Now, there's many studies that look at, the efficacy within the sensors. Diamond, mainly, it's multi-dose injection patients, type 2 diabetes, that showed that, by using this comparing to finger stick, I'm able to improve the A1C. Now, each study, there was a little bit difference, one of them 0.4%, one of them 0.9%. Steno 2 Tech is mainly in the Steno Diabetes Center in Copenhagen, and again, multi-dose injection, patient taking CGMS. The second group of patients were using finger stick, but they had it blinded CGMS, which means they cannot see the result. And then mainly they download the data, and what you see that there was an improvement in the A1C, there was an improvement in time in range, an improvement in time above range. The mobile data, I'll show you this one. So again, this is a little bit different. So this is a basal insulin. They're not taking meal insulin, so they're taking basal plus an oral. So this is even a lower hypoglycemia risk population. But even in this population that has lower risk, they still have an improvement in the A1C. Now, both of them did have an improvement because they're now monitored. But you can see that this is, for example, the group that using the CGM, which is the bluer one, dropped from 9.1 to 8, so 1.1%, and this one dropped 0.6%. So there was an improvement in the A1C. There is an improvement in time of range. There is improvement in time above range. So you're able to have a better control. Then the second question, well, put the CGMS, I'll put the Dexcom in this trial, and then I'll do it for a few months, then I'll stop it, and then the patient knows what to do. And this is exactly what they did. So they treated the patient, this is the same trial with the extension. So they treated the patient for 8 months. Then they said, you know what, let's see what will happen if we take it off. And mainly the grayish kind of line is the group that discontinues CGM. And again, time and range goes down again. And the A1C start to go up. So when I'm trying to say, the device works as long as you use it. You take it off, you're going to lose a lot of data because especially it's very involved in treatment. And again, this is basal insulin patients. So you're not adjusting even insulin, but you're adjusting the lifestyle. You're seeing how different food affect you. Now this is kind of a typical report, so it'll give you kind of estimated A1C, above, below range. And so typically as all the cases presented by pharmaceutical companies, patients do better. I never yet presented a case by any company that the patient does worse, but anyway. So this patient did amazingly better. The A1C dropped from 11.1 to 7.5. But forget the A1C. Sometimes you may not see much improvement in the A1C. You're going to see improvement in hypoglycemia. And again, that really matters. So what do you get with Dexcom? Now, of course, you're going to have a continuous glucose monitor, which is very important. You're going to have remote monitoring, you're going to have real data. The warm-up is about 30 minutes. Now, you have other sites, so you don't have to use the arm again. So that's give a convenience in that sense. You can use it 2 years or older. And then it has this kind of predictable severe low. So mainly it'll give you an alarm, which is the other CGMS do not have. So it'll tell you that expectedly you're going to get a glucose below 54 in the next 10, 20 minutes. And actually they did a study called HypoDE or something like this, which showed significant reduction in the severe lows and actually severe reduction in the rebound hyperglycemia, because typically when you're going to get such a low, you're going to overtreat. So it'll tell you, you are going to get low. And you try to teach patients. So when a patient comes to you, you need to teach them that insulin or the meal insulin, because the population who take multiple dose injection are the one who has the most likely. So you need to teach them the duration of the action of the insulin. Most patients do not understand that the insulin lasts 3-4 hours. And again, second part on the insulin, the meal insulin, when you take a high dose, the curve shift of the insulin moves to the right, which means it lasts longer. So, the things you have to look at. So when a patient take a dose, they have to understand the duration. They have to understand that if the number is, let's say, 90 after 1.5 hours, they are going to get low because they're still, you know, in the first hour you may have 60% of your meal insulin. The second hour you have about 30%. So after 1.5 hours, you have like about half of the dose. You are going to get low. So they have to calculate the residual insulin so to avoid insulin stacking. So this also will give you kind of, or will give the patient kind of alarm to predict that. Now, this is kind of a typical report. I'm sure you guys are already dealing with that. And so typically, you have to go in a step approach so you don't get to lose any factor. So you have to see if they use it correctly, if you capture enough data, and then you need to see lows, highs, and recognize a pattern. So how do you know that you have enough data? So you have to look at the metric, and you need to have at least 70%. Now, of course, 75 is not good enough. I mean, you should be 80, 90% capturing data. And generally speaking, on this patient, you can see there's only very little low, less than 1%, and mainly they have a lot of high glucose. So the first thing you always want to do is avoid lows. So you look if there's enough capturing data, then you're going to say, do I have lows? What the percentage of lows? What the time of the lows? You're lucky if the patient document, because of course they can document the insulin and the carbs on the CGMS. You're lucky if they do, because that will help you also more. And then the same for the highs. So if you have a patient like this and you're trying to look at lows, typically, again, as you see, you have the cursor is very weird. So this is the 5 percentile, 25%. So you want to see this kind of 5 percentile if it's touching the 70 range, correct? Now here we're talking non-pregnant, by the way. And so hypo will be that, those numbers that seem to be crossing here and touching it. And you can see this patient is really not getting low. Now, the patient will tell you, I'm getting lows, but if you look at the numbers, they're not really low. They may feel, so they may have symptomatic low. Because, for example, like this guy, his A1C was 10, so even if you get 85 or there's a fast drop in the glucose, they're going to complain of a low glucose. The second thing, you're going to look at the hyperglycemia, and typically you try to look at the 75 percentile and try to see how much or where do I get above 180. You can see here the 180 range. And you can see that generally speaking, he seems to have higher numbers here. For example, above, after the lunch, assuming this is lunch. Again, this Abdulaziz does not live in Dubai, because in Dubai, this all does not apply. I have people who come to me to the clinic at 7 in the morning because this is the time they sleep. So every patient who's type 1 and a lot of type 2, I have to write their life schedule because it's so confusing for me. And then you can see here that also there's increase after dinner, and the patient eat quite a bit. And then typically what they do, either they eat very late just before they go to bed, which is not preferable, or sometimes they go high, then they do another correction, which you need to, this is typically what you see most people do it wrong. They go very high, they either correct or they take too late, then they get low, then they overtreat the low, they're high the next day in the morning. And so mainly, you're going to look at this and you're going to look at their documentation. You want to encourage the patient to document their insulin intake and carb. I don't expect people to do it every day on their life, because if I'm type 1, I'm not going to document everything I do every day. So at least I'll tell them, try to put a full documentation for a week rather than incomplete documentation for 3 months. So I'll get a full detail, they put everything, hopefully, and then they bring, and then you look at their numbers and you look at the pattern. I mean, this is generally speaking, so this is the layout of all the days. But I mean, you can see a degree of drop, so you need to figure out, for example, in this patient, are they taking anything here at 2 in the morning to drop? Because something is happening here. And this is not a drop of a basal. So if you're taking too much basal, typically you see a little bit of sliding rather than fast drop. So you need to see, are they taking correction factor there? Or maybe they're taking too much of meal insulin and they need more for meal, less for basal. You need to figure this out, number one. And you need to explain to them that if you're high, you need to calculate the residual insulin. So at the end, I mean, treating diabetes, and this is only the sugar reading part, it's very complex. You need continuous monitoring. You need to adjust for food and activity. Type 1, of course, is and some type 2 who are taking MDI is a whole different animal. It's much harder to control type 1 diabetes. To have CGMS like Dexcom is going to give you a very good insight. Patient should understand that they're not putting the machine for you, so they bring it to you, so you look at the numbers. They're doing it for them first, so they can see how everything changes minute by minute. And it's going to make them a little bit more engaged in the adjustment of the treatment. They're going to learn how different food affect them. Some of them will tell you, you know what, every time I eat a piece of bread, I can eat rice, potato, nothing happened. For me, I feel the bread's doing it. So they'll learn different things, they'll learn different food and things like this. So A1C is good, A1C still now is a standard, but it's not really as good of a reading for people who are taking multiple dose injection as though are not. And I think I'll stop at this point. Thank you.
Thank you, Dr. Jalal Nafash,
Thank you.
from consultant endocrinologist from Dubai Diabetes Center.
Yes.
Before we go for the break, allow me to call Dr. Jalal for the appreciation certification.
So, ladies and gentlemen, please let's welcome Ms. Sarah Ledhami. She is a clinical care lead from Insulet, and she will give us a talk about Smart Starts with Omnipods 5. The floor is yours.
Thank you so much. I might just use this opportunity to say congratulations to every diabetes educator from the UAE here today on this first conference, and Zainab is here. Well done and congratulations. It really is a milestone for the UAE to see, so it's this button, okay, to see this occurring, and I hope this just keeps improving from strength to strength. So today I'm going to be introducing you, many of you have already had introductions to the Omnipod 5, but as you know, we are around the corner from launching, and today's session is to give you an overview on our product, as well as getting you ready for how to begin your patients on the Omnipod 5 system. So before I dive into the Omnipod 5 system, I want to highlight one of the papers. There's been multiple papers that are now being published in respected journals that are consensus papers written from professionals that have been working extensively in the AID era. And this paper in particular is a consensus report that was combined as a joint diabetes technology workshop between the European Association of Study of Diabetes as well as the American Diabetes Association. And it's just a great read for all of you working with patients who are embarking on AID systems to understand what are the benefits of AID, and I'm sure many of you know that AID systems are now really becoming the standard of care because of the improvements that you see in glycemic control, the improvements that you see in time and range, reduction of HbA1c, but also what to consider that may be challenges for you when you're putting patients on AID systems. So things like what kind of training do your patients require, how long will training take, what kind of troubleshooting do you need to be considering, as well as considerations for special circumstances like exercise, and of course Ramadan is around the corner, etc. So it's a great read. Now diving into the Omnipod 5 system and its overview. So I want you to bear with me. So there's quite a few components here, but really we do still follow the theme of simplicity. What you may know as Omnipod Dash is still going to be the same with Omnipod 5. So for example, when you look at the pod is going to continue to be the same size, the same weight. It's going to have the same user friendliness that all our patients have learnt to love, which is being tubeless, being waterproof. So this continues. What is going to be different is what is inside the pod. So the pod will now house what is called the Smart Adjust technology. So these pods are going to be different pods from the Dash. They're going to be specific pods that has the algorithm inside the pod, and the algorithm is only inside the pod, so it is not in the controller, as I will come to in a second. So Smart Adjust technology is built inside the pod, and it will communicate with the sensor of choice. So your patients will continue to have the flexibility to use the sensors that they have enjoyed using, whether it's a Dexcom G6, a Dexcom G7, or a Freestyle Libre 2 Plus. The algorithm is going to be helping correct from the highs, the lows, by adjusting insulin delivery every 5 minutes in terms of what we call a microbolus every 5 minutes. Now the Omnipod 5 app is going to be housed on the controller. So as you see in the picture here, we have the controller over here, and this is what will have the Omnipod 5 app built into it. So you will be getting some more and more guidance from us as we get closer to the launch on how you onboard patients so that they can log into the Omnipod 5 app. And that will involve creating an Omnipod ID and basically creating your username and password, and then they'll be able to log in with that username and password to then have the controller open to enter all the settings that they will require. Another great feature of the Omnipod 5 is that it will have customizable targets. So I will go into targets being the driving factor of the algorithm. This is the direct factor that will affect the algorithm, but the beauty is you have the option to customize targets over a 24-hour day. So if you have a child who parents may fear hypoglycemia while they're at school, you can raise the target during the school hours. Likewise, you may have someone who has a fear of hypoglycemia during the night. Again, you can raise the target during that time. But otherwise, when they're awake or when the child is with their parents, they have the ability to use the lowest target. The lowest target is the 110 target. So we have targets, 5 different targets that go up by 10 milligram increments, starting at 110 and going up to 150. And as I mentioned, you can create up to 8 different time blocks throughout the 24-hour day. Now, the calculator is different to what you may know with DASH. The calculator is now called a smart bolus calculator. And why is it smart? Because you will be able to integrate the user's sensor as well as the trend arrow of that glycemic reading to adjust the bolus delivery for the meals, taking into consideration the trend arrow of that CGM reading at that given time, as well as the activity feature, which can be used for times where there may be increased risk of hypoglycemia. So just so you can get an idea, I'm not going to go into too much details about this, but those that are using a G6 and a G7 sensor, let's just talk through the arrows here. So every 5 minutes, a sensor reading will be sent to the pod. And the pod is then going to get that sensor reading as well as the trend arrow and the prediction 60 minutes into the future to be able to deliver a micro bolus every 5 minutes. So the algorithm inside the pod determines that, and it delivers the micro bolus, and this information is then fed back to the controller. The controller is also what's responsible for showing the glucose readings from the Dexcom G7, as well as giving any alerts, giving any notifications, etc. And of course, from the controller is where the patient will be giving their boluses. So just like they would with DASH, you have the controller to be able to do that from the bolus button that you're used to using. Now you still see the Dexcom phone app as well, and that's because patients are still required to use the Dexcom application on their phone for activating and deactivating their Dexcom sensors. So everything still happens from the Dexcom app for them in terms of sensors. So the sensor activation, the sensor deactivation, alarms and alerts are still happening from the Dexcom app. So that's the communication via the arrows shown. Of course, any data that goes to the controller then goes to the Insulet cloud, and that's also where your data management system will be in place. Now, with the Freestyle Libre 2 Plus, it is going to be slightly different, where activation and deactivation is happening directly from the Omnipod 5 application. So in this case, there is no application from the phone, like the Libre application. Sensor readings are still going to the pod as you would normally see with the Dexcom, and the communication from pod to controller. However, this time you can see there's no phone, everything is activated and deactivated from the controller. And just in case the patient's pod falls off, or for whatever reason they are not using the pod but they've activated a sensor from the controller, they can also be in a sensor-only state and continue the life of that Freestyle Libre 2 Plus sensor while using the Omnipod controller for up to 30 days. Okay, So this is what the home screen would look like when somebody is in automated mode versus when they're in manual mode. In automated mode, you will notice the purple coloring. You will notice the top right corner mentioning automation with the symbol in bold, the square box around the glucose reading also in purple. However, in manual mode, you will notice that everything becomes blue, there is no box, and in the top right corner, it says manual. So in order to have automation, you need sensor and pod to be connected. So that ensures that automation will be occurring. And automation, as I mentioned, is adjusted every 5 minutes. And there is no need to disconnect at any point as it's waterproof. So showering, swimming, etc. is continuous. When in manual mode, however, the insulin delivery will be based on the manual basal program that would have been put into the controller at the time of initiation or as you update it with follow-ups. So that's the main difference there. There are also some differences in what features you can use in automation versus what features you can use in manual mode. So for example, if you go into the menu button on the controller, you will see in automation the temporary basal feature has been grayed out. So people who are in automation no longer need a temporary basal because the automation every 5 minutes is taking care of any rises in glucose that are happening or any potential risk of hypoglycemia. The system will pause delivery if it needs to pause delivery. So no suspension, no temp basal. However, what replaces that is activity mode. So if somebody wants to embark on any activity that may cause hypoglycemia, then they can activate the activity mode. And then in manual mode, they will have all the features that they would have had as they did with DASH. So temp basals are activated and extended boluses are present. Let's go a little bit deeper into the Smart Adjust technology. So the Smart Adjust technology, which as I mentioned is built into the pod, relies on 4 contributing factors. So the first one is an adaptive basal rate. And this adaptive basal rate is renewed with every pod change. It will also depend directly on the target glucose that you are using. It will take into consideration insulin on board and of course the sensor value that is coming to the pod every 5 minutes. Now, the adaptive basal rate, this is known as the total daily insulin, or it factors into it the total daily insulin. Now, on pod 1, this is a unique pod because the pod doesn't know the person doesn't yet know the technology. So you can say pod 1 is a getting to know period. In this stage, the physician or HCP is assessing the initial insulin settings. So you as a healthcare professional are using the total daily insulin that a patient may be on, if there are multiple daily injections, looking at how much basal and how much bolus they are using, and approximately 50% of that total daily insulin is then used to be factored into the manual basal program. Again, this comes back to your discretion on how much you want to be using, but as a guide, 50% of the total daily insulin. And then from there, the active basal program will estimate the total daily insulin for pod 1 and an adaptive basal rate will be established, and then this is going to be in a restrained form for pod 1. So automation starts from pod 1, but in a restrained form because it's collecting that data over that first pod, specifically 48 hours and a pod change. So if a patient is wearing the pod for the full 3 days, all they needed was that first 48 hours, even though they're wearing it for 72 hours, the first 48 hours of data and then a pod change will allow them to then have full automation, as in full capabilities by pod 2, which means the system is able to give its full aggression if it needs to. It can deliver up to 4 times the adaptive basal rate. So pod 2 will have a new adaptive basal rate and then so on as pods continue. It's using the last total daily insulin average of the last pod, but it also factors in the last 4 to 5 pods. So it's never just using only the last pod, it'll take into consideration the pods even before that. And that's because of situations where a patient may be sick for 3 days, and if they're sick, their insulin requirements have gone up. So it's unfair to just use that last 3 days as the total daily insulin average. We need to factor in some factors from the previous pods as well. So to give you an example, in the first box, you've got someone who's growing, so insulin needs are increasing. So in children, you'll notice that their total daily insulin as the months go on is increasing because their basal requirements are going up, their bolusing quantity has increased, and so adaptivity is increasing based on that total amount of insulin that the patient is using. Likewise, there may be situations where adaptivity may need to decrease the adaptive basal rate, and that could be someone who's embarked on a lifestyle change, they've lost weight, they're exercising more, they're requiring less and less insulin, so adaptivity will also be affected here and it will reduce the adaptive basal rate. Now, there are some factors that indirectly also affect the total daily insulin. So we said the glucose target is the main driving factor of the algorithm, and that's going to affect the total daily insulin. However, the smart bolus calculator settings can also affect. So the things like the insulin to carb ratios and correction factors can also affect. So if you've strengthened a carb ratio from a 1 to 20 and now you're using a 1 to 10, it means that the bolus amount is going to increase, and that's going to affect the total amount of insulin that's being delivered, which is going to affect the adaptive basal rate for the next pods. So just to keep in mind that indirectly you can also change the total daily insulin and affect the adaptivity by changing the bolus calculator settings as well, but only after you've already considered the target glucose as the driving force of the algorithm. So target glucoses, as I mentioned, directly impacts the algorithm. We have 5 different customizable targets. And just to give you an example, you know, of how it works, like how you can customize it for your patient. So in box number 1, you might have a lower glucose target overnight, with a higher glucose target during the school hours. Example number 2 is a higher target glucose with a lower target glucose during the daytime hours, and turning on activity feature for times where, you know, there's increased activity and increased risk of hypoglycemia. And then the last one is someone who says, no, I want to use the lowest target all throughout the day, but I'll use the activity feature when I need to. And this is going to show you a bit of a simulation of how the microboluses, so what you see down the bottom, are individual microboluses. These purple lines with little purple circles on top is like the lollipops, we call them. And you can see how the lollipops increase and decrease. So when you see it, when you see the dots right down here, this is pausing of delivery. And then, you know, potentially up here is where you're maximizing delivery, same with over here. So I want you to see what happens when the CGM is moving along. And the target here is 110. So if you correlate that down to the bottom, you'll see how delivery is being paused as it reaches the glucose target. But as it's expecting hyperglycemia to occur, it's ramping up and delivering more insulin and then as the glucose level is coming back down again, it's pausing delivery as well. So it's predicting rises, it's predicting lows, and it's delivering microboluses every 5 minutes based on that sensor reading, the trend, and the prediction. Now, all the data, as I mentioned, goes to the Insulet cloud, and because of that, we now have a lot of real-world users. Like we've got, you know, tens of thousands of patients that are on the Omnipod 5 system, and so we're able to start looking at behaviors, we're able to start looking at cohorts. So in this cohort, looking at the European cohort in the UK and Germany, we needed obviously 90 days of data and sufficient CGM data to be able to classify this cohort, but we were comparing approximately 15,000 users from the UK and 6.5 from Germany, and looking at what kind of targets are people actually using. So we don't know anything about their baseline A1Cs or anything like that. We just know what they're selecting as targets. And as you can see, in the first column, we have the 2 to 5-year-olds over here. So the 2 to 5-year-olds, only 18% of them in this cohort are using the 110 target. And you can see there's a bigger percentage using the 120 and the 130 glucose targets. And I guess that's understandable. You're talking about a very small, young population where there may be fears of hypoglycemia. But that's just to show you that as the group increases in age, so children going into adolescence and going into young adults, more than 50% of the users are using the 110 target, but not all of them are. So we're learning from the experiences from the UK and abroad that using the 110 target is actually going to give you the best outcomes, because we know that if you use the 110 target, which shown here is the dark purple line, the time in range is highest when using the dark purple line versus when you use the 130. And the same thing in the German population as well. So definitely want to encourage using the highest target if you feel there is no sort of reason not to use it. And this was also seen while using the highest target, that this had minimal impact on hypoglycemia. So there should be, again, that reassurance in the majority of your patients that you can safely use the 110 target without impacting hypoglycemia. So the bolus calculator, again, some of the same settings that you would have been using when starting patients on Omnipod DASH. So things like your target glucose, your correct above, insulin to carb ratio, correction factor, duration of insulin action, reverse correction, and minimum glucose for calculations are still going to be set when you initiate patients on Omnipod 5. And this will only be needed when they are bolusing themselves. So when they do their own manual boluses for meals or their own initiated corrections, which you know they can also do in addition to what the algorithm is doing, these settings will be used to calculate that dose. So this is irrespective of the algorithm. The algorithm does not need a correct above. The algorithm does not need an active insulin time. The algorithm has its own factors for that. This is for the calculator. And again, we're learning from the behaviors of patients, and I'm sure you would all agree with this, is that those who do not bolus don't have very good outcomes when it comes to time in range and HbA1c. We need to encourage patients to give boluses pre-meals, and actually none of the systems at the moment say that you should not be pre-bolusing. We should still be encouraging patients to give a bolus pre-meals. So those who are bolusing 4 or more times per day are having better outcomes when it comes to their increase in time in range. So definitely those that are bolusing for their main meals or significant carbohydrates meals need to be encouraged to do so, as this is resulting in the best outcomes for them glycemically. And with the smart bolus calculator, so remember it's smart because it's using the sensor reading. So the patient has the option to manually enter the glucose reading based on what's seen on the controller. But if they press the use sensor button, it's drawing in the reading from the Freestyle or the Dexcom based on not just the number, but also the trend. So if a patient is trending up, so they're 120 and trending up, the system has the ability to suggest a bolus amount of up to 30% more. And if they are trending down, it has the ability to decrease the bolus amount even down to 100%. So if they've already got a glucose reading, okay, so basically it's a smart calculator. Custom foods, I can't not spend at least 30 seconds on this just to say we're trying to simplify carb counting. We're trying to eliminate even the word of carb counting being essential. Carb awareness, absolutely, but your dietitians have a fantastic job of making custom foods a very useful tool, and 50 foods they can keep in a library, small, medium, large, or individual foods. And that's just to show you an example of what the screens would look like. And if they miss a meal, they do not pre-bolus at all. This slide is to show you that micro-boluses are being delivered over a 3.5-hour period where a patient, 9 a.m., started their meal, they didn't bolus for it, but still the system delivered 10.35 units of insulin to try and get the glucose level down. Obviously, if they had pre-bolused something, it would have been better than not pre-bolusing anything at all. But to show you what happens when you don't pre-bolus at all. Okay, activity feature, this is more for exercise. It raises the glucose to 150 so that it reduces the risk of hypoglycemia. Our data management system, which is called Discover. I'm going to skip this one and go straight to Discover to show you what the screens would look like. So going straight into here. So this is an overview of the summary page, going into the daily graphs and the settings, and our team is going to be coming to you in the coming weeks to discuss setting up your professional accounts and ensuring that you have that seamless transfer of data to your patients in order to view these reports as well. So just ending with expectations. So, remember, You know, in order to maximize the use of the system, you want your patients to be wearing a pod and a sensor in line of sight. So positioning of the sensor and the pod, we've been covering that in our trainings, is very important to ensure that there is no limitations in connectivity between sensor and pod. So no need to disconnect, obviously, for showering and bathing. Patients, setting realistic goals, ensuring that your patients understand that the first pod, while it's already in automation, is working in a conservative manner to get to know the patient. Optimization of settings may be required, so how often are you following up your patients? And time in range should improve over time, so try not to trick the system. There's no need to enter fake carbs or ghost carbs or anything like that in this system. Bolusing pre-meals is still heavily encouraged still, and self-management, knowing how to respond to alarms and troubleshoot, which is really important as well. This is just an example of where positioning of sensor and pod can happen, but basically same side or same plane. So you could have a Dexcom on one side of the stomach and a pod on the other side of the stomach. This is considered same plane. Or you can have a Libre on your right side and you can have a pod on the same arm as the Libre, or even on the abdomen on the right side as well. So just showing you the positionings of where ideally you should be putting your sensors. And finally, ending with some resources and tools that we will be sharing with you, such as the Panther tool. And this Panther tool is basically going to help you in how do you calculate your settings, how do you adjust, how do you, when it's reverted back to manual, why is this happening, why are patients having to troubleshoot constantly these things, and of course the sensor information as well. And I thank you very much.
Next symposium, company symposium, we will welcome back our colleague Shakir Abu Samhadana, Senior Diabetes Educator in SSMC, where he will be talking about Medtronic symposium. It's actually, he will be talking about not all algorithms are the same. You have 15 minutes, Shakir, please.
15 minutes?
15,
15, I think. So, good afternoon, everyone. I'll try to make it as short as it should be, because Sarah took longer than expected. But it was nice. It was nice, thank you. So, I'm just going to present about another pump that's available in the market. And before we start that, I think there is no one size fits all. So there is different pump and then different users. So the Medtronic pump has its user, the Omnipod pump has its user, and us as diabetes educator, we need to be fair and educated enough to choose the best device versus our patient. So in the agenda, we're going to speak about the SmartGuard algorithm and how the 780 algorithm work, and we'll speak about the algorithm comparison and outcome comparison as well. So, sorry, oops, back, sorry. Yeah, so the SmartGuard algorithm. So, the most features that 780 insulin pump from Medtronic has it, they have something called adjust and autocorrect. And what that mean? If you just look for this picture, here is the blood glucose level, and here is the green parallel here is the auto-basal correction. But because the pump that's seeing that the blood sugar is raising up, the algorithm, smart algorithm, think and decide this is not enough and we need to give a correction. So instead of automated insulin increasing, also there is another small boluses, goes every 5 minutes to get the blood sugar to the target. So the target is usually as low as 100%, and automated give more insulin earlier, often till the trending going to the normal level. And it is fully automated, so the patient does not need to do anything about this. And the automated and the algorithm will think about this to give automated basal or autocorrection every 5 minutes, which is end up with like 288 boluses or autocorrection per day. So in the smart mode, there is two things. There is things done by the algorithm itself, and there is another settings designed and adjusted by the patient. Auto-basal, it's by algorithm. So the patient has nothing to do with auto-basal. It will be calculated every single day at 12 midnight. The insulin pump algorithm will calculate the basal and will adjust it every 24 hours. Autocorrection will be changing every 24 hours. They will calculate the total amount of insulin divided, how we calculate the insulin sensitivity and carb ratio, and this will be updated every 24 hours. Insulin sensitivity factor, it is automated also. It's done by the algorithm. I know when we set up an insulin pump, we put insulin sensitivity and we put carb ratio, but that will be active only during the manual mode. Once you activate the smart guard, those will not be used anymore. It will be instead the insulin sensitivity and the carb ratio that changeable every day. It will be used. So what clinician can do or change in the algorithm, they can change the carb ratio. Actually, the only thing that we can play around in automated and guarded mode is the carb ratio. We can look, and there is many studies that prove that we need to intensify the carb ratio, and it shows a lot of improvement when it came for the good glycemic and more time in range. Auto basal target. This is also designed and edited by either patient or healthcare provider or both together. And there is a few study, new study. Before they used to say put it 120, but more studies are now coming out. They say you need to put it 100. We need to intensify insulin delivery and able to make time in range higher than the expected or more than we need to increase it. And the active insulin time, this is one of the debate settings that insulin pump company, they debated. So some people, they say put it 4 hours because the physiological structure of insulin lasts for 4 hours. But few studies say we need to intensify, we need to make it 2 hours. And the reason behind that, if we put it 2 hours, the pump will give us more auto bolus correction. So it will give more auto bolus correction, and that will get the blood sugar in the target faster. So active time insulin impact in the delivery at correction. It's not directly correlated with pharmacological dynamic of the insulin, as I mentioned, because if you look at the pharmacological dynamic of insulin, it says 4 hours. But if you notice that patient after 2 hours of the correction, they don't have any difference between their reading. It's very slow or very minimum. So instead, the 2 hours is recommended now, and it is evidence-based. It is the idea to put it 2 hours is just to give the autobolus faster and more, and they will give autocorrection slowly till the blood sugar become normal. And now we're going to speak about the Minimed 780 algorithm, how the pump think. So it's 5 components. So every day the insulin pump will collect the data from the pump and from the sensor. And it will collect the data as well from the bolus calculator and bolus amount, safety modules, and safe correction or safe meal bolus. I'm going to discuss in detail the most important part, which is insulin pump 780 superior with other pump in the market so far, about the safety modules. So what is safe module is? So before the insulin pump give any correction, it will go through, the algorithm will take this number and will think about, does the next bolus might has any risk of hypoglycemia? If the answer is yes, the pump will detect and will reduce up to 25% of the next bolus, and will keep monitoring the blood sugar trend and arrows till to keep the patient safe and within the normal target. And another thing, it's meal detection features. Sometimes a patient forgot to enter the meals, and the algorithm detect that there is carb entry without announcing. And how they detect it? Detect it because they see the arrows sliding up, and they know the changing between blood sugar is going so fast. So it gives correction, meal detection correction. And the last one, safe meal bolus. This is when the patient announced the bolus. So if the blood sugar is 125, and the patient announced that he's going to eat like 60 grams of carbs, and there is and the blood sugar is heading down, the algorithm will think about the next 4 hours. If there is a risk of hypoglycemia, if we give the full dose of the insulin for the 60 gram of carbs, if yes, it will reduce 25% of those insulin and will deliver the remaining. And we'll keep monitoring that patient. If the blood sugar within the target, it will not give the 25%, but if there is shooting up, it will go back for another category, which is auto bolus correction. So safe correction bolus action. This is how it's gone. Okay. So this is. So the blood sugar was normal, within the normal, and the blood sugar, this is the autobasal, and here the pump starting feeling the increasing of blood sugar, and here starting the autobasal correction, auto bolus correction to add it. And here when it reached to this point, there is, when it reached to this point, the algorithm, the number goes to algorithm and being analyzed. And there is 2 options. If they give 0.5 unit for the next 4 hours, there is no hypoglycemia risk. If I give 0.75 unit, there is a risk to be in the normal, but there is risk to be hypoglycemia after 4 hours. And if we give full 1 unit, there must be hypoglycemia. So the pump always will go for the safe side, and it give 0.5 unit. But it will keep checking this algorithm every 5 minutes to prevent any hyperglycemia. Okay. And this is the meal detection feature built on the Safe Guardian. So here, the patient announced the meal. And here, giving the auto bolus correction, but still the blood sugar is higher than the normal. Here, the pump, it will add another bolus to get the blood sugar to the normal side. Okay. So, current past glucose trend are used to detect presence of the meal. The past meal is detected to relax the bolus reduction from the safe bolus calculated features. So it will calculate if there is any risk of hypoglycemia for the next 4 hours, it will reduce. If the detection of hyperglycemia for the next 4 hours, they will increase the doses and they will keep running this algorithm every 5 minutes. And this is the safe meal algorithm. So checking bolus to see if they can potentially lead to hypoglycemia and use the prediction to predict glucose trend that may result from the bolus meal. And if hypoglycemia is a predict, the meal bolus is reduced by 25%. And the data that collected by the algorithm came from recent carb entry, current sugar glucose, and current rate of change. The most important actually is from the current change of the blood glucose. If the changes is very fast, then here the algorithm will decide to reduce 25%. So if now we're going to do the algorithm comparison between the available pump in the market here. So we have now in the market Omnipod 5 and SmartGuard 780 AG. So if we go to the autobasal delivery, it's fully automated in both, but in 780 the target is as low as 100, and in the Omnipod the target either between 110 to 150. You can choose any number, and the increment can be every 10. So it can be 110, 120, 130. And the optimized delivery, the frequency every 5 minutes in the Omnipod, in the 780, and 100% calculated dose to be 120. So it's 100% always the algorithm will calculate the amount of bolus to be 120. In the Omnipod, there is no autocorrection. There is something called automated basal. Okay. So the setting insulin carb ratio in the 780, active insulin time recommended 2 hours, autobasal recommended 100. The recommendation in Omnipod, the insulin to carb ratio, autobasal target, and correction factor. The thing is that the target, it can be one target in the 780. And in Omnipod, you can have multiple targets. There is one study said that if you have multiple targets, they might have other way around result. Because I'll show you now a study showing that if you have 100 targets, you will have better glycemic control. Sorry, 1 minute. So this is the difference between the 780 and the Omnipod. So here the difference. There is, imagine this patient. So here the automated basal starting here, and still the blood sugar is rising up. So here the pump decide to give an auto bolus plus the auto correction, whether we cannot see it in the other pump. Outcome comparison. There is real data comparison. Back. This is a real weird data comparison where they calculate all user of pump, whether to intensify the setting or not. So the time in range in 780 is 75.8, and the time in range in the other is 64%. User in range 62% all settings versus 86% 3.3 for the people who intensify the settings, which is 100 targets and 2 hours active time. Another comparison. Can skip this. So what does so why we are keen as a healthcare provider to reduce those 10%. If you look here, if they compare two group of people, they use Omnipod, and the other people, they're using 7080, and they found that time in range increased by 8% with people who are using 780. And for us as a healthcare provider, why it's matter that we increase the time in range for 10%, and this 10% higher than in the 780 because of three things. One, time in range contribute that the target is 100, not multiple target. The second one, the auto correction bolus. The third one, that they use only one target, where the Omnipod, they're using multiple time in range. So for us as a clinician, why is it very important? Because when we say 10% higher time in range, mean that mean 2.5 hours, 36 days, and that will reduce lower incidence of retinopathy, macro complication by 19%, lower incidence of cardiovascular accident by 25%, and the lower microvascular complication by 17%.
Shakir, can you conclude, please? Okay.
Thank you.
Excellent. Thank you.
Trying my best.
Thank you for presenting an amazing talks about pumps. Always pump will give hope for patients living with diabetes and increase their quality of life. Thank you. It's my honor to call Dr. Bashair Musa, Associated Professor from University of Sharjah, and Ms. Nabila from Imperial College London to moderate the last session of today about research innovations. Please, the floor is yours.
Good afternoon, everyone. Thank you very much for being here till this time of Saturday evening. We really appreciate that. And the good news is that we're going to talk about something that will stimulate your brain and stimulate your critical thinking. We will be talking about research and how research is very important in innovation. Today, I think I'm very happy to co-chair who is Ms. Nabila. And we have three amazing presenters who are interested in research. The session will run for about 40 minutes. We'll try to be on time. Each presenter will have about 12 minutes and 3 minutes for questions. We'll take one question from the stage, one question from the audience. And after that, we will discuss how great they did. So it gives me a great pleasure to start with the first presenter, Dr. Muiz Azzam. He is a pediatric endocrinology fellow from Al Jalila Hospital, Jalila Children's Hospital. Welcome to the stage.
Good evening. Hi. Thank you for the introduction, and thank you for giving me the chance to speak here today. I'm Dr. Muiz Azzam, and I'll be presenting my findings on evaluating the effects of GLP-1 agonists in pediatric patients with type 1 diabetes. Just a quick disclosure, this data is unpublished, and please refrain from taking pictures. It's going to be published soon, inshallah. So as we know, type 1 diabetes is characterized by absolute insulin deficiency due to autoimmune destruction of pancreatic beta cells, and that's what led the scientists over the last tens of years to focus mainly on compensating this deficiency by compensating the types of insulin. And despite the advances in treatment and monitoring, according to a paper published in the United States in 2019, less than 20% of patients with type 1 diabetes achieve their glycemic goals. On the contrary, the use of insulin as well is associated with a lot of side effects, such as weight gain and hypoglycemic episodes that also affect patients' compliance and confidence in insulin therapy. So recently, there has been a lot of advancements in the adjunct therapies for type 1 diabetes to try to at least reduce the burden of insulin for patients with type 1 diabetes. Technological innovations such as CGMs and insulin pump therapies have enhanced glycemic control, but still not to the extent that we are happy about and not to the extent of achieving glycemic control in a large subset of patients. Ultra-rapid insulins and adjunct pharmacotherapies such as SGLT2 and GLP-1 receptor agonists possibly offer improved glucose management and reduced insulin requirements. So GLP-1 agonists are a class of medications that's actually used to treat type 2 diabetes and obesity. They work by activating the GLP-1 receptor, they slow gastric emptying, they inhibit the release of glucagon and stimulate insulin production. They also work by activating the GLP-1 receptor in the brain, leading to appetite suppression and body weight reduction, which may offset the weight gain that's associated with the insulin therapy. And due to the wide distribution of GLP-1 receptors, GLP-1 agonists also have additional cardioprotective and renoprotective effects. Now, based on this mechanism of action of GLP-1, it made sense to think about why not in type 1 diabetes. If it helps with type 2, why not in type 1? The only thing in this mechanism that would not be helpful in type 1 is the stimulation of insulin production. But otherwise, all of the benefits can help even patients with type 1 diabetes achieve the same results that we see in type 2s, if not better. So the use of GLP-1 in adults with type 1 diabetes has shown benefit in glycemic control and weight management, but less is known about the impact in pediatric population. A reason for that is that the FDA approval for GLP-1s only starts at the age of 12 and was only given recently. Another reason is because most doctors, when they have pediatrics with type 1 diabetes, will always focus on insulin, on how to take insulin, how to manage with insulin therapy alone, but less is known about the use of adjunct therapies in type 1 diabetes for kids. A recent study in 2023 conducted that the use of semaglutide, which is a GLP-1 agonists in patients who are overweight or obese, was effective in lowering body weight, BMI, and improving glycemic metrics in adults with type 1 diabetes. Another study in Saudi Arabia in 2024 showed a mean reduction of 0.8% of A1C, and a mean weight reduction of 2.4 kgs, and a total daily dose of insulin also reduced by 2.1 units within 3 months, but also that's another study in adults. We've searched a lot for any paper describing any effect of GLP-1 in type 1 diabetics in pediatrics. None were found. So we started our own study in Al Jalila Hospital. The aim of the study was to analyze the efficacy of GLP-1 agonists in pediatric patients with type 1 diabetes. The objectives were mainly to assess the glycemic control and the additional metabolic outcomes, such as changes in weight and the insulin requirements. It was a retrospective cohort study utilizing medical records. And the population were obese patients with diagnosis of type 1 diabetes who were prescribed GLP-1 agonists for diabetes management, and it was originally prescribed for them for obesity. It's not for type 1 diabetes, but it has shown a lot of significant effects on glycemic control. The sample size, we only had 22 patients, type 1 diabetics on GLP-1 agonists, and the data collection, we looked at baseline and follow-up hemoglobin A1C, BMI, time in range, hypoglycemia, and total daily dose before and after the use of GLP-1s. As we said, we had 22 obese children with type 1 diabetes, equal gender distribution, 50% males, 50% females. The mean age was 15.8, plus minus 1.6 years. All 22 were on semaglutide, which is the only FDA-approved GLP-1 for pediatrics with obesity. And the mean treatment duration was 11 months. Now, we'll start with the results with the main things that the children were prescribed GLP-1s for, which are the weight and the BMI. As you can see in the table here, the weight standard deviation has dropped by 0.5 standard deviations with a very significant p-value. BMI SDS also reduced by 0.52. Plus minus 0.12 with a very significant p-value as well. And as you can see in the graphs here, it's showing a significant improvement in both weight and BMI SDS, which is very expected for GLP-1s, whether they're type 1 diabetics or not. For the type 1 diabetes parameters, we focused mainly on two things, which are the hemoglobin A1C and the time in range. The hemoglobin A1C showed a reduction of 0.8%, with a mean time of 11 months, with a very significant p-value, and the time in range has also climbed up by 11.6% with a very significant p-value as well. And as you can see in the graphs depicting both the reduction in A1C and the increase in time in range in our patients. Now, one thing that was concerning to anyone who's using GLP-1 in type 1 diabetes is the effects of hypoglycemia, which is the main side effects that we're expecting when we're both on insulin and GLP-1 agonist. Surprisingly, though, there was a reduction in hypoglycemia. It's not a very statistically significant reduction, but at least there is absolutely no increase in hypoglycemia, and that is probably because of the reduction of the total daily dose of insulin. Now, those patients have shown a reduction of 23% in the bolus insulin, and a 14% reduction of the total daily dose of insulin. And this explains probably why the patients have less hypoglycemia, even with all of these positive effects of GLP-1s. Now, we had a couple of correlation tests. The first one is comparing the change in the BMI standard deviation with the change in A1C. And the second one is the change in BMI versus the change in time and range. And surprisingly, neither of those was correlated. So what does that mean? That means that it's not the weight loss or the reduction in BMI which is the reason for the improvement in A1C and time and range. It's the medication itself. If the patient has lost the weight in any other way, they are not statistically likely to achieve the same results. And this gives us a lot of indication that it's the medication itself that is helping those patients. And this happens even with the reduction of the total daily dose of insulin, which is also on its own reduces the side effects of weight gain and of hypoglycemia. So the results were actually amazing for the first cohort of pediatric children with GLP-1 and type 1 diabetes. So as we said, the use of GLP-1 was associated with a statistically significant reduction in A1C, a statistically significant improvement in time and range, and they are not associated with the weight loss. The GLP-1 agonist did not cause increase in hypoglycemia. So in conclusion, the medical treatment of type 1 diabetes is evolving to include more than just insulin. GLP-1 agonists are a valid treatment for obese children with type 1 diabetes. The use of GLP-1 was associated with an improved A1C, increased time and range, without increasing the incidence of hypoglycemia. And since the medical treatment is evolving, our role as well as physicians and as educators is evolving to include more than just education on insulin use, but to stay up to date and to stay aware of all the new adjunct therapies that can be used in type 1 diabetes, and to spread this awareness for our patients. Just one last line is that further larger scale studies are recommended to get more comprehensive information on GLP-1 agonists and other adjunct therapies. This is a retrospective study. A clinical trial on this would hopefully show a lot of more amazing conclusions. Thank you very much.
Thank you, Dr. Maiz. If you can just wait because you finish on time. Thank you very much for being on time. We'll take one question from the audience, if there is any. Any questions? Okay. So, yes, please.
Thank you, Dr. Marquez. It looks like a lot of hard work. I just noticed that you've mentioned you took patients from 2000 to 2025.
Yes.
But then you analyzed the last 11 months.
No, the data collection was the last 5 years of patients, but the mean treatment time was 11 months. Some of them were longer, some of them were shorter. The longest one who used the GLP-1 used it for 2 years, and the shortest one was 4 months, and the mean was 11 months. Yes.
Thank you.
Yeah, another question here.
Just I want to ask, there is any incident of DKA during that time?
Yes, in the 22 patients, we had 2 patients who had DKA. One of them is poorly compliant to insulin, as the mom confessed, and the other one was due to dehydration, so maybe one that we can link relatively to the medication, but out of 22, only 2 patients had DKA.
So you will have a chance to start the trial, let's say, and you will have your control and indicated one. You will have they should be within target, do you think, or we should have also?
I'm sorry, I think what I understood from your question is that you're asking if the patients who we are going to start on GLP-1s, you want them to be in target before starting?
Do you think this will be better?
Actually, no, the best responders were the ones who had a very high BMI. The response was best in the people whose hemoglobin A1C was very elevated in the beginning. Those whose A1C was already in the good range before starting, it didn't improve much in the A1C. And because we said that it's not the weight loss or the BMI reduction that is causing this improvement, it's the medication itself that controls the blood sugar.
Thank you.
Yeah.
Thank you very much for that. And just one follow-up question from the first, audience. When you mention about the significant reduction in HbA1c or BMI, what is the duration of this change? How long it took to
okay, so the thing is, our patients didn't have the GLP-1s on an equal duration. It's not a clinical trial. They weren't given this medication for diabetes to begin with. They were giving them for obesity. Usually the best, the duration that will tell us whether the patient will respond eventually or not is the first 3 months. So if the first 3 months they show a significant response, they continue. If they don't show a response, even if some of them even continued for 17 and 18 months, but because their initial response was not that good, they didn't have a good response moving forward as well. But most of the patients had a significant reduction in hemoglobin A1C, and that's initially in the first few months of the medication. Thing is, another thing that we have to keep in mind here, that again, this is a retrospective study. So some patients, even the duration itself is not the factor that will determine it. Some kids would stay on the 0.25 for 3 months. Some of them will climb up every month. So it's not the time itself, it's which dose they were on as well. And there's a lot more data that's into this, but I presented just a hint of the results.
Yeah, well done. Thank you very much.
Thank you so much. Thank you.
Thank you. Thanks. Now I'll hand over the mic to my colleague.
Thank you, Doctor. And now we will give the speech to Ms. Mariam Dabbous. She's a senior lecturer, dietitian, and diabetes educator in Al-Qasimi Women's and Children's Hospital. The floor is yours.
Assalamu alaikum. Good afternoon. So I am happy to be here today, and a special thank for Ms. Zainab. So today, inshallah, I will talk about our recent research paper, YouTube on carbohydrate counting for diabetes management, a quality and content analysis of Arabic videos. So I will talk briefly about background, study objective, methods, result, discussion, and conclusion. So we used a cross-sectional study design. It was conducted in October 2024, and all videos were collected by the YouTube platform. So the objective to assess the quality and reliability of Arabic language videos on carbohydrate counting. So again, why we choose only the YouTube platform? Because since 2005, YouTube has become a significant source of health-related videos. Also, prior studies have shown that YouTube content about nutrition is little bit low quality, and 8 out of 10 adults look up diet and health information online. So our concern was like, it's to provide accessible, interactive education, but it is unregulated. And from our specialty and dealing daily with pediatric patients in our clinic, so again, we are, as a dietitian, I'm educating them carbohydrate counting. So again, here it's came the reason why to choose carbohydrate counting. Just I wanted to see like, if it is really, if the mothers went through the Google to search about carbohydrate counting, they can get the right information or not. So again, carbohydrate counting, it is very important to adjusting the insulin doses, reducing the hypo and hyperglycemia, and very important skill to manage diabetes. So the methodology of this study, we have to choose like keywords. Me and the team, we chose already 3 keywords in Arabic, carbohydrate counting or carbohydrate counting. This different Arabic keywords, we enter it to the YouTube data tools, and we end up with 108 video. After implementing the screening and the inclusion and exclusion criteria, we end up with 53 video. So the video characteristics were collected like number of view, comments, like, or duration. And also we collect the speaker category, if it is dietitian or healthcare provider or influencer, as well the video type, if it's a blogger or cooking show, education, experience, or podcast. Finally, also, we collected the information source. If it is from healthcare organization, that means it is official source or unofficial source like layperson, or if it's non-profit or a profit. So to evaluate this video, 3 expert dietitians, and by using DISRN, a valid quality criteria tool for consumer health information on a treatment choice. This tool, it is 16 items. It's scaled 1 to 5. And again, we used for statistical analysis SPSS. So I will go through the key result because of the time. So it shows the highest percentage of the speakers. 47% it was for dietitian. And again, like the highest message type, it was for the educational, 84%. While the highest source information, it was like 51% for unofficial sources, which is layperson. It's not official or related to ministries or official sources. So the key findings, among all speakers category, dietitians shows the highest reliability scores and even a p-value less than 0.05. The educational message type has the highest percentage of high reliability among other message type. The dietitian had the highest percentage of high overall quality. It's in comparison to the others healthcare provider, including physicians or nurses that had the highest rate of low quality information. This one, it's highlighting the significant gap in nutrition competency. So in this schedule, or this table, it's like showing like some positive correlations or negative correlations, as I will summarize it here. So Longer's videos showed higher reliability and also information equality, as well as overall equality. While here in that previous table, there is negative correlations, like videos with more comments, number of comments, showed lower reliability and overall equality. So I am happy to say this is the first analysis of Arabic YouTube content on carbohydrate counting of diabetes for diabetes patients. So we have also other study strength. It's including Arabic content as well across 22 nations, and also use the strict methodology ensuring videos relevance. We have little of limitations as well, like due to small sample size, and also YouTube data changes over the time, so which may affect the result. So also finding do not reflect to non-Arabic videos. Only we were assessing only the Arabic videos, talking about carbohydrates. So our future research to expand more sample size and include videos in others' language. So the conclusion, most videos were moderate to high quality. Dietitians' highest score in the information equality and reliability. Educational videos scored the best in reliability. So Longer's videos tend to have higher quality. Audience engagement, like for example, number of comments or number of likes, did not always reflect content quality. So the key recommendation after this study, viewers should seek a content from certified professional and applied critical thinking. So also a recommendation to encourage Nutrition Society and health authorities like Ministry of Health or EHS to verify the video content, or create official YouTube channel that provide reliable health information to the patients. Alhamdulillah, it's a good news. This study was accepted for publication in October 2025 in the Journal of Egyptian Public Health Association. Very soon, within 2 weeks, it will be available online. And this is my references, and thank you.
Thank you, Mariam. Thank you, Mariam, for your topic. Any questions?
Thank you, Mariam, for a very interesting presentation. Just one question.
Yes.
Have you included in the inclusion criteria of which videos that you will evaluate, did you include the qualification of the content creator, or have you looked into that to find out who create these videos?
Yes, like according to, we analyze like the speakers category, whether it is dietitians or influencer or like dietitian or healthcare provider. It was like, we have to look to speakers category.
And did you find any correlation between, their qualification and
Yes,
the
sure.
content?
That's why the dietitian shows the highest reliability, quality informations, again, like comparing to other speakers.
Oh, okay. Yeah.
Yes.
Thank you very much,
Welcome.
Mariam. Thank you.
Welcome.
So, our last speaker for this evening is Miss Manar Abu Asba. She's a diabetes educator from Imperial College London, and today she will talk to us about effectiveness of technological advances in diabetes self-care and management as a systematic review. Thank you. The floor is yours.
Thank you, Doctora. And thank you all for being here at the last minute. Believe me, I can speak all the day about this study, but I will take you in a brief about what I did in terms of my master thesis. Please refrain from taking a picture because this is due for publish and avoiding any misinterruption. So effectiveness, technological advance in diabetes and self-care and management, it's a systematic review. So in background, diabetes is a chronic disease with long-term complication. It's well known. Traditional management relies on insulin and glucose monitoring, generally speaking. Technology improve accuracy, safety, and quality of life. So what was the aim and objective? Assess the effectiveness and safety of advanced diabetes technology. And since morning, we've been including all these type of technology, and you are well aware of type of technology being used in treatment of diabetes. But to be more specific, we will go through details which type of technology being used at this review. So the objective was to evaluate CGM, closed loop system, insulin pump, and assessing any AI tools. So examine the effective on glycemic control and well-being. So if you all well aware, systemic review is a review of the review. So there been a study being done, and you catch up, pull this search, and you do your own review, and based on that you analyze your finding. So the review was done. Initially, which database being used? Midline, IMPAS, Scopus, Web of Science, and I specify the years because it's plenty actually, from 2010 up to 2023. So I focus on randomized control trial, observation study, mainly for type 1 and type 2 diabetes. So initial phase using Prisma chart, it's a template. For those who are not aware what is Prisma chart, it's a template being used to summarize all your findings. So from start up to the end. So while you are doing data search, you identify. So you are catching, pulling, chipping, doing your own search. So total number of study being identified through different database. So it's in total was midline 485. Don't be panic because all this will be filtered at the end. IMPAS 180, Web of Science 2,224, and Scopus 4,738. So the duplicate, do you believe it? 2,851, it's been removed. So based on that, you do screening now. So potentially relevant study being selected, which is 4,746, and out of this study not meeting the inclusion criteria also being extracted. So then you go and squeeze more your finding to go for eligibility based on your finding. So full text being assessed for inclusion criteria about 725, and at the end we end up no reliable study. There is no study meet the criteria about 619 study. So in conclusion, you find out 63 study. So we start with very huge number, but at the end you squeeze, and we end up with 63 study. So in total, CGM 35, out of these 28 randomized, 14 clinical trial, and 3 observation study. So closed loop system, taking into account my finding, and based on this study, we will subcategorize the intervention and finding. So closed loop system, only 10 study, out of these 7 randomized and 3 observation, and insulin pump use was 13 and 8 randomized control study. AI tools, only 5 being assessed, 5 study. So it's very important to squeeze your finding and identify your inclusion criteria. So to be more specific, it's randomized control trial, observation study, using only CGM, closing loop, insulin pump, or any AI implanted tool. So we exclude review, case report, non-human study, and gestational diabetes. As I mentioned, I end up with 63 study, and it's been done through different 12 countries, majority being US, UK, and Canada. Participants were different age group between children, elderly, as I mentioned, type 1 and type 2 diabetes. So the key technology being used, CGM, continuous glucose monitoring, closed loop, which is automated insulin delivery, insulin pump, improved dosing precision, and AI, which is a predictive and personalized management. So what was the outcome? So the outcome was being identified based on the finding. CGM reduced hypoglycemia and HbA1c, closed loop system improved time in range, and some adherence in challenging youth. And in terms of pump and AI tools, pump integrated with CGM improve glycemic and reduce any hypoglycemia event, it's been missed. AI tools optimize adherence, dose adjustment, and weight management. In the impact of quality, higher satisfaction and reduced stress burden in different age group, better sleep and anxiety, and encourage engagement and independency. Future research, definitely. We need to have more research, more evidence-based to support technology in diabetes care. Long-term data and the cost and the access to this device is very barrier, and emphasizes on AI being used and personalized decision-making. In conclusion, absolutely, technology enhance control, safety, and improve outcome, promote patient-centered care, and accessibility for all these devices. Thank you. Ready for question.
Yeah, thank you very much, Manar, for that. We'll take a question from the stage here, and then we'll ask the audience. Yeah.
What are the sample size for your study?
Yeah, let me recall it. Yeah, it's in terms to assess the intervention, it's, I say the different age group, different type of diabetes, mainly type 1 and type 2. And the sample size were being selected between 12 participants, the minimum sample, and the highest sample was out of 700. Yeah, so it's varied between very slow to a huge sample.
Any other questions?
Thank you. It is important study, and I would like to ask, how do you validate your study? Are you the only author, the principal author, or do you have co-authors who helped you in reviewing that paper? Because
Yes, thank you. That's very valuable question, actually. To avoid risk of bias, actually, there will be a 2 reviewer, and some study we include a 3rd reviewer. So we rely on web page, we rely on some website, so we get the access to review, and if bias being identified by these 2 reviewer, 3rd reviewer will be included. Yeah.
Yeah, thanks, Manar. You know, you said that in exclusion criteria.
Yes.
Review. You exclude reviews. Could you elaborate?
Yeah, I mean, exclusion, personal review, personal opinion. So it's not a randomized or observation study.
Narrative review?
Yes.
Systematic
yes,
as well?
Yes.
Systematic review?
It's excluded.
Okay, it's excluded.
It's excluded. It's out of exclusion criteria, not inclusion.
Yeah, and in terms of your results, you put it in a very clear way.
Yeah.
But it's kind of some percentages or some kind of numbers is missing from there. Do you have anything to share with us from the top of your head?
Well, it's because it's made the risk assessment, to assess this study, you use risk assessment tool, and you equalize the data. So it's not being assessed as a figure or number, it's been as a thesis and narrative review. It's an observation and opinion, rather than numbers and figures.
So what is the home taken message from your review?
Well, it's, first of all, don't do this study again because it's a huge study. So if you want to do a systematic in terms of technology, okay, I really find a lot of gap and barrier. So you need to be more specific. You need to specify your search. So as I start with big, huge number, I found myself diving in the sea. So, and I end up with 63. So initially, please, if you want to do this study, be specific which type of technology you need to assess. So as I mentioned, it's a huge, it's all about technology. So if you are started, you want to assess everything around you. Technology is not specific to CGM, BOM, AI, or any tools. So once I start, I could not pause actually. But if I need to repeat it and I do it again in the future, I need to be more precise, more specific with the type of technology I can assess.
Yeah, thank you very much for highlighting that, because, you know, from 7,000 articles to end up with something,
yes, indeed.
It's a big question mark.
Yes.
Yeah, thank you very much, Mona, for that.
Thank you. Thank you.
So we are waiting for the judges to calculate the scores and to announce the winners with the first, second, and third places. So stay tuned.
Thank you very much for everyone, and I have to say that for all the presenters, I think they did a great job in a very short time. They present their proposal and how they execute the project. So well done for everyone. So for us, yeah, 3 of you are the winners, but as you know, we always need to do some sort of ranking, and here is the announcement. So we'll start with the first place. Congratulations, Dr. Muiz. You came as the first winner. And I have to say that we don't have any conflict of interest to announce. Me and my co-chair, we are not part of any of these 3 researchers. So well done, Muiz. So, as we all know, whatever we are celebrating today is based on the originality of the research, the research design and methodology about the future direction and how the author is able to publish what they observed so far. So the second place will go to Miss Miriam Abbas. Congratulations, Miriam. And the third, last not least, very well done, Job Manar. The third place, it will go for Miss Manar from Imperial College.
We reach the end of the day. I would like to extend my heartfelt thanks to everyone who contributed in today's success, especially you who stayed late with us. We truly appreciate your energy and enthusiasm. See you tomorrow, and I will leave you with this nice video.